a stalwart group of people here in Harrisburg and a number of people online. I want to welcome you. My name is Ken Thompson. I'm the medical advisor for the Psychiatric Leadership Council, and I'm here to frame a little bit about what we're going to talk about this morning, and to introduce a couple of speakers who I am extraordinarily excited to do that. To start, though, we need to do the usual housekeeping stuff. So the housekeeping stuff is for those of you who are here. You can stand up and go whenever you need to. There is a bathroom to the right. For those of you who are online, presumably you know where your bathroom is. Just don't take us with you when you go into the bathroom. And I would point out that if you would like to participate in the chat and have a question, Lucy, you're monitoring the chat. You're monitoring the chat, Kate. Great. We will be able to take questions from people who are online. You who are here, all you need to do at the point that we're asking for questions is to raise your hand. And the other thing is that it's possible to apply for continuing education and CME benefits if you send a message to Lucy, which I believe is on the screen. So with that, we are here to talk about the past, present, and future of community mental health. And I'm going to just take a very brief moment to point out a couple of things that led us to talk about this today. The first is that it is just over 60 years since the Community Mental Health Act was passed as part of the New Frontier legislation sponsored under the administration of John F. Kennedy. Folks may realize and know that now it would be the first time that a president has actually talked to Congress about mental health was Kennedy's talk to the combined House and Senate in February of 1963. Unfortunately, within 3 weeks of the signing of the Community Mental Health Act, which Kennedy himself had really taken a personal interest in, he was murdered. So we've had always a little bit of a checkered history, or a history of challenge, but now we are 60 years on, and it's probably time to think a little bit about where we've gotten to and where we've come from. In addition to that, 4 years ago, almost exactly this time, we had a meeting with the governor, with Governor Wolf. At that point, we were really feeling ready to sort of launch an entire initiative around what really good community psychiatry and community mental health would look like. We all elbow bumped with the governor, and we're wondering what this COVID thing might do to our world. And within a week and a half, the shutdown had come. And we started the process of figuring out how to deal with that and the challenges that has brought to us. That, I think, really got us to the point where we are today. What we've realized is that we are in, sometimes people talk about it as a mental health crisis. I continually refer to it as a mental health emergency, because I think that a crisis somehow doesn't sound as urgent as an emergency. And I think we have an emergency going on. This whole of society is challenged right now. And the task that we have, I think, at this moment is to figure out how we can best attend to the multiplicity of needs and challenges that the American people, and the people of Pennsylvania in particular, for this group, are facing. And it is an opportunity today to start to think about what that means. How do we manage the incredible needs and demands that people have for help? How do we make sure, if we can, that we help people not have troubles in the first place? What can we do to do more mental health promotion, and prevention? And I asked that question in part because I just had a conversation with folks from Ohio, where I was speaking to the head of the Office of Prevention in the Department of Mental Health for the state of Ohio. And I thought, it's funny, I've never had a conversation in the state of Pennsylvania with anybody who was the head of the Office of Prevention. And I suddenly thought maybe there's some place that we can go in terms of helping the state think about some of the work that it does. So today we're going to think about the past. We're going to consider where we are at the present, and we are going to look at the future and imagine what the possibilities are. It isn't so much to fix what is wrong as it is to find what the possibilities for what's really good and to move those things forward. Now, it is my great honor to introduce our keynote speaker, Estelle Richman. Estelle Richman is, for me, a personal hero. I have to tell you, I'm going to talk a little bit about her career in just a second, but just so you know, this is actually very personal for me because Estelle is one of the two founders of the Pennsylvania Psychiatric Leadership Council with David Dinich. And I had a small, I'm not even sure what role it is, if it was really a role, but I had a small role in this, in that one time, it's quite a while ago, Estelle was in Pittsburgh talking at the University of Pittsburgh about the creation of Community Behavioral Health, a managed care organization that she helped put together and led in Philadelphia, which was a model then for what managed care could actually do that was good. She came to Pittsburgh to talk about that, and I was asked to, after her talk, to drive her to the airport. And Estelle didn't know me from anything, and I had the opportunity to drive her to the airport. This is a lesson, by the way, if you ever get an opportunity to drive somebody to the airport, take it up. Because what I spent the time doing was just telling Estelle a little bit about the challenges of trying to teach and act as a community psychiatrist within the university systems that we had, that we were sort of being excluded out of any possibilities. And I left her off at the airport, and she got back to Philadelphia. And the next thing I hear is from David and Estelle that they are in the process of creating what became the Pennsylvania Psychiatric Leadership Council and the Centers of Excellence with fellowships for people to go on into public community service, and that this would be part of the academic mission because there would be state monies that Estelle figured out how to make possible. So without that, none of us would be here, and the opportunities that I think we present to the state wouldn't be here. And I just think it's an extraordinarily, it was a very, very lucky thing for me to be part of this. And I'm just glad that Estelle and David were able to make that happen. But that's not the only time Estelle stepped into my life. There are two other times, and I'm going to count today too, as a third. In probably 2005, I got a phone call. I'm trying to remember who it was from. Well, it'll come to me, but I got a phone call asking me to consider helping to close Harrisburg State Hospital. And there was one significant line in the request, and that was, Estelle Richman would really like it if you would be willing to take this task on. And then the person, whoever it was, said, can you possibly imagine saying no to Estelle? And I didn't, and that led to another extraordinary moment in my own career. So thank you for that, Estelle, as well. And then the other thing I'll just say is that years later, when I was working for SAMHSA, and SAMHSA decided that it didn't actually want to have any psychiatrists in it, and I was summarily relieved of my job. The person who I called to just go out to dinner with in Washington was Estelle. I don't know if you remember this, Estelle, but Estelle took me out, and at the end of the whole thing, I felt, okay, this is just the way it works, and I can manage this. It's going to be okay. So, and now I talked to Estelle about what she's going to talk about today, and I think all of you are going to find this to be quite profound. And I think it's going to be meaningful for what we think about into the future. So I'm seeing as another intercession by Estelle in my career, but now in all of your careers. Estelle Richman is a native of, born in North Carolina, raised in Virginia, ended up in Cleveland for a while, and then decided to come east and came to Philadelphia. Estelle, did you get a degree in social work, or what was the degree that you had? Psychology. Okay, so psychologist. She came to Philadelphia and was instrumental, as I said, in a number of things, including the creation of community behavioral health. She then went on to become the secretary for, at the time it was public welfare, and then it became human services. And then in a place where she could have interceded in my career, but she decided not to, she decided that rather than go to SAMHSA, she was going to go to HUD. And she went to HUD and spent 10 years or almost 10 years at HUD, really reshaping and that organization as the chief operating officer and acting director for a period of time. And then I think she decided that she was going to stop for a little while and travel around the world. And I have had the opportunity periodically to be about a week behind Estelle in various kinds of places. I've never actually been able to catch up with her. Her last place of adventure was in Antarctica. So maybe one day I'll be able to get there. But she has come out of retirement and she's taking on the issue of gun violence, particularly in Philadelphia. And I think some of what she's going to say is going to reflect on that. She's a recipient of numerous awards and honorary doctorates, and just as an extraordinary person who's lived a life of commitment and service, and I think also innovation, and for me, inspiration, and I think you'll find the same. Estelle, please join us.
Thank you, Ken, for that very kind introduction. Most of all, what it means is I'm old. When you have all of those things on a resume, it means you've just been around for a long time. And part of that is what we're going to talk about a little bit today. But I'm really pleased to talk to this group, as an aging leader, and I'm one of those that sort of proud of my age. Although in essence, in my family, I'm probably young. My grandmother lived to be 109. So I don't know whether I'm going to hit that point or not. But as an aging leader, it is really quite heartwarming to see initiatives that you started many, many years ago continue to not only to exist, but to continue to thrive. And hopefully we'll continue to do that. Training from that point on, from when that conversation, to the airport, in fact, that did become a little bit of a lottery. Mark Turner would find out who would like to drive me to the airport. And since I spent a lot of time in Pittsburgh and Allegheny County, I always almost had someone different driving me each time. And it's about a 45-minute drive. So someone had my undivided attention for that period of time. But the training and supporting of young psychiatrists to remain in our state just seems so important. Between our three locations of medical schools, keeping our psychiatrists here and attracting them to stay in the public sector was just critically important, and we had to figure out how to do that. And again, I really believe it continues to be critical. It continues to be important, and I really want to thank PPLC and all of the young psychiatrists for hanging in there. And letting your passion and your contributions continue to support people in our state. I also want to thank you not only for inviting me to be able to celebrate this, but also to walk down a little bit of memory lane in recognition of the 60th anniversary of the Community Mental Health Act. Again, as old, I actually remember the signing of it with President Kennedy, just because it was such an important piece. And at that point, while I was still in college, but it really was a landmark decision and act he did. He actually signed it on October 31st, 1963. And you do the little bit of math, it was just 3 weeks before he was assassinated. And the goal of that was to really establish a system of community-based care instead of institutional care across the U.S. for people with mental illness. The announcement really helped deliver on that promise of strengthening the care available in the community. Incidentally, Pennsylvania enacted their state law, the Mental Health Procedures Act, about 3 years later in 1966. Although the vision and the intent of the Community Mental Health Act in both laws was admirable and was something that we needed, neither were funded at a level that they could actually create the community-based system we wanted. That should sound familiar. We still struggle with that level of funding, but the vision was there, so it did get off the ground. We just didn't quite have the political influence at that point in time to be able to get the funding into it. In the ensuing 60 years, we've seen tremendous growth in our community systems, yet we really still have to recognize how far we have to go to reach a truly equitable system of supports for all. Actually, in this talk, I want to make 3 major points and leave time for questions and for you to challenge me on any of my thoughts. By the way, one of the things that comes with age is a boldness to be opinionated and outspoken. And I have no problem with people challenging or saying, that's crazy. Mainly because I will then disappear into the dust, hopefully, and you will get to run the system. First, I want to talk about the state of the system when I arrived in Pennsylvania in 1988. Next, what I call the managed care years from about 1994-95 to 2010. And the start of the discussion around the social determinants of health. Finally, the turbulence of the last 5 years and a peek at the future. Finally, if we have time, I want to talk a little bit and share some ideas of what I've learned about systems change in leadership in the past 50 years. When I arrived in Pennsylvania, I was, the job I was asked to take was director of the Southeast area as the Southeast area director. It was basically a new position that combined oversight of the state hospital with community services. I was working for Secretary John White and Deputy Secretary Marty Nisley, who also came from Ohio, and that's how I got asked to come. My primary responsibility at that point was closing Philadelphia State Hospital, fondly called Byberry. The movie The Snake Pit accurately described the environment. So if you haven't seen that movie, go see it. I would call it a horror film, but it really is a pretty accurate description of what the environment for Philadelphia State Hospital was like at that point in time. It was a traditional institutional environment with people sitting and pacing and doing very little. The decision had been made that this closure would essentially be movement of people from the hospital to the community, not a trans-institutional transfer that had usually happened in most parts of the country. No one really believed we could pull this off and move most people to the community with supports. However, the governor had said in his speech to close the hospital that the money would follow the clients. And we took him at his word for that. However, with the help of an incredible team of advocates and a couple of thank you, Joe Rogers, Mary Hurdick, Mike Viguer, Steve Gold, Eileen Shane, who were 2 of the lawyers, and Loretta Ferry. We actually pulled it off. We really did move the majority of people to the community. We had a few that went to Norristown that we kept in a separate unit and ultimately were able to move everybody out. The hospital closed in June of 1990. And it was actually this closure that I believe set the standard for other closures in several ways. First, the funds supporting the hospital moved to the community. to support clients not only being discharged, but we created a class called the diversion. And these were people who would have gone to the state hospital. And that's probably part that didn't continue in legacy, and that's really too bad. But at that point in time, $40 million was supporting the state hospital. And the governor, with a little pressure, actually moved $40 million in lump sum to the city. You can do a lot with $40 million. And we really were able to create a pretty significant continuum of care. We also created a lot of new categorical services, extended acute hospitals, a long-term residential services. I think there were 5 of them at the time, LTSRs. We had specialized residential services for those with mental illness and addictions. Consumers and families became a part of the evaluation system and to determine whether the system was responsive to needs and requests. And thank you to all who are still involved with the consumer satisfaction teams. That was one of the big things that came out of it. And a big thank you to Loretta Ferry, who created that and led it for so many years. We created the community treatment teams, the CTTs. It's a highly focused intensive case management model that was the first of its kind in Pennsylvania also, where we had a team of 7 working with 10 to 12 clients. So our ratios were incredibly small, and we had a psychiatrist with each of our units. That too was thanks to the Philadelphia psychiatric community, who really leaned into this at an incredible level. And thank you goes to Sandy Vasco, who in many years worked both for the state and the city to actually make this and put it together. We had a wide array of residential supports. As you know, the key so often to people living in the community is having the residential programs and supports that actually do what they say they're going to do. And we had the funding to really respond to almost everything that people said they needed. So there were supported programs for clients with addictions and mental illness, supported housing for clients with developmental disabilities and mental illness, residential programs for clients that had significant medical needs. My comment at the time was we had one of everything and not enough of anything. But there were a lot of independent programs that really began to work and set a model for us. Another support at the time that helped us pull all of this together was a major RWJ, Robert Wood Johnson grant, which the city had received in 1986, just before I arrived in the city. But Ohio also had some RWJ grants from the same source. So we sort of knew what they were about and how they could help. But the primary focal point was they gave us a solid support for our community treatment teams. They gave us 100 vouchers from HUD to help us create a financial stream for housing. They funded an integrated IT system that would be the base of our IT system as we went into managed care. They funded a single mental health authority, which is PMHCC, was created out of the RWJ grant about the same time. And they laid all of the groundwork ultimately for managed care, which gave the basis. It was whenever I talk about CBH, I go back to CBH couldn't have happened without the closure. We were able from the closure to have the funds to fund ourselves in the creation and startup of CBH, which made all the difference. So overall, the closure was quite successful. It changed the landscape of Philadelphia, and it laid all of the groundwork we needed to go to the next level. It was period from 1990 to probably 1994. We probably began to just stabilize the system, tried to make sure the residential programs continued to work towards the development of CBH. CBH actually, and some people who were around at that time know, took us about 7 years to really bring together. We actually did the incorporation of it as a private nonprofit probably in 1992. And as you know, it didn't go live to 1997. So we had a fair amount of development time. And prior to 1992, Dr. Richard Searles had done a lot of research on what the financing part of managed care would do to a county mental health system. So we had a lot to work with at that point in time. People sort of said, well, how did you do it? Well, there were people before me and a lot of support during that time to be able to understand actuarial care, how to be able to understand the finance, and how to work with managed care companies. I call some of that period pre-health choices. Philadelphia had been the location of what the state called at that point Health Pass. Health Pass was a mandatory managed care system for West and Southwest Philadelphia, just that area. It had started in 1986 and continued up to the point of health choices. It stayed, the main point that they were trying to make, it saved dollars. It saved big state dollars. However, as it was assessed in those last years, it showed no significant impact on access or quality, which forced the state to be able to look at it to figure out how do we begin to get the other factors in. Behavioral health services were very limited in Health Pass. Essentially, they had no relationship. The Health Pass provider had no relationship with the county mental health services. They paid for some inpatient stays, but essentially what they wanted, what they waited for were the patients to go to the state hospital, so it wouldn't be on their dime. So they really at that point manipulated mental health in a fairly significant way. There was also non-mandatory managed care around. Several of the plans, the big plans, Independence Blue Cross, opted in, but they really had little impact overall in the system. The membership was pretty low. They contracted out behavioral health services to the for-profit plans. And again, there was little relationship between the county providers and the managed care companies. But the critical piece, which I think we all live with today, is that those, both Health Pass, the non-mandatory managed care centers, saw behavioral health as a profit center. So they really said, okay, we'll do mental health, but that'll be our profit. And we will pay a little bit for it, but this is not this is not what we really do, and we aren't going there. Well, that stuck with all of us, you know, so that conversation led to the ongoing conversation about carve in, carve out. And we were very afraid in those days that if we carved it in, the managed care companies, the broad companies would use it as a profit center, as opposed to if we could carve it out and we control our own future. I'm an integrated health person. So, you know, for a while, I tried to figure out how we could do it in. There was just no way at that day and time, which was, what, 27 years ago, somewhere in that range, that we were going to change the mentality enough to make a carve-in work. So we really did do a carve-out, but under those circumstances. In planning for health choices, DPW set some pretty clear goals, and I think they were very clear, particularly on the physical health side. They wanted all members to get access to a full array of services. They carved no populations out. They really had very good ideas and good grasp of how to measure outcomes. They looked at hospitalization, they looked at readmits, they looked at maternity health care, chronic illness. But they did that all in the physical health side. They really didn't have a clear vision of what kinds of outcomes they wanted on the behavioral side. So they went for the basic ones: hospitalizations, the length of stay, and the number of people that were referred to the state mental hospitals. But they really hadn't dug down very deep in that. But there were many people who made this plan work. And overall, by any standard, Health Choices in Pennsylvania has been successful. But I would be remiss if I didn't at least say thank you to Feather Houston, who was the secretary at that point in time, Charles Curry, who really put much of the behavioral health piece together. And a lot of it goes to Charlie, because he fought just about for everything we got in the overall plan. And Sherry Knowlton, who was the Deputy Secretary of the Office of Medical Assistance Programs, because she also worked with it. And she, in reality, all of the pieces of Health Choices had to fit within our Medicaid plan. And the major decisions they had to make at this point in time really was the carve in, carve out, and how much of it got carved in, how much of it was in. And they really decided in the end, this was all in. There were no exclusions, everybody was in. And what this did was totally change the role of the county mental health system. As Charlie was prone to say, we had a right of first opportunity, not the right of first refusal. So if counties wanted to be in, that was their choice and their right to choose to be in. We also created, we knew the goal, part of the goal of managed care rather than better, good care, was also we knew that there would be some savings. If you manage well, if you really use your dollars well, you have a pot that DPW gives you, and you have the services you provide, and in the world of economics, that's profit in between. For us, it was reinvestment dollars. So we created the new term of county reinvestment dollars. And that worked well. That became an incentive for all of us to try to figure out how you provide good services, spend your money well, but at the same time, if you can create enough community programs to keep people out of your most expensive service, which is inpatient services, then you have dollars saved to create more. And that was the concept that we all worked with at that much. And that stimulated all sorts of creativities, I think, across the state, and trying to find that right balance in reinvestment in terms of how do you support your community programs, how do you bring in new creative programs, and how do you make sure that people who are receiving services now, those that are using the services, get all they need. One of the outcomes we were looking for was an impact on the state mental hospitals. The goal was to reduce reliance on state mental hospitals, and that would reduce state cost. At the same period of time, let me jump back to the feds for a second. This was a period of time in which the U.S. Supreme Court issued the landmark decision on Olmstead. And Olmstead essentially found that unjustified segregation of people with disabilities was a form of unlawful discrimination of ADA. While in DC at HUD, I actually spent a lot of time on Olmstead because we were trying to figure out how we use Olmstead law to open up housing. And I think in a variety of ways, the Obama administration was able to do that, but that's a whole nother speech. For health choices, as you all know, it started in Philadelphia in the Southeast in 1997. It moved to Allegheny County in the Southwest in 1999, and Lehigh Cap area in 2000 and surrounding area in 2001, with the goal of going statewide. Unfortunately, the Ridge-Strikert administration hit a financial roadblock after Lehigh Cap, and expansion ended. But in 2003, when the Rendell administration came into Harrisburg, our goal was to continue to expand health choices, both on the physical and behavioral health statewide. And by 2007, all counties were a part of health choices. It was important to us that this happened because we wanted each county to envision how they wanted to use managed care, to re-envision how they provided services in their county. And because of that, and because of the right of first opportunity, we have, as you know now, lots of different models in Pennsylvania in terms of how counties sought to do it. Philadelphia had a all-inclusive model with CBH. Allegheny County went with CCBH, which accidentally now I think is one of the strongest in the country. I think what they've been able to do with that and looking at a modified way of really integrating services is really a model to continue to pull apart and understand. But most of all, we wanted health choices to respond to local needs. We wanted to reflect what that county and those joiners wanted to see for themselves. We wanted a continued focus on community-based treatment and to keep as many people as possible in the community with supports, including children and youth, and not have people in state hospitals, residential treatment, or away from home. And we felt that this was all possible if we used our funds in a way to promote that, and that we had the incentive for the county strong enough that they could see a way to do it. Again, many thanks, because in my administration, we couldn't have happened, wouldn't have successfully happened without Joan Ernie and her team. And I know Joan was here last night, but Joan was my deputy for mental health and substance abuse. And without Joan and her staff, very focused on this and very creative in how we did the funding, we were able to find the right mix of supporting counties, the right mix of listening to families and people who use our services, and finding the right mix for reinvestment. And while, as I look back at those years, I think I complained frequently about how much of a budget struggle it was. I think every single year, and those of you who lived through it know that the Rendell administration, I think, had 3 years that we had an exceptionally long period of time before the budget was passed. We would, and Ed Rendell would say, we're not signing this until we get what we want. And we were working with a legislature at the time that I would not say was human services slanted. So we fought for everything we had. And I was known to say during my many years was that it felt more like I was a secretary of budget rather than a secretary of mental health and policy. But even with that kind of scenario, and we were really good in the end of what we call revenue maximization. Some people call them schemes, but they were all legal. But we really looked at creative ways to generate revenue. It was also during this period that PPLC came into existence, and thanks to Dave Denich and the consulting support of Jeanette Harrison out of Ohio, we realized really early on that if we were going to develop and be successful in the community, we had needed more psychiatrists. And we needed them to choose to work in the community setting, and we needed them to choose to work with people with severe and persistent mental illness. We had a close working relationship with Philadelphia Housing Finance Agency to adopt policies to help with more supported housing. We needed more break in there, and we needed more support in capital funds. We also started any number of initiatives with the criminal justice system, both for children and adults. And to adapt policies that would keep people with mental illness out of jails. We also at that point started PeopleStat within the department to be able to use data. I'm a data person, and we wanted to use the data to be able to see if we were on the right track. Because in my belief is good data drives policy and practice. We identified what I thought were high need clients and defined it high need clients if they worked with more than 2 offices. In other words, OMHSAS and OCYF, OMHSAS and OMAP, because we had to be able to identify those high need clients and to get the offices to work together. As much as I try to keep the silos from being silos, there's a natural pull to people to go back to their own office. And this was a counterforce to push them together. I don't know whether all those things are still continuing to happen, but if they aren't, they need to. And we spent a lot of discussions on revenue maximization projects aimed at increasing federal dollars and giving us flexibility. And although there's always a conversation that the feds are going to cap Medicaid, my assumption was they were going to talk about it, but they never would do it, and they haven't. So the goal should be always revenue maximization at some level through the use of waivers, state plan amendments. There are just a lot of ways to be able to generate more federal dollars, and we need to continue to drive that. There were a lot of, during that period of time, we closed 3 state hospitals, 2 mental retardation centers, and in all of those, the focus was moving residents to small community residences. It was always an effort to be able to keep people community-based and to decrease the state hospital and retardation center population, which happened. The key, though, was always trying to force the legislature to move all the funds to the counties and not to the general fund. And in general, I think we did okay. We didn't do as well as I think that's the deal that Philadelphia got in the beginning, but I think Joan and I and the mayors on the governor's budget office actually did fairly good. I give us probably a C+ on moving monies to the community and not to the general fund. You continue focus on removing restraints and seclusion from residential programs in state hospitals. We were pretty successful on that. We continue to, we developed the peer support system and got Medicaid reimbursement for it. We developed a system and funding for autism spectrum and basically began to recognize the in-between land of people on the spectrum. I'm sure I've forgotten programs that were created that time, but the key was to be present, to be able to have a lot of communication and to get as much money of the Medicaid system into the general system so we could maintain our community-based system. When the Rendell administration left, the new administration appointed a leader that believed there was rampant waste and set about to find it. The problem was he took the money out of the system, hoping to replace it with what he called waste. As all of you should know, there's very little waste in this system. I will never say there's zero, but there wasn't a lot to warrant the kind of money that came out of the system. So that the system had a major setback for those 4 years. Well, for the first 18 months or so, because, and I say thank you to Bev McElrath, because she stabilized the system and put vision back in it. And it took her, the remainder of her administration, to try to do as much remedy back into the system as she could. And while those years were a lot of years of change, they were also about stabilization. It really was a little quiet period between when the Rendell administration left and we had a little chaos, and the Affordable Care Act. And she picked up the very beginning of the Affordable Care Act and began to put supports in place that would get us through that. The budget challenges had always ebbed and flowed, and the country in general struggled. The Affordable Care Act passed, but the challenge there was we brought people into the system, thousands of them, but we didn't expand the system. So the system quickly became overwhelmed by new clients, not a new lot of expansion dollars. And I called it, we entered the age of political healthcare. Healthcare became a sort of a political ball back and forth, not understanding the threat to our community system, a threat to our community hospitals, and a threat to the welfare and the being of our clients. One of the good things that did come out is that we began to hear the terminology of social determinants of health much more frequently, which was a realization that it wasn't about treatment 100%. That's a major part, but it really is about housing. It's about food. It's about community resources. It's about all the things that make it possible for us to live. While treatment is very definitely part of that, treatment without housing, it doesn't work. People who are homeless are not people who are okay. People who are struggling every day for food. So we really needed to understand the social determinants of health, but it wasn't understanding it. It was having Medicaid fund them. And I'm going to jump momentarily to the future. Medicaid is now beginning to fund temporary housing, where Medicaid is now funding food. It often takes a plan amendment or it takes a waiver. And I would share with you, I believe the administration we have in Washington right now will approve just about anything a state puts in front of them if they can show that it is for the welfare of the people. And we need to take advantage of that. I wish we could predict the outcome of the fall election, but unless anyone has a really good magic 8-ball, we can't do that yet. So we need to take advantage of what we know and have now and be able to really see it. In 2016, when the Wolf administration took over and really implemented the Affordable Care Act, we really began to realize how much the landscape is changing. And we really began to realize how many people had been surviving, but not with treatment, and how vast that landscape had changed over the years. And this led us to the pandemic. And we were about to face what many of us have called the perfect storm. The pandemic sent everybody home, as Ken said, but left the most vulnerable in precarious situations. People who are homeless, people in poverty who needed to work, people living in overcrowded conditions, and significant food insecurity was one of that perfect storm. The second was the civil unrest across the country. As the country was forced to face with long-term racial disparities, manifesting itself in so many different ways. But it created the second part of what was the perfect storm. And the third one is a continual and starting then, but continuing explosion of gun violence in our larger cities. And that continues. And this continual exposure of our children and youth to trauma, often untreated. And that brings us to today. The pandemic is over, but the issues it exposed are still here. And as we stop and look at our past, this is really a time to learn and a time to assess where we are and where we're going in the future. Just a couple of ideas around this. We still deal with the social determinants of health, and we need to continue to expand them and continue to push Medicaid to fund more of them. Housing is still essential for stability. We need meaningful activities during the day. And as someone who failed retirement, I still believe people my age should be retired. I'm going to try it again. One of these days I'll be successful. We need to help people develop social networks, and we also need to understand integrated healthcare, and we need to bring the word prevention into mental health. In the opiate epidemic, addictions are not new. Co-occurring disorders are not new. Self-medicating is not new, but we now need more tools, more funds, and more awareness. We need to truly understand what medication-assisted treatment means and implement it. We need to reduce more barriers to treatment. We need to make sure that we're doing more warm and / hot handoffs after overdose and after detox. And we need to continue to work with the state to identify unhelpful regulations and practices. Probably my newest passion, other than the gun violence activities, is integrated healthcare. We have to get better at integrating between physical and behavioral health. And while family physicians and internists often prescribe behavioral medications and do other informal housing, we need psychiatrists now to take blood pressures perhaps, or understand the impact of lead, or understand the physical disabilities of many of our clients. We also need to look at early intervention. I would say that we need much more focus on very young children between 0 and 5, particularly those between 0 and 3. That's prevention. Listening to parents without looking to diagnose. We have 2 states now, both California and Massachusetts, who've received waivers for prevention in young children. And this means they can provide service without a diagnosis. And we need to get much more into being able to provide service without diagnosis, and I wouldn't limit it to children. You know, no one would think you have to develop pneumonia before you get a shot to avoid it. You shouldn't have to have a diagnosis before you get a treatment or you are able to have an assessment. I read your paper. I have to say, I thought I would glance at it. I actually read it twice because it was that good. I think it nails the issues. It has recommendations and a plan. But I'm going to just mention again a couple of points on it that I think are real critical. We now need to assess where we are in our political landscape and how it differs from 60 years ago when the Mental Health Procedures Act was written. I firmly believe anything that's 25 years and older needs to be looked at. We don't necessarily need to change it, but we need to review it to see if it's in a relationship to today's world. It's hard to imagine that something written 60 years ago is relevant for today. It doesn't need massive change, but it needs a massive look. And we need to decide what fits and what doesn't fit. we need to figure out the world, 60 years ago, we were just beginning downsizing of institutions, removing slowly to community-based services. Today's different. Our number of people in state institutions is significantly down. We have a different world even since the pandemic than we had before. How do our laws reflect that? And I'll give you a hint. My thought is trauma. I see us with two very distinct populations right now. One is our historical focus with people with severe and persistent mental illness. They are our priority, and we need to never lose our focus to listen and include them in all of our policy decisions. Over the years, we have learned and listened to people with lived experience, and we continue to do so. But there's a new population. The new population is people who've experienced long-term and persistent trauma. Think poverty, gun violence, constant presence of fight or flight decisions, high levels of adrenaline, and a war zone environment. A trauma-informed state forces me to realize that behavioral results of not treating trauma is what we're living with today. It means we need to listen more and devise new ways of responding to young men or others who have been neglected by our system, but are now suffering from significant behavioral challenges. Cognitive behavior therapy, CBT, has been shown to be an effective intervention. Are we using it to reach them? Are we actually beginning to look at how our therapy models interact with the people we're working with? And just as an FYI, because this is an area that I've been working with for the past year, the average age of a young person most likely to shoot or die is between 25 and 30, with an average around 29. It is not under 18. The 18-year-old under 18 group represents about 10%, and it's pretty much stayed at that level for the last 20 years. It's gone up a little, but it's still in that 10% range. But these young men and many of their other folks have been living in a trauma environment for 10 or 15 years and have a continual flight or fight adrenaline push continually. And the new data coming out is beginning to show the impact of what that does on the brain and on the behavior. We need a new plan, and we need to figure out how we're implementing it. Secondly is your statement on a vision of an integrated health system and an integrated behavioral health system. This should not be a discussion of carve in and carve out and making it mutually exclusive. We can do both. We can have an integrated health system and still have our carve out, but we need to think about how to do it and how we integrate our services. Let me just say that if we don't control this conversation, somebody's going to do it to us. So our best position is to try to talk to each other, figure out how we integrate and how we make it real. I'm going to go real quickly through what I've learned in the last 50 years, because I really do want you to have time for questions and challenges. The first one on my list is we're all part of a government system. We need to understand our government. We need to understand how it works, why it doesn't work. But I hear too many people say, I'm not political. Well, unfortunately, you live in a political environment. Your best bet on this is to understand why it works and what the problems are. The second one is, and this one often comes up, is leadership is important. And we need leadership that is not risk aversive. I've met too many good leaders, but the moment they hit a conflict or they have to take a certain amount of risk, they back off again. If we're going to fight for what we believe, we have to be able to take the risk and the consequences of what that means. Leaders must understand the political environment and how government works and make it work when it's resistant. Just because, one of the quick side, one of the things I'm on now, I'm president of the Project Home board. Project Home is a homeless system in Philadelphia agency, and I'm president of the board. And Sister Mary Scullion, who's been a founder within Project Home, announced to us about 2 years ago she was going to retire. And my job right now is to hire a replacement. Now, this is like we're hiring a replacement for a saint. So it's really has all of us with a lot of angst. Sister Mary at one point sued both Ed Rendell when he was mayor and John Street when he was mayor because they said no to a housing project. She won, they didn't do it, she sued them again. And, you know, at the end of about 5 years, she won. And they basically had to do what the court told them to do. You would think that would set up some animosity. They probably are two of her biggest fans, you know, and will probably do anything she wanted at any point in time, which in many ways shows you fighting back doesn't mean you make an enemy. Fighting back means you make a system better. And it's what frightens me about replacing Sister Mary is that am I going to find somebody else who goes toe to toe with political leaders to get what's right? Anyone in a leadership position must understand financing and have a financial strategy. No more of this, I'm the CEO or I'm the director and I have a budget person and they do my budget. No, no, no. I'm the CEO and I need to understand that budget and I need to be able to manipulate it in ways that makes it work. They also need a media strategy that clarifies and doesn't muddle the water. In other words, if you really have a statement, make it. Don't try to make it so politically correct that nobody understands what you said or what you mean. And with that, develop have strong communication skills, but most of all, be a good listener. Set concrete, but realistic goals and stress performance outcomes. Talk and listen to people who receive our services, people who use our services and their families, and as often as possible. I would say 99% of the time, include them in policy decisions. Develop relationships and partnerships in everything you do and nourish innovation and creativity in yourself and in others. Practice flexibility. You know, for me, having flexible rules, and people say, but rules aren't flexible. Rules are a rule. And I said, no, I want flexible rules because everyone is different. And you need that level of being able to see and respect that. Talk and encourage risk. Most successful operations when they started were viewed as risky. And most people at some point thought they couldn't work. And someone said, oh, yes, they can. Let's try it. When starting a project, ask yourself, what does success look like? And don't proceed until you can articulate the answer. Let research drive policy and practice. You know, these days I'm on two foundations that fund major research. And I think my biggest complaint about their funding of research is most research, good research, doesn't get put into policy and practice. There's some really good research out there on gun violence and on trauma. And it's been there a while and we are just very slow to take it up. So part of it is don't repeat it, read it, figure out where and how it can work and tweak it to make it work for your environment. And probably most of all, don't let the perfect be the enemy of the good. It was a statement that Mike Mash, who was the budget director under Rendell, used to tell us all the time. Now, I want to end with two quotes, one from Martin Luther King. The arc of the universe is long, but bends towards justice. That's been my favorite one for a long time. And my new one is from Amanda Gorman, who's a poet laureate, who said, "For there is always light, if only we're brave enough to see it, if only we're brave enough to be it." So we're at a crucial moment right now. We can make our own future or we can wait for someone to do it with us. But I think this is a group that was born out of innovation, continue with that innovation, and can take advantage of the opportunities we have to be able, with a new administration here in Harrisburg, an unknown future at the federal level, but this is our opportunity to actually begin to create the new world we want to live in. So thank you very much for your attention.
That was everything that I hoped for and more. We have a brief amount of time. I'm going to do two things. One, we're going to take 3 questions They've got to be quick. And then, and one of those is from the chat, if there is anything in the chat. Okay, not yet. So, so we may just limit it to 2 questions in the room. Does anybody have a question for Estelle? Gordon, and then
I'll try to speak up. Thanks so much. This makes it easier. Thanks so much. Wonderful trip down memory lane and the present, and most inspiring. Thanks for all you've done. I have the following question. Seems to me that there is a lack of understanding in society as to what health and well-being involves. We see it's okay to give people medication and to give them treatment, but the social determinants of health are seen as political issues rather than public health issues. They're not seen as intrinsic to the well-being of individuals, communities, and society. And what I've been puzzling over and would appreciate any insight you might have is, how can we transform the understanding in our communities that these social determinants of health are not political issues, but are public health issues?
You know, I think that's one we've been struggling with for many years. Our system really did take a turn to make healthcare much more political in nature. And on top of that, states like Pennsylvania, that I would have called a purple state, if we had learned to work well between our different parties and do the best, turned back into a red and blue state, so that we have people fighting for ideology rather than for people. Part of this, though, goes enough for my political speech, but part of it is, again, education, doing as much as we can to help folks understand that healthcare. You know, people often ask me, why did I go to HUD rather than to HHS when I left the state? And why did I? And I actually was one of the lucky ones. I actually had a choice. I had offers from both. And I deliberately chose HUD because it seemed to me that the secret to having better healthcare was being able to get people into housing. And if I could figure out how the housing system worked, I could figure out how to make a better healthcare system. But people don't attach those two. We see housing over here, and it was the biggest obstacle I had in trying to do that were the people in HUD. They said housing and health, we don't belong in healthcare, it's over there. You know, so unfortunately, we had some pretty enlightening leaders at that point in time who were willing to at least start the conversation. But I don't think we ever got the conversation enough into the community and into the states for them to continue it. You know, there's some things that make treatment effective. And one of those is housing, another is food. You know, it goes back to the old days of Maslow's hierarchy. If you don't have food and housing, I'm going to have a hard time talking to you about why you should take your medication, why you should go and take care of yourself. We also desperately need to get into wellness. The stuff about, we accept prevention healthcare and everything except behavioral health. We have to figure out a way to start a conversation about prevention. We know a lot more than we knew 60 years ago. We have a lot of detail and information about behavioral health, when it starts, how to delay it, what trauma is. We now need to talk about that. Frankly, I really believe a lot of the research in this stuff is out there. We have not figured out an effective way of moving research into policy. And I don't have an answer for that, because it looks like it should be something that we do naturally. We have some of the best universities in the country in Pennsylvania, and they are generating a lot of that research, but we haven't figured out how to get it to us. But so I would say, to change the paradigm, communication, getting research moved into policy, and just making people aware that you're not going to get your money's worth out of treatment until you invest in housing, food, and social supports.
You know, I'm just going to take a little intersection here, Gordon, and point out that Len Duell was a psychiatrist who worked for HUD in the 1960s and actually created the Healthy Cities movement. which is all over the world around wellness, except the United States. And I now realize that as soon as Estelle took that job at HUD, I should have begged her to take me with her there. That's a helpful insight for me. Anyhow, we've got one more.
Just as one of the things that HUD did accomplish at that point, and we're still implementing, is that we took people with severe and persistent mental illness because of OMHSAS and said they had denied their rights to live in the community, and therefore they should jump to the top of any housing waiting list, which was a major, and that's happening, not as quickly as we wanted to, but now we have an avenue to, if we can make the case for unjustified separation, we can make a case for jumping people to the top of the waiting list in housing. And as you know, most housing waiting lists for public housing and vouchers is usually in the thousands. In Philadelphia is in the tens of thousands.
Elizabeth.
Hi, Elizabeth Kunkel. I'm the Chief Medical Officer at Pennsylvania Psychiatric Institute in Harrisburg. We're part of Penn State Health, but I also lived 30 years and worked in Philadelphia, so I know CBH well. So first of all, thank you for your comments, which were wonderful, and I learned a lot. In looking at the carve-out model, and looking at your statements about integration, how do you marry those two, and does the carve-out model work?
That's a $64,000 question. I've been trying to figure out, can we make a carve-out model work with integration? I actually think we can, and but what it takes is the two parts of the system coming together and having some real honest conversations about it, rather than being fearful. The behavioral health system is still afraid that if we go carve in, that the managed care companies will make us a profit center and we'll lose everything we've gained. You know, that was true 60 years ago, 50 years, well, no, 27 years ago. I would test the waters on it now. But I believe, and again, I'm looking at some of this. I've had an opportunity to both talk to and to visit CCBH and help them celebrate their 25th anniversary 2 years ago. I actually think they have modeled some of this. And part of it is because of UPMC, and they're both sort of inside of it. And so they found ways to get closer. I would say they're a lot closer than Philadelphia, for example, in integrating those two. But I think it takes both conversation. I think it takes some trust. I think it takes the state primarily saying, this is the actuarial rate, and we're going to make it work for both sides of the equation. We need to make sure that we support our hospitals. We also need to make sure we're supporting the people in the community. And that those two shouldn't be so far apart. But I think it's fear that's been operating. And we've let the fear control us. And in the beginning, no doubt about it, the fear was palpable and real. I'm not sure it's real right now, but we don't know because we haven't tried it. But I think we need to push. And unfortunately, that does come from the state. I shouldn't say unfortunately. I think the state takes a major role in trying to figure out how do we integrate these services. My concern is they're going to say, oh, the only way to do it is carve it in, and won't put enough restrictions on it to make sure that it works. But I think you can do a carve out and still have close enough integration to make sure that we're not missing part of it.
All right, Estelle, you're almost finished. Let me do one last thing. What?
The mic here.
Yes, well, it's hard, I don't want to drop it.
Oh. Wow.
Now, the question is, can I read it? Let's see, here we go. This is from the PPLC in recognition of Estelle, who is on this panel here. It says, a visionary inspiring generations of community leaders.
Thank
And
you.
this is, I don't know where you're going to go next. You're going to have to decide.
I'm going to Cleveland to enjoy the eclipse.
Thank you all.
Thank you.
Thank you.
Thank you. Thank you very much. And enjoy Joe Rogers. He was a mainstay for me in Philadelphia, and truly represents what I believe was the basis of much of our change. So,
Thank you.
Yep.
Estelle, who made all of what we're doing here possible. Let's give her a round of applause. Okay. I just want to point out that the paper that Estelle referred to, Reimagining Mental Health in Pennsylvania. I want to, is it on? I want to point out that the Reimagining Mental Health in Pennsylvania statement from the PPLC, with the great help of Stan Morawski, who helped to pull it all together, is in the packet that you've got. And for those folks who are online, if there's a way, we'll figure out how to get it to you. Maybe, nope. Lucy, what are we doing? After. Okay. Okay. Anyhow, that is there for you to take a look at. Now, is Joe ready? Take five. Okay, we are now getting set up for Joe Rogers. Hi, Joe. Are you there? Can you hear me?
Yes, I can. Hear me?
Hey.
You can hear me?
Yep, I can hear you. We're about to start again, everybody. We're ready to go. Time to sit down, please. Hello, everybody. Again, we are joined now by Joe Rogers, and I would like to just say a couple of words. Joe, it's good to see you. I don't know if you remember this, Joe, and I don't even know if I actually met you or if we just talked, but sometime in the late 1980s, I went to WBAI radio station in New York City with a friend of mine, another colleague, psychiatrist by the name of Steve Mullins, to talk about a project that we had working with homeless guys in the Bronx. And you were on the radio show with us talking about the work that was going on in Philadelphia and the work of the peer network that I don't know if you had quite created yet or were in the process of, but I came away from that meeting, I think for the first time, really getting what it was to hear a consumer's voice expressed about where we should be going in policy and practice. And it never left me. It never left me. So I am deeply appreciative of the opportunity to introduce Joe Rogers to all of you. Many of you from Philadelphia probably know Joe or know about the work that he's done running the national, for many years, the National Mental Health Consumers Clearinghouse, creating that as a technical center funded by the federal government, really groundbreaking work to bring the consumer voice forward and to put it in a driver's seat in terms of the development of mental health policy across the country. Joe and the folks in Southeast Pennsylvania really were the leaders across the country. And that work was inspired and led by Joe for many years. He's also continued in those efforts to, he built up the Southeast Pennsylvania Mental Health Association. I don't know, I think it's changed its name, but it's also still very much extant and important in the role of what happens in the Philadelphia area, and has been an inspiration. As Estelle was talking, and Joe, I don't know if you got the opportunity to hear Estelle speak, but she went into some of the history around Byberry. And last night, I reheard the story of a young man who decided that maybe the money should go into the community that had been in the hospital, and that maybe it would be a good idea to lock yourself to the gate in front of the hospital until they decided to do the funding, and thereby created an impasse and a need to actually make sure that we put the money where the people were. That kind of work, that's the kind of courage that Joe Rogers has done and led, and the kind of vision that he's led has propagated for many years. And I'm just thrilled that we have two people in Pennsylvania, Estelle and Joe, who have been national leaders and have made a dent in where we are. And I would like to offer Joe the opportunity now to talk and tell us something about where we've been, where we are now, and where you hope we will go. You ready to go? Okay, thank you.
I'm ready.
Let's go.
Thank you. Thank you very much. Boy, it was great to see Estelle, wasn't it? I miss Estelle. I miss Joan. I miss all of you guys. I am retired, so I'm not in the battle as much anymore. The history of the consumer survivor ex-patient movement kind of goes all the way back to the 60s and 70s, and it really grew out of a sense that what we needed wasn't so much a better treatment or a better medicine, but what we needed was liberation. In fact, the early name of the movement in Pennsylvania was called the Mental Patients Liberation Front. And, that sounds very radical, but what they did was they went into state hospitals and informed people that they have a right to live in the community, and that they should be themselves advocating for their right to live in the community. And that was so radical that they got arrested for trying to spread that message in Haverford State Hospital. I came along and joined the early ends of that. I mean, the beginning of the kind of a change in the movement to one of more looking at the system and how can we work with a system to institute the changes we wanted. But I still think that liberation idea kept us and fed us, because it was what we were looking at was, as Estelle calls them, social determinants, but we called them human rights. We called them freedom. To live, have a decent place to live, have health care. My gosh, how are you supposed to recover from major trauma, major mental health concerns, if you want to call it mental illness? How do you recover from such devastating, all-impacting problems without supports? Human supports, basic human supports. I work with I was going to say Trevor Hadley. I work with Mark Sulzer. First I worked with Trevor, and now I work with Mark. I still do some work with Mark. And what they're talking about is the idea that what we need is of people that are trying to struggle to overcome and become fully integrated back into the community, we need to be able to be integrated. We need to have ways that we are integrating and interfacing with the community, community inclusion. And without that, it's very hard. Just the isolation alone will keep you sick, will keep you determined, keep you feeling depressed, keep you feeling out of touch. I mean, early experiments during the Korean War where people were locked up, they tortured them by isolating them. And I can tell you from my own personal experience, struggling with mental illness, being diagnosed first with schizophrenia and then with bipolar disorder, that, you know, there's a huge amount of isolation, partly due to the stigma, just partly due to your social circumstances, being so poor that you really can't relate to people. Can't go out to a movie. You can't go out to dinner. You don't have the money. So we thought in terms of liberation. How can we liberate people? So of course, one of our first focuses was on state hospitals. There was nothing more oppressive, and there is nothing still more oppressive than being locked away miles sometimes from the community in a huge institution with very little kind of humanity. And so we started working on how can we liberate people from state hospitals. And luckily we had people like Estelle and other too many to name, people who supported that in the government. Who the idea was, can we get people out of the hospitals and live in the community in a decent way? And to do that, we not only needed to close the hospitals, we needed to transfer the money to the community, and there needed to be a political voice for that. There needed to be a strong political voice calling for this massive social change from institutional care to community care, and for the resources to follow the patient. And thanks to people like Mary Hurdick and other advocates and friends of the movement, we were able to organize. We talk about chaining ourselves. We took over city council and and had demonstrations time and time again, where we literally would take over city council. And sometimes it was on homelessness and the need for housing for homeless people, including people with psychiatric diagnosis, or especially for people with psychiatric diagnosis. We fought for CBH because we really felt that the resources combined into one pocket, so to speak, run by the county, would be resources that could be coordinated and could do things with reinvestment dollars that never been done before to help people be fully integrated back in the community. We believe that self-help and mutual support was a vital part of that, the isolation could be addressed by us coming together in our own support groups, our own places to organize and be together and socialize and speak out to each other and organize. And we did that in Philadelphia. We had all these organized efforts were a direct growth of having places like drop-in centers and consumer-run programs where we could come and get together and decide on issues and be heard. So I think it's something that's really needed in our social change movement of mental health care. Mental health care is not just a medical movement. It's not a movement just for better science, though those things are important, but it's a movement for social change. How do we treat people with serious psychiatric disabilities? And it's part of a larger movement of how we treat people with disabilities. and how we go about integrating people back into the community or into the community to begin with. I think Estelle hit a nail on the head when she talked about the housing. Without Housing First, which is the name of the program in Philadelphia and around in New York and some other areas, people would not have the opportunity to have a place to live where they can recover. I mean, our treatment of people still is most largely, we look at you as someone who, if we give you the right medication, you're going to recover from mental health challenges. But you could be medicated up the kazoo, and if you're living on the street, you're going to be sick. You're going to get sick anyway. You're definitely going to get physically sick. You're going to have illness, which will destroy your mental illness. Will destroy your mental health. It'll make you sicker. So we need to have a social change movement. Estelle alluded to the fact that the next 4 years are going to be an interesting, well, unfortunately, maybe way too interesting, depending on the election results. And Pennsylvania, by the way, is absolutely key. I'm sure you all know that if the way Pennsylvania goes pretty much determines the way the next 4 years are going to be. And we definitely need a social change movement to deal with that. No matter what the outcome, we need to keep the pressure on. We need to have people out of the suites and into the streets, demanding that that health care and mental health care is basic rights. It's not something that should be considered after everything else has been considered. How can you have an industrious population that's able to produce the best automobile if it's not a healthy population? I mean, just look at the situation of health in this country. And we got the scare with the COVID that we're not prepared to deal with health issues, especially health crises. So, we need to have a strong, organized voice of the professionals, of the family members, and particularly of the people who are recipients of services, be that services in healthcare or services in mental health care. And there should be an integration of those efforts. We should be united in our voice, fighting for the rights of people to have health care. And that's what we did in Philadelphia and around Pennsylvania, and eventually nationally. We organized, we brought people together, and we would find issues that were amenable to mobilization and to change, so that we could have victories. You can't really maintain a movement. You can't maintain movement if there aren't victories. So we picked key issues. Homelessness, of course, was all over the newspaper at the time when I came to Philadelphia. The Philadelphia Inquirer had just won a Pulitzer Prize for its coverage of the homeless situation in Philadelphia, and we saw that as a wonderful opportunity, a horrible situation, but a wonderful opportunity to organize. And we were being discriminated in public housing. We couldn't get into public housing. If you had a psychiatric diagnosis, you were basically barred by their rules and regulations. You were barred from Philadelphia Public Housing Authority. So we changed one place we changed ourselves to was to the front gates of the Philadelphia Housing Authority, and the workers all parked their cars in the courtyard where with the gates closed. They couldn't get their cars out of the parking lot. So that was effective. They heard us, and they met with us, and eventually we met with HUD, and HUD said, well, that's discrimination. We can't have that. So the rules were changed, and then people like Estelle and others organized to get it so that there was more positive even than you can't discriminate, but you have to find a way to bring us to the front of the list because because of the past discrimination as a way of justifying and balancing the scale some. So the history was one of getting organized and working with our allies. Without our allies, we would have been just people in the street making a lot of noise. Luckily, we had some really good, strong allies. And we even worked through a Republican administration, getting some good response with Mr. Kerry. I want to call him Dr. Kerry. We worked with him, and he was a Republican. So even Republicans could be brought on board and respond positively to the idea of social change. Mutual support was so important, peer support, that we wanted to see ways that we could kind of institutionalize peer support. And down in Georgia, of all places, they had established funding through Medicaid, through a waiver for Medicaid funding peer support, certified peer supporters. And Pennsylvania, we said, well, if they can do it in Georgia, we met with Estelle and Joan. We brought Estelle and Joan in for dinner, gave them a free dinner, and we sat down with them, and we said, if they can do it in Georgia, why can't we do it in Pennsylvania, especially since we do have some resources like reinvestment funds and stuff? And Estelle said, yeah, that makes sense. And so we went about creating a system of training and funding peer supports. And then Pennsylvania is now one of the leading states in terms of numbers and integration of peer support, certified peer support throughout the state. It's one of the kind of unsung miracles of our state is that we have so much peer support going on. And peer support kind of is an insidious revolutionary thing in that it works very subtly. It helps in ways that's hard to even sometimes measure, as Mark Seltzer can testify. But it works, and we now have it throughout our state. I guess what the future looks like is very scary. Human resources are the first that they start talking about cutting. They start talking about Medicaid, messing with Medicaid and messing with Medicare. We need to be organized. We need to be voting. We need to register and vote. We need to get the people who are users of our services registered and voting. It's perfectly legal to go in and make sure that there's registration forms available to the people that use your services. You need to talk it up. You can't tell us who to vote for, but you sure can tell us what the issues are, and people can research on their own, or they can also understand who supports what issues. You can do surveys of the candidates and ask them how they support the issues, and then publish the surveys. And that's one way to get the information out as to who's going to be supportive, who, if they get elected, will be supportive of human services. So I really want to thank Estelle for her talk and her wonderful years of service. And I will hand it back over to the moderator. I understand there may be some questions. Hello, moderator. And I guess I ended sooner than he thought I would be ending. There you go.
I'm here. What do I need to do?
Questions?
I wanted to thank you first for all of your leadership and for that superb talk. That I think the truth of the matter is, way back in the 1980s, building on the work that had gone on in the 60s and 70s, you were actually constructing the future then, and that future continues to project out into the future that we see. So I want to thank you. I want everybody here to have an opportunity to acknowledge what you've done for us and what you said today.
Thank you.
And I think we
I
can
wish there
couple
with
questions. Can we take a couple of questions? Anybody have a question?
Joe Lloyd Wertz here. And as a behavioral health advocate over the past 15 years, I still wonder as to how it is that I can finally get arrested, as you did, to serve the cause. I am so happy to have had you here at this meeting. Very, very happy. Joe, if you had two things to suggest to us as to how to engage political figures in our Commonwealth, what would those two things be?
Well, you need to get to know them. What we did was we targeted few key people on chairmen of the appropriations and those committees that are key committees in making the decisions, and we got to know them. It's interesting. Mental health is a narrative that goes throughout almost all families, and if you can get yourself introduced to somebody who's in one of those positions of powers, sometimes we did it with the staff person. The staff of a appropriations chair is more powerful than the senator or the congressperson themselves, because they know, as Estelle said, somebody always has somebody reading the budget, and they don't bother to read the budget unless you're Estelle, and that's so true. Senators pass these budgets and they never read them, but the person that does read them is the chief staffer for the budget committee. So you get in there and you get to know them. You meet with them regularly. You go up every chance you can go to the House or the Senate or the legislative body. You go out and meet them. And the second thing is that you participate in the electoral process. You take a role, even if it's a small role, and that's one way you get to know candidates is by being a volunteer for the political process. You have to get political. You can't. I mean, it's wonderful to be good academics. It's wonderful to be good practitioners. It's wonderful to do peer support and be a good supporter of your peers, but you've got to get out there and get into the political process.
Any other questions? Anybody else got a question for us?
If you put in the chat, I can see the chat.
Did you have a question, Alison? There's somebody's got a hand raised, and
Okay. They in the chat, or
somebody got a Lauren Roth. We're calling on you, Lauren. Can you hear us?
Yes, I can hear you. Can you hear me?
Yes. Go ahead.
Joe, you're fantastic. Can you reflect a bit on your emergence as a leader who people listen to and value? It's a bit of an invasive question, I realize, but having people like you is just so important. How did you rise, shall we say, as a leader and spokesperson?
well, I got training in it. You know, there was leadership training and a lot of opportunities at leadership training, including in my high school. Later, I was a member of a group called the Young Workers Liberation League, which was a effort to train young people in leadership. So I think one thing would be great for us to do some leadership training programs in like local mental health associations could be very good at being instruments in the National Alliance for the Mentally Ill in identifying young recipients of services and helping them learn about leadership, helping them learn about Martin Luther King, helping them learn about Cesar Chavez, helping them learn about how social change only comes when people take a leadership role in calling for social change. So I think we could do some work in creating leadership institutes to help train future leaders, and we need future leaders to help keep the movements for social change. Just like this organization for psychiatrists, it's a training ground for psychiatrists on being community psychiatrists. Well, there should also be workshops on how to be a community psychiatrist who leads social change. So that's where I got my help in learning to be a leader and being challenged to be a leader.
Well, thank you for the personal statement.
Thank you for the question.
All right. You know, Joe, I don't know if you've heard this term before, but there is an emerging way of talking about what you've been talking about all along. That's called solidarity care. The notion is that it is by people, with people, among people, together, that we can find ways to rejigger or to rethink or to reimagine and to redo how we relate and connect with each other, and the power that comes from folks finding a way to escape their isolation and their tendency, unfortunately, to be left behind if resources are not available. So the idea of solidarity care, of connecting, of reimagining how we link ourselves together, I think has been a really critical thing that you have been leading for a long time. And I think personally, for all the talk about technology and various ways of moving forward, I think it is in the fundamentals that you outlined that our future is going to persist. And I think it's going to inform all the work that we do. And I want to thank you again for enunciating it, leading it, and then making us pursue it. Thank you very, very much. And thank Joe from all of us.
Thank you, everybody. God bless.
We have about 15 minutes. We are remarkably on time. So we will be assembled back here in about 15 minutes. Say what? Checkout is at 11, just so you know. Okay, thank you all, and we'll see you in a few minutes.
Dr. Vergere is a leading expert in community, geriatric, and administrative psychiatry, and was attracted to psychiatry as a medical student at Hahnemann Drexel because of the influence of community mental health movement had on how students and residents were trained. Again, running through a few highlights of Dr. Vergere's distinguished career, he served in his early career as medical director of a partial hospitalization program at Hahnemann. Also worked with the Philadelphia Office of Mental Health to oversee the opening of the first shelter for homeless individuals with mental illness in the late 1970s. He organized the mobile emergency teams in Philadelphia in the 1980s and helped draft the guidelines that created long-term structured residences following the closure of Philadelphia State Hospital. He also served as the Daniel Lieberman Professor and Chair for the Department of Psychiatry and Human Behavior for the Sidney Kimmel Medical College at Thomas Jefferson University, and Senior Vice President for Partnerships and Affiliations for Thomas Jefferson University, and has served in a variety of leadership capacities in the American Psychiatric Association, as well as the Pennsylvania Psychiatric Society and the Philadelphia Psychiatric Society, and has been bestowed a wide variety of honors during his illustrious career. I'll pick out one of the many that in 2007, he became the first psychiatrist to receive the Bell of Hope Award presented by the Mental Health Association of Southeast Pennsylvania. Secondly, we are joined by Dr. Mark Salzer, who is director of the Temple University Collaborative on Community Inclusion. Dr. Salzer is a psychologist and professor of social and behavioral sciences in the College of Public Health at Temple University, and he is the principal investigator and director of the Temple University Collaborative on Community Inclusion of Individuals with Psychiatric Disabilities, which is a research and training center that has been funded by the National Institute of Disability, Independent Living, and Rehabilitation Research since 2003. He has previously been on the faculties of Meharry Medical College and Vanderbilt University, as well as the University of Pennsylvania, prior to his tenure at Temple. He has been the principal and co-investigator of more than $30 million in federally funded research grants, has published more than 150 articles and book chapters on the effective delivery of community mental health and rehabilitation services, has given over 450 presentations nationally and internationally. He's been interviewed on both national and international media, and has also received a variety of awards and honors as well. And then thirdly, I'm joined here in person, by Nancy Wyman, who is consultant for the Southeast Region Mental Health Services Coordination Office. And Nancy has, as well, has a long history in community mental health. She was the Montgomery County Deputy Administrator for Mental Health Services from 1986 to 2014, and was a champion for individuals with mental health challenges, an advocate for family members, a partner to providers, and a leader and consensus builder in the community. And in 2003, she initiated the transformation of Montgomery County's public mental health system to embrace and adopt the philosophy and best practices of the recovery movement. Prior to that, she worked for several years at Norristown State Hospital in a variety of roles, and currently works as a consultant for the Southeast Region Mental Health Services Coordination Office, and has done consulting projects with Temple University's Collaborative on Community Inclusion and Department of Rehabilitation Sciences, also with the Pennsylvania Mental Health and Justice Center of Excellence at Drexel. And she's also the current president of the Montgomery County Correctional Facility Board of Inspectors, and also engages in a variety of fun activities listed at the bottom of her bio. Some that stuck out to me is that she is a member of a book club and is learning how to garden, which are two things that we have in common. So with that, I am going to turn it over to Dr. Vergere to kick us off. And I will say our goal, we have about an hour, is for each of our presenters to speak for about 10 to 15 minutes to allow a lot of time for questions and discussion.
Well, thank you, Rachel, for your kind introduction and for your work in this field that's near and dear to my heart. And also thank you to Ken Thompson for his ongoing leadership to keeping psychiatry connected to the community. This is critical, and we're living in critical times right now. And in that vein, I'd like to just share something that I was faced with this morning. So I opened my morning newspaper, and what do we see? But our esteemed governor of the state of Florida has come up with a new headline that he hopes to take national. And this one is sidewalks to shelters. where Florida is now passed a law that will mandate that you cannot sleep or snooze or pitch a tent in any public areas. You must go to county or city designated areas. But, you know, the background on this is important for us to keep in mind, because the sentiment about serious and persistent mental illness and the social issues that are attached to it keep coming back over and over again. And the solutions, unfortunately, are often naive, sensationalized, and not connected. But having practiced in Philadelphia with colleagues like Joe and Estelle, have helped to make this a more rational conversation. And I was asked to talk about my perspective as a provider from the early days to my current days. So I don't think we have all day for that. And I'm not sure I can get all the facts straight. So I'm going to jump around a little bit, but try to err on being brief rather than long here. But in the context of colleagues, I couldn't be bookend better than with Joe Rogers and Mark Salzer. So on one side, Joe described the vivid days of protest and trying to capture the attention of city government. And he would chain himself to the gates of City Hall. I wouldn't. But Joe knew I was there to help, but he and Mary Scullion would literally do that. So he was an alter ego in that sense. He would do some of the things that I couldn't quite get myself to do there. On the other side was Mark Salzer, who was very systematically collecting data, analyzing data, and pursuing this in much more logical pathways than Joe and I could muster, and others in the coalition movement at the time. So it's important to have a variety of people focusing on the topic in hand today. And I think Estelle has so eloquently outlined this evolution. I'm going to go back a little further. And my two themes here are going to be about exposure and education, as well as persistence. Because everyone, I'm sure, in the room there today has had to persist on topics that often others would rather us push away. So my exposure goes back, you know, the Mental Health Act. I was in high school when that was passed. I was a high school senior. I had no clue I was going to go into psychiatry. I wasn't even sure I was going to go into medicine. But I knew from the exposure to that, that there was a very logical conversation going on, that people should be able to access care and that the care should be integrated. And I had seen in my own life, in my family and friends, how important mental health support and physical support were. So they were the basis premises that I went forward with. Fast forward to medical school, this was reinforced further by people like Cliff Bedarkey and Paul Fink, who somehow grabbed hold of me on a SAMHSA grant, where we were looking at sites in North Philadelphia to open satellites for what was then the Hahnemann Community Mental Health Center, which then became the JFK Community Mental Health Center. But I was surrounded by teachers who were also reinforcing the same values, that mental health services need to start at home. Prevention and early intervention is critical. There were early intervention and daycare programs built into our satellite sites at that time, and a host of other things. And naively, I thought that's the way it was everywhere else too. But I did exist in a little bit of a bubble there, I guess. When I transitioned into practice after residency, my first position was to run a day hospital. Well, that day hospital was funded by a grant from Blue Cross, IBC. And it included staffing with nurses and social workers. And it was brought in by my chair then, is Whirling, who was committed to the idea that the critical point in services to acute care occurred before you admitted people. So he instituted a rule that everyone who was proposed for admission from all of our then satellites that were scattered around our catchment area in North Philadelphia must go to the day hospital before they go to the emergency room or inpatient unit. Now, again, I had the luxury of having social workers and nursing staff, whole entourage to help me there. And we would get to work every day. And that's how we started every day. And the majority of folks, guess what? Didn't need to get admitted to the hospital. We could find other resources. When that funding stopped, that model went away. And so that story, each of you have heard over and over again. There are good ideas out there, but sustaining funding and keeping this front and center in the bigger conversation about what kind of healthcare do we want to make sure everyone receives is something that we drift away from over and over again for different reasons. Following that time, then we started to focus on housing, because you can't run a day hospital without a place to send people home to. And you begin to realize that where they were living was part of the problem that got them to us in the first place. And that's when I got to meet Sister Mary Scullion and then Joe and other people like Tim Hopper, who in New York would, everyone was trying to analyze, well, are people homeless because they're mentally ill? And we tried to broaden that conversation, and he would scream it loud and clear and say, people who are homeless all have one thing in common, and that is the lack of a stable place to live and a supportive place to live. But before we got into the coalition and the state hospital issues, this was some of the background that was going on in our city. Joe has mentioned that even our Republican administrations were friendly in those days. So Governor Ridge was a critical partner in some of what went on, along with Rendell and Casey. But somewhere along the way, around the 1980 or so, is when I was leading the Philadelphia Psychiatric Society. The issue of Byberry came on the list, Philadelphia State Hospital. Now, back to my education emphasis. As a medical student, I was sent to Penhurst. I was sent there with my class to observe the conditions with a faculty dialogue in the background that was pointing to, this is shameful and we could do better than this. The officials at Penhurst didn't know that's why we were there, but my medical school education included that in there. And I got the same education on Byberry. You know, as a provider, I was kind of distanced from that. The members of my council were distant from it. We thought it was a resource until you started to look more deeply into that. So we needed to be brought into the conversation. And that conversation expanded with Joe, and Mary Herdig's name was mentioned early, and she was a critical organizer there, Loretta Ferry. And from all of that, we were able to transition to what eventually became CBH. CBH, Joe probably remembers the day when there we were in the mayor's office. Rendell was mayor at the time, trying to convince him to take this risk. Mary Herdig leading the conversation. Estelle was in the area, and we were trying to promote that she could run an entity called CBH that could be an answer to what the problems that we were seeing from all of the carve-outs and the selling off of the financial portion of the capitation rate that for-profit and even non-profit entities were using to fund other portions of their plans or their investors. And so, again, looking back over these years, I think the formation of CBH was a real keystone in what we see now in how we evolved back then, because it opened the doors to rethinking how we wanted to use our resources. and invest them in proper places. There were other services that came into play there during this, what I would call a socialization phase, where the public was becoming, and the professionals were becoming much more aware that there were better models for taking care of things. But we had to pass laws such as Code Blue because we couldn't bring homeless in prior to Code Blue. Richard Searles asked us to develop a mobile emergency team. We didn't have anything like that. And that model has persisted, although isn't always used in the way it was designed to be used. Karen Snyder asked me to draft something for how to lock residents, because we weren't allowed to lock residents. You could lock a hospital door, but community facilities were meant to be unlocked. And I can remember a heated discussion at our coalition meeting, and Joe and Mary and Loretta were there, and the topic was lockable facilities and things like that. And I finally had to say, there are some people we just can't help enough so that they can sustain themselves. Not everyone is going to fit this model that we have of recovery and stabilization. And so what unfolded from there were the rules that you could actually have places such as LTSRs. Now, I'm not up to date on where they are today in 2024, but I know if I go back 10 years, they were already filled, and they weren't always meeting what they were designed to do. They were designed to not only be lockable, but to provide the recovery services that were unrealistic to expect from an acute hospital unit. So that acute hospitalization was meant to be acute, not 30 days, 60 days, 90 days, as it has become at times because of the backlogs in the system. So the LTSR idea was another good one that fit in the middle of this and helped stabilize people enough that they can move to the next level of care. So these are the kinds of things that were transpiring back then. And then we got to another socialization phase where we were being asked to call our patients consumers. So it's a reminder to our group today that we have to be mindful of our audiences. In the end, the professional audience that fought the notion of consumer learned to embrace it. They just didn't understand it. Some felt it was derogatory, that when we would talk about patients, we were talking about it with empathy and professional concern. But what Joe Rogers and his colleagues educated us on was that, there's an empowerment issue here. There's a choice issue here. There's an education issue. There's a collaboration issue here, which constantly gets overlooked by the so-called caring professionals. So there was another important chapter along this road to where we are today and how we want to approach delivering care. The other part to the consumer movement was, though, to recognize the value of the families and supporting structures. These were not always friendly partners. So we had NAMI and we had the Mental Health Association. And at the time that when Bob Lerner stepped down, we needed to appoint a new director of that. And when we appointed Joe Rogers to that role, that stirred a certain amount of attention in the community, which eventually was bridged. So I think that when we're moving forward, and to those of you who are younger in the field, you certainly need to persist, but you also need to anchor your persistence in some shared values that with rich collaborations, like I was fortunate to have, you're able to go from ideas to action. Today, I think we're in a very strange phase, and I'm glad that Estelle brought in the whole impact of the pandemic superimposed on an eroding infrastructure in our youth. Imagine today, someone in their 30s probably doesn't even know what institutionalization is. The state hospitals, at least in Pennsylvania, don't even come into play. And there's so many other forces that come in when a young professional tries to do a comprehensive planning for an individual. But I am confident that we will get beyond this. I think that Florida, it used to be California, raised all the ideas that we thought sometimes were a little bit hard to digest. So now it seems to be Florida keeps raising them. Last month, they eliminated fluorine in our drinking water down here in Collier County. So I think we need to pay attention to these trends. That's why I bring up that newspaper clipping, but we also should be prepared now to insert ourselves in these conversations. If you look at the quotes in the paper this morning, the government is saying, and I will quote, the legislation I signed today upheld our commitment to law and order while also ensuring homeless individuals have the resources they need to get back on their feet. That's from our governor's office. Compassionate conservatism, pointing to decades of funding for efforts that haven't helped, will now bring in attention to poverty, mental health, and substance use disorder. So that's the government's hope. From the consumer side, they have now passed legislation that will create forced internment camps, shoving homeless people into fenced villages where they will be neither seen nor heard. So somewhere between these two poles is where we live. And I'm confident that our next leaders are somewhere in this audience today. And you need to be prepared to persist and educate those who are coming up behind you, and also create that important dialogue with your local and state legislators. I'm going to stop at that point because I look forward to hearing what my other panelists have to say.
Thank you. Thank you so much for that, your wisdom and sharing your expertise. And on to Dr. Salser. Take it away.
All right. Thank you, Rachel. And thank you for the introduction. I just wanted to let you know or say again that meeting with psychiatry fellows at Penn is a highlight of my year and is now an opportunity for me to honor Trevor Hadley and Larry Reel, who are so committed to PPLC and its mission. So again, I appreciate being able to be part of this panel. Dr. Vergere, wonderful to see you again and be connected. And thank you for kicking off this session with such important comments about our past. Nancy, I'm sorry I'm not there in person. I arrived home from a trip at 1 a.m. this morning and actually kind of agonized a little bit about driving out this morning to see you and others in person, but probably more wisely decided not to do that. But I'm now feeling ambivalent about it again, but it's too late. And I want to thank Joseph as well. Those of you, probably you don't know this, but Joseph has essentially hired me 26 years ago and brought me to Pennsylvania. And he's taught me so much since. We've talked about Joseph's advocacy efforts and the things that he was willing to do to advocate on behalf of people with lived experience. And I want to share that I have kept a newspaper photo of Joseph being carried away by a few officers at a protest about 20 years ago. And I keep it as a symbol of how essential it is for all of us to keep fighting. And I think, Dr. Vergere, you've been making this point as well. Fighting for the health, wellness, recovery, and rights of people with significant mental health issues. So those of you who want to keep this symbol or have a copy of it, send me an email. I'll send it to you, and we can all be reminded of what we really need to do and what's needed to keep things going, hopefully in a positive direction in the future. I've been asked to talk a little bit about where we are with the concept of recovery and where we might go in the future. Some of the things I'm going to say might sound a little challenging, and that is correct, but hopefully it'll be a little bit uplifting as well. All of you know that the concept of recovery emerged out of a very enlightening time, internationally actually, including calls for racial equality, women's rights, LGBTQ plus rights, consumerism, and a disability rights movement, including the independent living movement. And Pat Deegan is actually among the first to write about recovery in 1988. And for those of you who don't know who Pat Deegan is, you should go Google her and read everything you can. She's brilliant. Pat had a background working in centers for independent living, which you should also become familiar with if you're not in the broader disability community. And she wrote about people with disabilities, including mental illnesses, viewing themselves as, quote, recovering a new sense of self and purpose within and beyond the limits of the disability. So she's really usually recognized as one of the first people to write about the concept of recovery. Obviously, Bill Anthony and many others since, including Joseph Rogers, as well as Susan Rogers, who's an incredible advocate in her own right. And I see her right there. Susan is also amazing, but Estelle, Ken, many of you, and of course, SAMHSA have also helped this concept become universally adopted in public mental health systems around the world as a driver of system and service delivery philosophies. The research suggests that recovery is real. It is something that happens in the lives of people, including people with very significant mental health issues. And the concept has undoubtedly offered hope about a better life for many people with lived experience, offers hope to providers that people they work with can lead good lives, offers hope for family members. And I just want to reiterate that these impacts cannot be overemphasized in terms of their importance. Hope is critical and something for us to pay a lot of attention to. The impact of recovery on mental health policies and services, however, is somewhat open to debate, in my opinion. Some have suggested that services such as case management, psychiatric rehabilitation, including clubhouses and supported employment, and peer support exist because of the concept of recovery. But I always like to point out, sometimes unhelpfully, that all of these existed well before the near universal adoption of the recovery concept. All of those things that I mentioned were around a long time before the concept of recovery became known. And in fact, one could argue that recovery may not have had much of an impact on the progress of these types of services. Rehabilitation services remain underfunded. PACT, a program in assertive case community treatment, a early form of case management services, started in Madison in the 1960s. It used to emphasize people living good lives in the community, including going to work, school, leisure, those kinds of things. And right now, case management doesn't really seem to focus much on those kinds of things. Clubhouses actually started in the 1950s. So that's actually, that preceded the concept of recovery by 20 or 30 years. Supported employment models have also been around for decades, predated the concept of recovery. Peer support has also been around for a very long time as well. Recovery Inc., DMDA, now DBSA, GROW, which is a self-help mutual aid group that started in Australia that actually introduced me to the concept of recovery, and peer support also started in the 1950s. Certainly, there were no certified peer specialists until about 20 years ago. I wish I could say that the growth of certified peer specialists and acceptance of certified peer specialists is a result of the influence of the recovery concept, but I suspect it more likely has to do with shifting funding for peer support from SAMHSA block grants, state and county funds to Medicaid reimbursed services. So there's probably a funding shift that explains the growth of certified peer specialists, not necessarily the concept of recovery. And I also want to just mention that the concept of stigma towards people with mental illnesses remains significant. There's good research suggesting that it really has not changed much in the last 20 or 30 years. Even though we've been talking about it, we have May is Mental Health Awareness Month, October is Recovery Month, but the research suggests that stigma is still very present and has very significant impacts on the lives of people in recovery, including stigma among mental health professionals. But I'll leave that where it is right now. Some well-known recovery advocates have raised concerns about the extent to which the concept of recovery has been influential. About 20 years ago, Larry Davidson and colleagues raised concerns that if we are not careful, recovery could become old wine in a new bottle. In a subsequent article, Larry and his colleagues described a number of concerns people raise about recovery that may limit its impact. The concerns include the sense that professional expertise is devalued, recovery is not evidence-based, and that there's been a lack of truly novel services to promote recovery, which is what I described a few minutes ago, and that recovery is a fad. Mike Slade, who's well known for his work in the concept of recovery in the UK and elsewhere around the world, has really expressed similar concerns about the concept of recovery, and in fact has raised concerns that the concept has led to abuses rather than supporting people with significant mental health issues. There is a group in the United Kingdom that has come out with the term recovery in the bin. And they talk about the concept of recovery having been co-opted to punish and control those dealing with mental distress, rather than focusing on human rights and social justice issues. And Kim Hopper, who's really a well-known anthropologist in the mental health area, fears that the concept of recovery has become this is his quote, a co-opted, near toothless gospel of hope. So all of these folks who are really proponents of recovery have raised alarms about the concepts for a long time. I actually have a paper currently under review. That's something I get to do is try to come up with ideas and influence the field in that way. And in this paper, I certainly make the argument that the concept of recovery is real, but it's likely time to build on the concept rather than basing everything we do on what some have referred to as a very polyvalent and complicated concept. Larry Davidson and some colleagues I mentioned before had made a comment that it seems that the only thing most stakeholders agree about recovery is that there is a considerable amount of confusion and debate about the concept between and among various constituencies within the mental health communities. In this paper, I review a number of different definitions of recovery that have been proposed over the years, including SAMHSA's definition. This complicates the implementation of policies and programs based on the concept if we have so many different definitions of it, so many different ways of understanding it. Some people have actually argued that recovery is such a unique experience that there cannot be one single definition, as it really depends on the person. So some people are even saying there's no such, there isn't a single definition that we can have. Instead of trying to define the concept, many have instead tried to identify the concepts related to recovery. Larry Davidson, again, talks about concepts like overcoming stigma, redefining self, identity, hope, and commitment. Mike Slade and his colleagues talk about meaning in life, connectedness, hope, and optimism. Marcia Ellison also writes about empowerment, purpose, and hope as all being concepts related to recovery. But all of these concepts are also well-established in the literature and well-established concepts. And it really raises a question of how unique recovery this concept is, if it's a blend of old concepts that have been around for a while. People have also written about the different perspectives about recovery. There are consumer perspectives about recovery, clinical perspectives, service-based perspectives, service user and informal caregiver perspectives, gender perspectives, family perspectives, lots of different perspectives on recovery. One of the things that really got me starting to go down this line of work is that people have also proposed various types of recovery. They've talked about subjective recovery, clinical recovery, personal subjective recovery, consumer recovery, social recovery, vocational recovery, personal civic recovery, psychological recovery. I'm going to stop there because there are another 10 different types of recovery that have been proposed. People have developed measures of recovery. I've been involved in this business as well. There are like 20, 25 different measures of recovery that are out there. This is a complicated concept that we have here. So I'm going to end with a quick proposal for how we can build on this concept of recovery. And for those who are familiar with my center, the Temple University Collaborative on Community Inclusion, you might not be surprised that I suggest that we embrace the concept of community inclusion as a way to build on recovery and really promote recovery long term. Community inclusion is is a concept that's widely accepted in the broader disability community. It influences policies and programs and practices and has done so for about 70 years or so. It's based now on the Americans with Disabilities Act and the OMHSAS decision. And I usually talk about community inclusion as referring to opportunities that people with significant mental health issues have to live in the community and be valued for one's uniqueness and abilities like everyone else. The opportunity to go to work, go to school, dating, parenting, leisure recreation, voting, volunteering, family, friendships, relationships, going to church, synagogue, or mosque. All of these kinds of things are things that we should be promoting in our policies, programs, and practices that we're involved with. There's been a great conversation so far about social determinants of health as being critical. Community inclusion and the resulting participation that will hopefully result from these increased opportunities are social determinants of health. Work, employment is associated with positive health outcomes. Relationships are associated with positive health outcomes. Going to church, synagogue, or mosque, if you're a believer, is associated with positive health outcomes. So these are health issues, so much so that I actually refer to community inclusion and participation as a medical necessity. And I use that concept intentionally. It's not just medications, therapies, treatments, case management that promote mental health and wellness, and symptom reduction and stabilization. It is also promoting opportunities for people to participate in the community like everyone else. So I'm going to stop there and pass it on to Nancy, but I appreciate the opportunity to talk about where we are with recovery right now and where we might consider going in the future.
All right, thank you, Mark. And on to Nancy, our final panelist.
Well, hello, everybody. My name is Nancy Weeman, and I'm not from Philadelphia. I was from Montgomery County, so I know everything that people have talked about today, but I helped do the development of the services in Montgomery County. And I thought what I would do, first off, Mark, you have blown my mind, and now we have to go out to lunch so I can talk about all that you suggested. I thought that I would tell you the story of my career a little bit because I bridged both of these worlds, and I think it has really helped shape my thinking and may also help all of you think about how thinking changes over time and how you can start out in one place with one set of ideas and really grow in a different direction. So I started my work in 1969, which is 55 years ago. I graduated from college, had my resume in my hand, and I had the idea that I wanted to do something where I could help people. I also had the idea, like many 22-year-olds, that I wanted to live in a city, get a job, have an apartment with my friends, go to the shore and meet boys. So there I was, what am I going to do to be able to accomplish those goals? And as it turned out, I drove onto the grounds of Norristown State Hospital and got hired in the vocational services department, which my responsibility was to help people get jobs on the grounds, which turned out over time not to be something that was considered to be legal, but I worked in the male admission unit and in an ongoing care unit. And I placed people in employment opportunities in the hospital and in the community. And I will say that my idea of helping people was to take care of them, that I was a person who could help them by taking care of them. And I also will say that I did not have an idea that institutionalization, I didn't understand it. I didn't know what it was. I didn't know the harm that come to people over time in living in a setting like that. I was just there, and my job was to help people. I will tell you, Norristown was not known as a snake pit as Byberry was. Norristown actually was an interesting place. Alfred P. Noyes, who was a psychiatrist in the 30s and 40s, had been superintendent there. And the hospital actually had many of the elements, albeit in the wrong place, of what I would consider a center of excellence now. It had a 4-year psychiatric residency training program. It had a large psychology department that had internships for PhDs. So there were lots of new folks coming in every year to work at the hospital. All the social work graduate schools had internships. Bryn Mawr, Temple, Penn, with students at the hospital. There was actually a nursing residence at the hospital where the nursing schools people came through and stayed and got their practicums there. Occupational therapy, recreational therapy, vocational services, all were connected to the universities in the Southeast region and had students coming in. On the hospital grounds was a general hospital. And this place was sort of like a town to most of us. There were a lot of young people just out of college working there, and it was a very, very interesting place to work. We were there at a very heady time. We were there at the beginning of the deinstitutionalization process that came about because of the 1963 Community Mental Health Act in this country. And so a lot of our work, while we worked with people in the hospital, we also did a lot of work to place people in the community. And we took them shopping, we had groups, it was always interesting to me. I can remember taking a lady to a grocery store and all she kept doing was stepping on the automatic doormat and saying, look at this, look at this, look at this. It gave you a very hands-on, real picture over time, I understood, of the impact of institutionalization on people. They were removed from the community. And although many of the things that they did in the hospital were community-like, they were not in the community at large. Over time, as the hospital got smaller, they started to take away some of these elements that I think helped Norristown have the reputation that it did. So the psychiatric residency program went away. The internships programs went away. The social work programs went away. Outside people stopped coming in. It was just a very interesting time. I worked in direct care for 7 years, and then I worked in administration, which I really, really liked. And I decided at some point that I was working in a place that was dying, and that I really did not want to continue to work there. And so I went to graduate school, and then, as luck would have it, really good luck, I was hired right at the time that I graduated from graduate school to become the deputy administrator for mental health services in Montgomery County. Montgomery County is a suburban county of Philadelphia. It had the 3rd largest mental health program in the state. And at that time, I was the only staff person for that job. I had, in hindsight, a very small budget of $6 million, and medical assistance was not part of a managed care program. It was available through the state, and so our provider network essentially had 2 funding streams that they managed. And we began in Montgomery County. I was very fortunate also that Molly France, who was the administrator, had already foreseen the connections to both family support through an active and growing NAMI movement and the peer movement through the Mental Health Association of Pennsylvania. So we were involved with having the voice of family members and consumers at our table from the time that I started my work. And then as Estelle talked this morning, I was part of that movement that helped to decrease the census at the state hospitals. Byberry closed in 1989 and 1990, and then the state made the contract with counties to say, if you will agree to close a certain number of beds at the hospital, we will begin to put money into your budget so that you can develop programs for those people that are leaving the hospital and also have services available so that people in the community do not have to come into the hospital. And that was an amazing time in the mental health system. It lasted for about 10 years. Norristown served Montgomery and Bucks County and the northwest part of Philadelphia. There were 3 units there for Germantown, Mount Airy area of Philadelphia. And Byberry closed, and then Haverford State Hospital closed. Both of those hospitals consolidated into Norristown. And then we began a process to bring Norristown back down to the size that it was before those closures had occurred. And what was interesting about that time was that the 5 county administrators agreed to a 5-year plan of working together so that those 2 counties, Bucks and Chester, who had many less people in the state hospital than Philadelphia, Delaware County, and Montgomery County, that we understood the importance of developing infrastructure, and that those counties on some years of our 5-year plan would get money for their infrastructure development without closing beds. So that was what was unusual about that project. In 1997, in the middle of all this development, Health Choices began. And as Estelle talked, Philadelphia had CBH, and the 4 suburban counties contracted with managed care companies, Magellan, and there was another one whose name I have forgotten. I actually have forgotten it. I don't think it exists anymore. So we all were very excited about this because, as she said, we then as counties had the management responsibility of all the dollars. And that way you could start to use the money. It's very important to think about using the money to achieve the goals that you would like to have happen in the community. And the fact that we could save money and then reinvest in the community gave us a wonderful opportunity to continue to develop. So that brings us to about the end of the century, which sounds very strange to say, I think, because I always think of 1899 or 19, as the end of the century, but we were at the end of the century. We had many fewer beds at Norristown, and what we had the experience of each county wanting to do continued bed closures, but having situations with individuals that were fairly idiosyncratic. And so that to do a program for an individual was difficult because of the cost of that program. And so we went together and partnered and developed the Southeast Region Services Coordination Office and set about to develop a set of regional programs in the Southeast region that still exist today, that all of us share and have capacity to have individuals from our county participate in. And that was pretty innovative, that we worked together to not just do things as individual counties, but to go together and work to help the consumers in our area. So we get to the early 2000s, and there we are. We have done all this work. And so the question is, now what? And what we started to hear from the consumers more and more and more clearly was that this is nice that we have services, but services are life. Services themselves should not be the end experience of our life. And so we started to think about, how do we do something different with this system? Has our system in the community become somewhat institutionalized? Now, I was a person that had to be deinstitutionalized. I was a professional who thought differently about community living because I didn't know about it as a person who worked in a state hospital. So it takes time to change how you think about things. And simultaneous with this questioning, as Mark pointed out, there was a lot of work being done and discussion being done about recovery. And what is that? And what is the individual process that a person goes through to be able to live successfully with something called a serious mental illness? So we decided in Montgomery County that our idea of service would change and that we would start to reorganize our system, and that services, to be thought of them in this concept, construct of recovery, would be that services are tools to help the individual. They are not the end point. They are just one tool of many tools that can be available to a person to help them move forward. And so we always had this mental health luncheon every year with lots of people coming. And so I did a keynote address, and we actually named this process. We called it the Partnership for Recovery, A Journey of Hope. And we laid out a vision, which is, I think, a role of the county office and the people that work there, is to lay out a vision for the community to start to have a context for the changes that we are going to make. In 2004, Pam Howard on my staff and Jack Boyle from the Mental Health Association came to me and said, Nancy, there's lots of stuff going on in Georgia, as was mentioned, about peer support. And we think that's something that we at the Mental Health Association and you in Montgomery County should think about doing. And so I said, well, okay, let's do it. So we started an educational certification process to train people who had lived experience to be peer specialists. And at that time, with Joan Ernie at the state, she said, you guys start with this and we'll work with you to figure out how to make this something that can be paid for through the Medicaid program. And for me, I'm interested in what Mark said about peer support, but I think for me, it is one of the biggest achievements of all the work over the years that we have done together. I just feel when I look and listen and hear out there of the presence of it now, it is just a given that it is in the system. It is everywhere. You can have it as an individual service. It's not necessarily a specialized service. It's available everywhere. They have peer specialists in the Department of Corrections and in the DOC. It is something whose time had come, and I think it can continue to evolve to be a good support for people. The point of that little discussion, I think, is that, as Estelle talked this morning, is that we need to be able to get to yes. We need to take risks, and we need to be able to get to yes. So as I think about issues today, because I have a couple things that nobody else has mentioned that I would like to talk about, but I just wanted to talk about a little bit about the issue of leadership. I think leaders need to have a vision. We need to be able to articulate with those people that we are serving, consumers and family members, what it is that will work for them. And we need to listen as we work together to hear what it is that would make a difference for them. As Estelle said this morning, I agree 100% with this. We need to understand how the money works. People roll their eyes about the money. And I never did all the details of the money. I had competent staff that worked with me. Actually, they helped me understand how this worked. But I always felt it was really important to understand how the money works, because you can start to use your money to pay for the change that you would like to see occur. I think it's important to find early adapters. There's always people out there that are interested in learning and changing and thinking differently about what we do. And if you can identify them and bring them on board, eventually the system moves ahead. Someone who is in an administrative position like I was, part of my job was to be the face of this, to be out there in the community talking about it, to be meeting with executive directors and saying, here's where we're going. What do you think about where we're going? What do you see as obstacles? Are you interested? Will you come on board? That takes a lot of work. So I think it's important to have very competent staff working with you that can do the actual implementation on a day-to-day basis. The other thing I think that we did very well in Montgomery County that I think is important, we set up a structure for learning. I had like a little think tank of consultants that I brought in, people that really knew what was going on in the country. And I think that is an important thing for your jobs in the future. You need to be able to keep your curiosity and passion alive. You need to look about you and see what is going on and bring in and talk to people who are doing different things in different areas. Am I doing okay?
Need to wrap up in a minute.
Okay, I'll wrap up in a minute. Oh, this is so unfair. I could talk for hours. So I'm passionate about this. I think you could be passionate about it. There are some areas of problem right now because I still work in the system 10 to 15 hours a month. I think one of the things that nobody talked about today are the jails. And the problem that we have with our system is that there are more and more people with serious mental illness in jail. In fact, the state is in the process of developing a 420-bed state-of-the-art forensic center on the grounds of Norristown State Hospital, which is a very helpful thing for all the folks that are coming into the criminal justice system. It is very sad to me that this is the story of our time, because I think what we need are centers of excellence, state-of-the-art centers of excellence in the community for everyone to have access to, so that this movement toward access to services through the criminal justice system comes back. I am the president of the Montgomery County Board of Inspectors, which means that we meet monthly. We oversee the operation of our local county jail. And one of our responsibilities is to go out each month and meet with people in the jail and talk to them about the issues that they have. I will tell you that jail is no place for a person with a mental illness. And I would challenge all of you. I would challenge those of you in administrative positions to go out on the street and see what is happening in your area, to visit programs, to go see where people live, to go to and get tours of your jail and see what these institutions are like. They are not places for people with serious mental illness. And those of you that work directly with people, I would challenge you to learn about the context of the work that you are doing. When you work individually in a place, you are working individually in a place, and that is fine. You're doing good work, but there is a context within which you work, and your voice at the table could be very helpful to making some of these changes. And so I had to get that in.
No problem. I appreciate so much of the wisdom shared by our panel. We're right at the end, and so I think we can squeeze in at most one question, I would say, because I know that our next speaker is already here. I'll quickly throw out to the audience. Is there anybody in the audience who has a question? Since many of our planned questions have been answered, or any questions in the chat? Click no to the chat. Any in the audience?
And we speak as a panelist in this.
Absolutely. Yeah. Questions for you.
So
Yeah.
I thank you, Nancy, for bringing up the whole issue of the prison system. We need to note that and keep that in the record of today's conversation. I wanted to comment also on Mark's comments about recovery. I think that it's important that we research it and study it, but I also think we could make it a little more simple too. And I remember when Catherine Powell was promoting this at SAMHSA, and it was a radical change in conversation from curing and treating to recovering. And it required a whole mindset. But we also talked about it as, let's get to be more like the rest of healthcare. Because we do talk about recovering from a heart attack. we do talk about recovering from surgery. Now, the way recovery is handled in other areas of medicine is not always good. Because, you know, there are other factors that come into play, financial and otherwise, as to whether or not rehab is offered. But the other important thing that's often missing is asking the patient what their notion of recovery is. What do they want to recover to? What do they want to come back to? So while in the broadest sense, I think, Mark, you nicely outlined all of these parameters. I think a simpler way to think about it is every time we meet with an individual, we need to try to understand with them what their notion of recovery is. What do they want to get back to?
Right. Thank you, Mike. I think we'll have a closing question and comment from Ken and then wrap up there.
So I think this is on. Just very quickly, you know, on the topic of recovery and part of the critique of recovery, I think is the notion that in the end, it does have this tendency to turn all of the responsibility and the possible of failure back on the individual. And we carry this as a very individualistically oriented approach. I'm wondering, Mark, if part of what you were outlining is a way to begin to think about how we think about people in their process of recovery, not being all alone, not being just themselves individually, but being part of a web. And that maybe that's the way that you're talking about this notion of inclusion that gets a little bit beyond where we've been. We could use the term neoliberal sort of focus on the individual and move towards some kind of sense that people are both like light. We are both particle and wave. We are both ourselves and we are part of something. And if we aren't both those things at the same time, maybe that's where we lose our capacity to think, is if we can't hold both those ideas in our minds at the same time. Is that where we need to go?
Yeah, but I would also say that the broader disability community has already gone there, even though it's not completely 100% effective. I mean, but yeah, we can go there. Other populations, other areas have already pursued that route and have been successful in doing this. We've been a little less successful in mental health so far.
Well, thank you, Mark. And I must say, it pains me to cut off this discussion at this point because this has been such just a rich array of experiences and wisdom you all have shared. And truly, I'd say the good news is that you mostly answered all of the planned questions I had anyway. And so I think we covered a lot of ground. So I want to thank you so much, Mike and Mark, for joining us by Zoom, and Nancy here in person. And we will move on to the next session on our agenda, but so appreciative of all you've shared about where we have come from and the vision moving forward based on that.
And thank you to our panelists as well. Really appreciate your moving the conversation along. I'm Lloyd. I'm here to introduce Jen Smith from our Office of Mental Health and Substance Abuse Services by this Psychiatric Leadership Council, which has offered over the course of 15 years fellowship experiences for 85 psychiatrists at a minimum, the majority of whom in community psychiatry have remained in our Commonwealth to this day. That has, having recognized the lack of Black and Brown people in psychiatric residency programs, decided a couple of years ago to start up a psychiatric residency program, learning collaborative with the directors, and have since that time involved the 13 psychiatric residency programs in Pennsylvania, and in fact have most recently shown a decided uptick in the number of people who are Black and Brown, who identify themselves as such, who are entering the psychiatric residency programs here in our Commonwealth. Not to mention now offering 2 meetings a week where we talk about how to improve that effort, and also then to find ways to offer things like training for the OMHSAS sponsored crisis workers who are out there training in the recovery model. It's kind of what the Psychiatric Leadership Council has been made to do, and we're proud to be able to be here today. And note that our next speaker is Jennifer Smith, who spent a few years as director, as actually secretary in the Department of Drug and Alcohol Programs. And you came in at a very common, smooth time, right? That was in total disarray, folks. That department was what I don't know how they figured out how to continue the operation. And Jen came in and she settled it. She found ways, even during times of ASAM, when everybody was going to sue you and everybody else for whatever the millions of dollars. And you took care of that and you stood up to it and you made it happen. And now you're our advocate in the Office of Mental Health and Substance Abuse Services. You have been there for the last couple of years under Governor Shapiro, and we hope to remain as such. OMHSAS Deputy Secretary Jen Smith.
Thank you for that introduction, and good morning, everyone. I am very conscious of the fact that I stand between you and the really delicious food that I have seen coming in slowly on carts. I'll also say that I feel as if I should have been here for the last hour and been participatory with that panel to talk a little bit about state hospitals and evolution and direction forward. So maybe some panelists I can chat with you at some point in the future about that. Lots to say. 30 minutes is probably 30 hours would be more sufficient, I think, to tell you all the things that are currently happening. So I'll tell you that today's presentation is not as information heavy as what I normally give. And that's because A, I had 30 minutes and I knew I was butting up against lunch. And B, because a number of you are already part of other groups or have access through folks like Lloyd and Deb to presentations that we give through other groups like the MAC, and you're part of our stakeholder groups and our listservs. And so I don't want to be standing here the half hour before lunch regurgitating information that you can hear through lots of other sources. Instead, I wanted to focus things a little bit differently today. So first, I'll just start by sharing in terms of background. Lloyd mentioned I did serve as the secretary for the Department of Drug and Alcohol Programs for about 7 years. That was my first experience in the health and human services world. So when I graduated from college, I have an accounting and an economics degree, and I got a job with the state as an accountant. And I did that work for about 8 years or so before I moved into some roles that involved strategic planning, communications, kind of higher level management, and then made a huge leap at the end of 2015 into health and human services with really no idea what I was doing or why I was doing it, other than the fact that I felt very called to missions work. And while I had always envisioned missions work, meaning you get in an airplane and fly to a foreign country and, help people less fortunate than you, the reality is there are plenty of Pennsylvanians right here that are less fortunate than me. And so public service really is missions work. So I took on the deputy secretary role there in 2015, and then in 2017 was asked by Governor Wolf to take over as secretary. And Lloyd mentioned the department was very, very new, so there was a lot of building to do. In addition to that, we were right at the peak of deaths from the opioid crisis. And so it was no small task trying to navigate my way in a new space. So here we are now in 2024. I have about 8 years of behavioral health experience under my belt, but still a lot to learn from a professional perspective. From a personal perspective, I am the mother of now 8 children. Our youngest turns 6 months old today. Our oldest is 25. We have several of our children with mental health challenges. We have one child with an intellectual disability, and we have one child with ADHD, autism, and a number of other behavioral challenges. And he's 7, almost 8. So I am no stranger to our behavioral health system as a consumer. And I will tell you that it gives you a very, very different perspective when you are both a policymaker and a funder and also a consumer of services. So I'm giving you all that as perspective for what I'm about to share here. So I want to talk, I noticed the agenda had sort of this theme of like past, present, future. So that's sort of how my slides are laid out here, where we came from. So I'm going to start with some fun. Hopefully you can see that picture. Who remembers a time when you wanted to travel somewhere and you hadn't been there before? And the only way to do that was to get out one of your really gigantic paper maps, or my dad had atlas books. Those were nicer. They were a little more manageable and they would zoom in on like certain areas. And then you'd have to get out the pen and paper, right? And you follow your finger right down, turn left on, turn right on, take route, 81 south. So you really had to kind of plan that out pretty well in advance. And then while you're driving, try to read your handwriting to get somewhere. And then there were these things called triptychs. And if you use triptychs, yeah, I see some smiles. So we would go on vacation in the summer and my dad would go to AAA because we are faithful AAA members and say, this is where we're going. I need a triptych book printed. And it was this nice kind of flip chart style book that took you turn by turn through to your destination with maps and then printed words that said, turn left, etc. And then a little more recently, we had these really clunky things that were very expensive that you could buy to plunk on your dashboard. Garmin made some, what was the name of the other? TomTom. Yeah, TomTom. And those were only for the elite people. Not everybody had one of those things in your car. This is where we've come from, right? Now today, where are we today? Today we are, set it down. I can, in a moment's notice, decide to go anywhere in the world and have a myriad of directions right at my fingertips, including traffic challenges and accidents and sometimes police, which is helpful in and of itself. We have come a really long way. And the reason that I'm pointing that out is because it's important to understand where we are in behavioral health as it relates to where we've come. And for folks who have worked in this field for a prolonged period of time, and I'm not really one of those people quite yet. I mean, I haven't even quite made a decade in the system. But for folks who have done it for a long time, because you see the change so incrementally, it is really important sometimes to stop and take a look back at how far we've come. Because it doesn't always seem like fast progress. It doesn't always seem like we've done enough, maybe. But when you have the ability to look back over your shoulder, you really can assess just how far we have come and give ourselves a little bit of credit for that. It also gives you the opportunity to look forward, and we'll do that in just a moment. So where are we in the behavioral health field? I will qualify this by saying I did not get Governor's office approval on this PowerPoint. This is Jen Smith's own rendering of where we are now. And the first and probably most obvious for many of you sitting in the room is that there currently exists this discrepancy between policy and practice. And a lot of that results from the post-pandemic era. There were many, many flexibilities, rules and regulations that were waived, payment requirements that were changed during COVID. And, we put the pedal to the metal. We accelerated our system to meet the needs of the people. And then all of a sudden, the end of the pandemic, public health emergency ends, and all of a sudden we're to roll back to what we knew before. And I mean, we're driving a semi here, folks. The behavioral health system doesn't stop on a dime. We're still moving, trucking. And all of a sudden it's like, try to pump the brakes. And the truth of the matter is we haven't really come to a stop where they want us to come to a stop. You know, there are still ways in which the system is sort of operating outside of what the actual expectations are. And so we're in this strange time of like trying to figure out whether we let the policy catch up to where practice is, or whether we really need to keep pulling practice back a little bit to meet where policy is. And it's this push and pull. Now, mind you, despite that push and pull, we are at a time and a moment, and I think I heard this in the last panel, where there is such great motivation right now. There are so many people that are excited about, interested in, and wanting to help propel the behavioral health field forward. And that is a wonderful thing. That is absolutely something we need to harness. Everyone wants to see the system move in a positive way. The challenge is, and this is where my next 2 bullet points are, that because everyone's so interested, it means that we're seeing lots of new opportunities for pilot programs, for testing out new innovative technologies and tools and strategies. And so it feels almost like there's a lack of real planning around that path forward. So we've got everybody interested and wanting to be engaged and ready to help, but nobody's quite sure what the best way to help is. And so we're going to put some money to try this thing, and then we're going to put some money to try this thing. And oh, well, that's going to be done in 5 years, so we can study that then. In the meantime, you know, we'll do this thing over here. And it feels very disorganized. And, you know, I'm saying that coming from federal grants coming down, state grants going out, counties going in, you know, 6 different directions. And it very much feels like we're trying to herd cats right now. You know, everybody has good intentions, but are we all rowing in the same direction on the same boat? Not necessarily. But I think we can get there. We need a little time, we need a little planning, and we need some vision setting, thanks to our last speaker talking about the importance of casting a vision. And then the last bullet point on here is certainly nothing lost on any of you, which is the fact that we've got pretty poor salaries for folks working in our field, on top of burnout that they've been experiencing both through the pandemic and as a result of this incongruence between policy and practice that's been going on post-pandemic. So, you know, we're at a place where it's getting tougher and tougher to get folks interested in coming in to the field. And I have children, 4 of whom are older teenager, young adult years, you know, so just starting to enter the workforce. And 2 of them were interested in furthering their education. 2 of them said, absolutely not, Mom. I am perfectly happy. One of them works at a quarry. And she had 3.9 GPA. She was an extroverted child. She loves working with children and older adults. And you know, as a mom, I had such hopes for what this girl was going to accomplish. And she drives a water truck at a quarry. She said, I'm satisfied. I'm satisfied doing that right now. And I don't have any student loans. It's really tough. It's tough to sell our field because it's a lot of work and it's a lot of expense. And the payoff isn't all that great from the perspective that they sit in, right? I mean, we now would say, well, the payoff is how we see people's lives impacted, right? Well, we can say that. When you were 18, 19 years old, did you have the capacity to think imagine what it would feel like to impact people's lives that way? No, you can't see that. So that's where we are. Where we're headed. If you can't see the picture, this is one of those self-driving cars, and the driver's got his hands behind his head. You know, he said, hey, Tesla, take me to Chick-fil-A for a sandwich and the car is driving itself. So where I'd like to see the behavioral health field headed, truly integrated healthcare. And that's a buzzword. Everybody likes to talk about integrated care. So let me explain what I mean by this concept of truly integrated healthcare. I am talking about a situation where services and providers are proactively brought to the individual who needs the services, and that's done real time. Cross-disciplinary teams, real time, based on a patient's needs. So for example, my father has heart disease, diabetes, he's overweight, he needs to have blood work done on a regular basis. Instead of him going to see 5 and 6 different specialists and having to get on all those wait lists to get in to see people, he goes to one appointment and those people come to him. And it doesn't have to mean come to him in person. You know, some of these services can be done through a telehealth means, but having doctors in the room coming to him, talking about what's needed, how increasing one medication might affect the care that he's receiving from another doctor. And that's across physical and behavioral health services. And I think that there's some movement to go there. You know, I mentioned earlier, there's lots of models being piloted. SAMHSA likes to put out these opportunities to try different ways of integrating physical health and behavioral health. And, you know, we tried, let's put some behavioral health in physical health places. Now we're going to try putting physical health in some behavioral health places. Concept, all good, but we still haven't really changed the way that healthcare is delivered and the way that we think about the delivery of healthcare. So this is where, you know, I have my consumer hat on as a mother of a young child who has to grapple with the education system, the physical health system, the world of psychiatry, case managers at the county level. And I am the one keeping all of those people informed about what's happening on a daily basis. So on the shoulders of the parent falls the responsibility of, well, Clayton took his medication a little bit late today, so that's going to impact these 6 things. And, oh, he had a bad day at daycare this morning. I'm going to have to let the teacher know that he had a bad day at daycare because that's going to affect his day at school, which then is going to affect his van ride home. So I'm going to have to let the van driver know that he had a bad day. And it is just this enormous burden that gets placed on the consumer to try to keep all of these professionals apprised of what's happening. And guess what? That takes a toll on the consumer. And now we've got another consumer to add to the mix. You know, now I need to talk to somebody about how I'm feeling and how it's affecting the way that I parent and my marriage, and the way that I interact with people in my workplace. So it is sort of this perpetual cycle of creating more consumers in the system because we haven't met the needs of the existing consumers. Sufficient investments to transform the system and funding models to support it. Again, this was touched on by the last panel. It's almost like we were channeling each other. Funding is a really difficult beast to tame. And that is true in any system. I mean, that's not unique to behavioral health. The challenge is that there's fewer dollars for us to talk about how they go round. The Medicaid system is extremely complicated. And, you know, truth be told, without some changes at the federal level, I don't know how we would build a model that would sustain the type of system that I'm talking about needing. You know, the idea of requesting specific state plan amendments for every unique service that you're operating and every environment that those services are delivered in. It's, I mean, it's counting widgets. And we have to get up out of the counting of widgets and look at really the success and the outcomes and the healthiness of people and use those as drivers. And then last but not least, a well-equipped workforce that's compensated appropriately. And by well-equipped, I mean, given the right training and given the right opportunities. We often are limited geographically in the types of populations we serve, or we're limited by the school that we receive our education in and the types of populations that school is geographically located with, or the organizations that we intern with that, you know, may be very specific to the area where we're attending school. And lack of this ability for people to grow outside of what they currently know. You know, and I loved the story about having been a worker at Norristown and sort of knowing this little bubble of what existed in Norristown. And I think my childhood was very akin to that. I knew the little bubble of where I lived. I knew the types of people that lived there, and they were all, frankly, pretty much the same. They all looked a lot alike. And it wasn't until I really started a professional career where I worked with people all across the state, all across the nation, all across the world that I thought, gosh, I was a sheltered child. I mean, I really did not have exposure to a diverse group of people. And that wasn't because my parents were trying to keep me protected in any way. It just was the circumstances of where I was at that time in my life. And I think that's really true of people who work in behavioral health as well. You know, you kind of get into one niche and you know that piece of the system, you know, those people you work with, those populations you serve. And I love the idea of being able to kind of step up out of that and think more broadly about what the system looks like and how you might be able to plug gaps in that system that you may not have realized you could fill. So the next question would be, how do we get to the where we are now, you know, versus where we want to be? And there's no good answer to that question other than we have to keep working together. We have to keep thinking creatively, and we have to keep pushing the system. I did, because I felt obligated to put something more than just pictures in my PowerPoint, include this slide that talks a little bit about one step in the right direction. This is by no means going to fix the behavioral health system. This is a drop in the bucket. But this is part of what the governor has included in his 24-25 budget proposal. This is not secretive information. It's all available on the governor's website. If you want more information about it, you can get more details behind what each of these things means. You know, you can see some significant continued funding in schools to address mental health, an increase to the county base funds, which is a really, really important funding stream, especially when we're talking about the idea of institutionalization and jails and, you know, how do we get our arms around this challenge of individuals with mental illness residing in locations that just aren't most appropriate for them. Those county-based dollars are critical in working to build county and community programs that can better serve those individuals. So I'll end with kind of one point that I hadn't originally wanted to talk about, but because the discussion from the session before me kind of led me there, I just felt compelled to include it, and I have no minutes left. When it comes to the discussion around institutionalization and state hospitals and capacity and jails, it's a really hard discussion. It's hard for me both as a policymaker and as a mother. Those aren't settings that I want to envision my family members participating in. However, there is also a great need for individuals who have really complex needs. And we don't have the community programs that can adequately serve them right now. And that's partly because we don't have the money to build those programs. It's partly because we don't have the workforce to staff those kinds of programs. When you're talking about building a program that has a 3-to-1 or 4-to-1 ratio, you've got 3 or 4 staff members assigned to one individual 24 hours a day. That's huge. That's really hard to sustain, both from a funding perspective and a staffing perspective. So I just always want to make the point that I don't think it's anyone's desire for individuals to reside long-term in a state mental hospital. That's not our desire, certainly. It's not the desire of my staff who treat those individuals and work with them and really come to see them as family members in some cases. But it is a sad reality of where we are. And I am very hopeful that we can see that shift again occur, where we can start reducing capacity at some of those facilities, where we start seeing the availability of community programming for those individuals for long-term stays in the community. That's my hope. But we aren't there today. So at this point, our state hospitals are a place where they are safe and they are not in the criminal justice system, so that at least we can assure they have access to the appropriate medication that they need and that they have access to some programming, some art and music therapy and things like that. So, I wouldn't be doing my job if I didn't take a moment to really appreciate the staff who work in those facilities. They have a really hard job, and, they get a bad rap because everybody likes to talk pretty negatively about institutionalization. And, there's good reasons for that. But we do have some really great staff that are working hard to take care of the people that don't have another place to go. And that's where they reside right now. So just a deep appreciation for my staff and for anyone who has worked in those facilities. It is a hard job. And I would like to say that, we've stepped into the current century. But the reality is we really haven't. When you walk on those campuses, it still is sort of like stepping back in time. It is its own community there. I will say one last note on a positive note. We are finally implementing electronic health records at all of our state hospitals, and that will be done next year at this time. And that has been a very long time coming. It's sad that that has to be an accomplishment, but it really is. And staff are working hard to get that done. So hooray for that. So Deb and folks, you're happy to share the slides. There's not a whole lot in there, but I do very much appreciate you giving me the time. And I know that food is awaiting you.
We do have a few minutes if folks want to ask questions. Maybe 1 or 2 we could take.
Just hungry.
Hello. So I have a million questions. I'm not going to ask them. I'm more so just going to comment. So I appreciate you coming today and speaking, and also showing a side of humility that I haven't seen as an emerging leader and really looking at leadership. And so I just want to let you know that I appreciate you coming today.
Thank
I
you.
appreciate the comments that you had. And you will be getting a card from me probably when you're
Sounds
walking
great.
out.
Sounds great.
Any other questions? Ken?
Nobody else does. So,
We can always count on you, Ken.
So I have, I'm gonna just ask one, but I do have two.
Okay.
Maybe I'll ask another one another time. Just I was saying earlier to this group that earlier this last week, I was on a telephone call with people from the state of Ohio,
Mhm.
where they were addressing an upsurge in the number of suicides in a particular refugee community
Mm.
that I actually work with in Pittsburgh.
Mhm.
But what was most striking about the conversation, besides the tragedy of that, was that the person who I was talking to was the head of the Office of Prevention and Mental Health Promotion in the Office of Mental Health in the state of Ohio. And I thought, I've never, ever had a conversation with anybody in the state of Pennsylvania that was from the Office of Prevention and Mental Health Promotion in the Office of Mental Health and
Yeah,
Substance
I like that title a lot.
So I just wanted to mention that as, I really don't like it when the Steelers lose to the Browns. And I especially don't like it when the state loses to Ohio.
Well, I have to say, my very, very good friend runs the behavioral health programs in Ohio. I have a really great relationship with her. So, and she is a really cutting edge leader in this space and quite an advocate for people in recovery as well. So it doesn't surprise me that she would have a department that is more focused on talking about the prevention and promotion. I mean, after all, my office on slide 1 still uses a really, really outdated term in its title. So I would love to get that changed. If you all are looking for something relatively easy to advocate to the General Assembly to do, a name change to our office would be really welcome for us, because I hate having to say the official title of it in public. It's actually kind of embarrassing. So if you're looking for an easy win, I like that. But I very much love that title. And I love that the importance is being placed on prevention, which I can honestly say our office probably doesn't do a good enough job of, and that's just me being transparent with all of you. I think we get very much caught up in the treatment side of things and workforce issues and emerging situations, and you tend to forget both the prevention and the recovery pieces. Those are the ones I think that are unfortunately easiest to move down the priority list. But those are two of the most important functions that our office serves. So I love that you brought that up. I'm going to write it down on my notebook here so I don't forget it as we start talking about reimagining the behavioral health system. Maybe we can implement some of those titles and programs in a more effective way. Thanks, Ken.
So we did have one comment/question online,
Good.
and this came in from Mercedes. Oh, I'm sorry. I apologize. This came in from Chris Peterson, and he was talking about resources are needed for primary prevention and early childhood treatment in the home and community, as well as schools. How can we help with that?
Oh, that's a great question. And gosh, I feel like I need like 15 more minutes. Okay, I'm going to try to be really quick. So on the slide where I talked about the governor's budget, the very first item there was another $100 million investment in mental health programming in schools. So this is a sustaining of $100 million that was put in the current fiscal year's budget. And there was a lot of outcry about the proposal, both for the current fiscal year and the new sustained proposal, saying, why are you putting this in schools? Why are we not putting this through the behavioral health system? Schools only operate, 9 months a year. What are kids doing to stay connected the other 3 months? And, I think that it's such a challenge, and it's so sad to me that we end up spending time fighting with ourselves about where to allocate the precious resources that we have, instead of having the abundance of resources to decide how to best allocate them. And so, the reason I'm bringing this up in response to that question is because our governor is very supportive of schools and counties and the behavioral health system partnering together to figure out ways to identify early, hopefully, children who might need these supports, ensure that they're provided in the schools where they can be, and to coordinate the community care using counties and providers to do that. So we have an administration that is very, very supportive of that approach. And it isn't supportive in a way that should take away from any of the rest of the system. This isn't about, well, you're taking monies away from counties and giving it to schools. No, this is about, we need more money in the system, period. And this is one item that we've chosen to fund and support because we know that schools are a place where we see children and that they often will be identified as having needs that extend beyond the behavioral health system, but that include behavioral health needs. So the ways in which you can be helpful is, one, supporting when there are initiatives like this coming out and, making yourself available to counties and schools to say, how can we help? What can we do? How can we partner? I think the other mechanism is to continue to advocate to our legislators and policymakers about the importance of developing the system. We spend a lot of time kind of advocating for really specific purposes. I want to see this one project funded. So, I'm going to go to my legislators and say, we need $5 million to fund this one thing. And I think we need to do a better job of educating folks about what our system is, how it works more broadly, and how the fact that you fund one part of the system can actually have positive ripple effects on so many other parts of the system. So instead of kind of grappling over, well, you should fund this instead of this, the request just needs to be, you need to fund behavioral health more appropriately. And then we make those things work across the system. I also think, and I think we have one more question, that our private insurance companies really need to start coming to the table to have conversations about ensuring coverage for our children. And I say that as a policymaker and as a consumer. I have children that have both private insurance and are part of the Medicaid program. And I have had more than one provider say to me, have you considered dropping your private insurance because you will get much better responsiveness and coverage if your child only has Medicaid? And that's a sad world that we live in. I'm sorry, go ahead.
No, Mary Ann Albaugh. I am a child and adolescent psychiatrist from Erie, Pennsylvania, and I very much appreciate all of what you've been saying. And I want to add a few points to that. And I also just resonate with that notion of motherhood and children in our care that have needs and how we wear those multiple hats. So I appreciate this conversation. I just want us all to think about kindergarten is already too late for many of our children. So really the place that we need to be at is -9 months onward. So how do we support families in this process? How do we value parenting, childcare? That time frame is so vital that by the time we see kindergartners as a child and adolescent psychiatrist, there are already traumas and disruptions and hurts in place and cementing. And then we tend to put them into paths that go to trajectories of externalizing into the juvenile justice system versus internalizing into the mental health universe. 100% agree with you on parity. How do all of us support this? I don't have specific answers, but I just would encourage you to include that -9 months to 6 years, and that we need to be looking at how do we get services, get interventions, get supports without a diagnosis. And so those are all things that I'm glad you're shaking your head and thank you.
Amen to that, without the diagnosis.
Oh, all right, get the last word, Dr. Niemark.
Of course, Jeff.
Hey, nice to see you, Secretary. Thank you for the presentation. Jeff Niemark from Community Care. I'm going to go in the opposite direction. While I very much value prevention and think it should be prioritized and resourced adequately, did want to ask a question about thinking of the folks, particularly the folks who need long-term, I'm going to say structured, potentially supervised care. And particularly something that's, I think, troubled me and others is thinking about what right sizing as opposed to downsizing the number of slots, beds, or supports we have for that cohort is, because it's real. I think to your earlier point, there are a lot of opportunities on how such treatment settings can be made more recovery oriented and proactive, but how do we really think about using sort of data and what's known out there to really think about how many, how much we need at the sort of state hospital level, at, our LTSR or CRR level, because I think we've adopted more of a philosophical position than an empirical one when we've come up with those numbers. And I think we need to continuously be evaluating that right sizing, I'll say.
Yeah, I think the key phrase is you said, what we know. And I'm not sure we know what we know. So there's lots of data being collected and reported, but not in a way that's comparing apples to apples, especially in the population that you're talking about. So we've got extreme challenges with the dual diagnosis population, specifically IDD and MH, where we've got, folks in state centers who, are really challenging for the staff there. And, staff would really prefer that they come to a state hospital, but we don't have the capacity at a state hospital to handle them. We've got wait lists at some of our facilities. Then we've got South Mountain, which is a long-term restoration center that has every bed filled all the time, essentially. We've got older adults who are living in various types of long-term facilities that are not behavioral health focused facilities and not receiving the behavioral health care and treatment that they really should be. But it's difficult because we don't have our arms around what that population actually looks like. And then you add that to the funding discussion of how do we pay for those services being provided in those settings. And that's been a little bit of a challenge for some of these facilities who really are trying to provide the right care, but can't figure out how to staff it and how to get it paid for through the Medicaid program. So I'm not sure we really have a good handle on what the needs are across the system to be able to identify what that number is for a right size. I think that is absolutely a challenge. So if you're volunteering to do that study for us, Dr. Niemark, I would take you up on that.
I agree. I think there's been the apples to apples part has been a real challenge. I know the American Psychiatric, there's been a lot of work at embeddedness and how to compare these different categories. So I'm happy to coordinate in any way possible on it, but I think
I'm signing you up to do it.
Okay.
No, I think it is important. It is important. And we haven't done it in the way that we need to.
Well, I just want to take a moment again to thank Jen for coming and speaking with our group. So Jen, I think you'll probably find lots of people who would be willing to partner with you on various things. So you're in a room of very knowledgeable folks who could certainly dig in. They're ready to dig in and help for sure. So we are at time for lunch. Our lunch is cut just a little bit shorter because we have had such wonderful presenters this morning. So our program will resume in about a half an hour. So please take some time to get yourself some food, to talk with each other a little bit and network. And we will see you back here at 12:45. Moving into the
this behavioral health program that's managing the behavioral health program for 24 rural counties in Pennsylvania. She studied at the Penn State University, where she studied nursing and began her career as a staff nurse on an inpatient psychiatric facility in central Pennsylvania. She's worked in program development for community-based behavioral health programs, including an outpatient behavioral health, mobile crisis, and community residential rehabilitation services. In the past, she's been a state director for behavioral health services for ViaQuest Behavioral Health. Right now, she is working with her team and members of the counties to develop a responsive, member-focused behavioral health services system across those 24 counties. Welcome, Sally.
Thank you.
All right. Next, we have Kat Fieser. Kat is a licensed social worker, and she received her MSW at Edinburgh University, right near Erie. Yeah, wonderful. That's my stomping ground. She is currently working at the University of Pittsburgh in their Program Evaluation and Research Unit, Peru, and implementing strategies to coordinate overdose prevention efforts in 4 counties in Ohio. She has numerous certificates from the Pennsylvania Certification Board and sits on their board of directors. She's actively working in behavioral health care since 2012. She's been training individuals, and we've talked about the workforce needs. This is a very important area of our efforts. So she's been training individuals in the state of Pennsylvania and across the nation since 2014 with PMHCA and other contract positions. She's a expert in the subject matter expert in multiple state level initiatives. And in particular, she's been assisting individuals who are providing life-saving care and with evidence-based and informed knowledge, skills, and strategies, looking at best practices and an effort to diminish public harm when we look at those areas of need. She's an advocate for peers and looking at how do we develop and deliver public and behavioral health services. So welcome. And last but not least on this panel, talking about the community and current state of affairs is Wes Sowers. He's a graduate of Brown University and Northwestern University Medical School, completed his residencies at Cook County Hospital and Albert Einstein College of Medicine in the Department of Psychiatry. He is currently the clinical professor of psychiatry at UPMC and director of the Center of Public Service Psychiatry at the Western Psychiatric Hospital. He serves as the medical director for the Pennsylvania Organization for Women in Early Recovery and as a consulting psychiatrist at several community mental health agencies. He is certified in adult psychiatry with a subspecialty certification in addictions, as well as administrative psychiatry. I didn't know this part, but he served medical director of Office of Behavioral Health in the Department of Human Services in Allegheny County for 10 years. 2001 to 2011. A longtime member of the PPLC, as well as a member of the Association of Community Psychiatrists, where he is the past president. And he's a board of directors of the American Association of Psychiatric Administrators, as well as a participant and member of the Group for Advancement of Psychiatry. I can go on. He is the chief editor of our new textbook on community psychiatry. So welcome. And I'm going to stop and let you all get started. And we're just going to go down the line here. And so, Sally, you have the floor.
Thanks, Marianne, and thank you everyone for inviting me to speak today. As Marianne said, I work for the Behavioral Health Alliance of Rural PA. So just a little scope about the counties that we represent. 24 rural counties, starting at Wayne County, coming across the northern tier with the exception of a couple, Lackawanna, Luzerne, Susquehanna, those are not ours. But then we go clear over to Warren, and then down to the southwest corner to Greene, not covering all those counties, but Greene's one of our newer counties. And then southeast, we go as far as Schuylkill County. So with lots of the counties in between. So when I speak to you today about what I see as challenges and opportunities in our community mental health system, I'm speaking from the rural perspective. I think we would find if we had conversations and had rural, urban, and other areas represented that there's a lot of similarities. We used to think that there were some distinctions, but I'm not so sure about that. Maybe in a couple areas, but I think we all have some similar struggles or challenges, and we all have some similar great opportunities. Let's start with some of the opportunities because I'd like to start on a positive note. And we heard Deputy Smith talking earlier, and I think that having the strong leadership that she brings to the Office of Mental Health and Substance Abuse Services will open up an array of opportunities for all of us across the state. We've been in conversations with the department around flexibilities with staffing waivers and the ability to develop some innovative programming. And so I'm very hopeful that moving into the next couple years, we'll have more opportunities to look at, while these services might not specifically meet our need, how can we tweak them to do that and get some leeway from the department. Also, I think one of the other opportunities was some of the changes brought about by the public health emergency and some of the leeway we were given with telehealth and telepsychiatry. This obviously was a great opportunity in the rural counties to reach more members and reach them in a more timely manner, simply because our biggest barrier has always been and will continue to be transportation. So how do we get our members from their home to our clinics, or how do we get our staff from our clinics to their home? So that continues to be a challenge. But certainly telehealth, and now looking at post-pandemic and the public health emergency ending and some of those flexibilities going away, really having those conversations with the department about how can we stretch this, what can we keep, and what do we absolutely have to give up? I think many of my providers would say right now they're struggling with some of the information regarding the 4 walls rule. So if you're a licensed clinic in any area, let alone the rural areas, you either have to have your clinician at the clinic or your member you're serving at the clinic. And this, of course, was suspended during the pandemic. So we were really able to go out and go into the community with telehealth and do telehealth in a variety of ways. So I am optimistic that some of the workarounds for this rule, the CMS rule that the state's talking about, will give us some more opportunities for flexibility with telehealth. They're looking at doing some things with the mobile mental health bulletin that'll help us significantly overcome this challenge of needing to have somebody in that clinic site, and also looking at is there potential to develop a new service under the rehab model. So very excited about those prospects, and will continue to be part of those conversations. In addition to the challenge of transportation, I think I have to mention the workforce challenges. And at BHARP, we have experienced those workforce challenges across our provider network, which has led to decreased accessibility for our members and utilization of services. We did do some planning and put some funds on the table to do a couple of projects that we think we're starting to see a little bit of progress in these areas with higher utilization. One was a behavioral health higher education program that we're doing now, where we essentially will pay for the last full year, senior year, for baccalaureate degree students. And in return, they will do an internship in one of our providers across our 24 counties. And we will, they will then be hired there at that provider organization. So we really were looking to the state to come in and do something meaningful, I think, around tuition reimbursement and supporting individuals that do want to get a degree in a field that puts them into our human service agencies. But we simply couldn't wait anymore. We were at a crisis point across our rural counties. The other program that we're doing that I think has netted a lot of attention is our provider workforce and development, or our network enhancement and stabilization. And this is a reinvestment plan. And in this plan, we had 33 providers step up willing to do a data collection process for us. And the data points that they're collecting are all related to their staffing. So how many of their positions that they have are currently staffed, how many are open for longer than 3 months, longer than 6 months, longer than a year, collecting a variety of data points in a way that allows us for the first time to quantify what we mean when we say we have a staffing shortage. I think we all have talked about the staffing shortage. We all know it's there and it's real, but not everyone responds to our anecdotal information. And we tend to speak with feelings and emotions and get very heated about this. And so it was way past time for us as an organization to try to collect some data points and really be able to illustrate this. And I will say those data points really did prove out all of our emotion and our feelings around the staffing crisis. We started that data collection process with these providers that were willing to do it. We engaged them in what are the data points that are important to you? What are the data points that are important to us? How do we look at that? How do we benchmark our data points with other industries? And we put together a rather comprehensive data collection process that continues now to this day. In addition to the data collection, we provided dollars for each of the provider organizations that were interested to develop plans around recruitment and retention. So how were they going to address their individual staffing shortages? And I'm here to say that they did a great job, our providers, and they did some very innovative plans, and they're starting to see, again, some results for their efforts. So we started with less than 70% of the available positions staffed, and we now have gone over that 70% mark. So we're happy about that over a series of 2.5 years. So starting to see some daylight there, starting to see positions that aren't open for a year or more. We did those positions and divided out that data by position type. So we looked at community-based workers and family-based. We looked at community-based workers and IVHS. We looked at clinic-based workers. So we've stratified that data in a variety of ways. And there certainly are some positions that rise to the top as being most difficult to fill. I think one of the other things that'll come as no surprise to you, and certainly the Deputy Secretary alluded to it, is our rate of pay for the workers in the behavioral health field. We benchmark that against other industry, and I'm here to tell you that a delivery truck driver can make more than a master's prepared person in some of our programs. So when we talk about return on investment for students, as Deputy Smith did, right? What's in it for me to go into debt for student loans? What's going to be my net return on this? I'd love to say that we have a really, I think, altruistic population coming up out of high school and into college now, right? These kiddos want to change the world, want to see things better, but money still plays a role, I think, in some of those decisions. And when we're lagging behind delivery truck drivers and plumbers and those types of things with rates of pay for master's prepared people, it's pretty hard to compete. So, but I do think that our data showed that if we do some focused efforts, right, really talk to the individuals in the behavioral health field about what's important to them, we can kind of turn that tide a little bit and at least attract more people here. I've said it before when we've talked about these issues. I think given the population or the generation that's coming into colleges now and their desire to do good things and change the world, that we clearly have a PR problem in behavioral health, because we would be nicely matched with those aspirations of making people feel better, helping people live better, that I think we see in many young people today. So I think that in the next couple years, one of the challenges that we face in rural counties is certainly capacity and the number of members that are available to utilize the service and choice. So I'm all for choice. I want choice whenever I have an issue that I'm going to seek medical attention for. But we also have to be realistic about what is our ability as a community to support that choice. We tend to end up with one large provider providing several services across the continuum of care, and always kind of worried about what happens if this provider isn't here, like where do we go next? So in our rural counties, it is not uncommon to see that one large provider and then some fill in with smaller agencies. We're always talking about what should it look like to have capacity to serve the membership. Dr. Niemark, through his work with Community Care, has been working on that now. How do you measure network capacity and adequacy? When do we know we have enough providers? Will we ever have enough providers? All those questions. So that is a challenge for us that a lot of times our counties feel as if their eggs are all in one basket. And while we support those providers, we also want to support choice for our members. And we want to have a stable system where if one piece of that falters for whatever reason, we can still continue to serve the members that need services. So I think that that is a challenge for us, how we balance choice with an adequate network that we can sustain financially and that's ready to meet the needs of our members. Moving in over the next couple years, I think if we can continue to do the work around workforce, right? How do we attract more young people to the behavioral health field? How do we help them finance a college education? How do we help them get into the agencies and organizations where we need them the most? I think if we continue to do our work there and can continue to see some progress, although small, that'll be a good thing for our rural counties. I think the challenges around transportation, I've been at the table to have these conversations. There is no public transportation. There's no Uber or Lyft or anything else in many of my counties. So we have to talk about how you begin to develop some kind of community responsibility around how do we help people get to appointments, or how do we get to people for appointments outside of clinic settings. So I think that is my comments. I can turn it over to Kat if she wants to talk a little bit about her perspective, and I'm happy to answer any questions.
Yeah,
Sally,
awesome.
go for it.
Thanks, Sally. Is that working? Can everybody hear me? Yeah,
Yes.
awesome. All right. Thanks. So Kat Feeser, I just want to say, like, I've been blown away by the information that I've heard here today, and, you know, by the vision, right, that everybody has been sharing, and kind of going back and forth in my head, and, you know, doing that internal dialogue as I was sitting back there sharing with Katie, like, you know, what do I share? And because I think I do a lot of different things, and training is probably one of the most impactful parts when we look at, you know, mental health work within our communities, and primarily training peers, right? So, and my favorite would be with Pennsylvania Mental Health Consumer Association, the forensic peer training. So that's where we focus on individuals with serious mental illness or substance use interfacing with the criminal justice system, and ways that we can intercept them and divert them from the criminal justice system and into services, right? So we know that individuals move through our criminal justice system, right, in a very sequenced way. So that's what that training is developed for, is for certified peers or certified recovery specialists throughout the state of Pennsylvania to learn in a unique way to work within these systems, not against our systems, right? So to work with all our stakeholders that are around to pair with them and be able to identify, right, individuals that would benefit from services. So why did this work become important to me, right? How did I get involved in it? You know, being an individual that spent, you know, the ages of, you know, 19 to 31 going in and out of incarceration, and never being offered, right, a diversion program or an intercept, or having a professional say to me, you know, what happened to you? right? What's going on? What was the precursor, right? It was always the mental health or the substance use, right? It was always the fact that I was the problem, which I believed for, I would say, a very, 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 very long time. And I loved the conversation earlier when we were talking about, you know, the definition of recovery, right? Is it the particle or the wave? And I would say that it is a 1000% social connection. It is a community connection. Every single person that I've come in contact with, family included, has benefited from the fact that I've entered into recovery. There's no doubt about that, you know? But it was, you know, my first interaction was at the age of 16. I grew up in a home that lacked emotional wealth, spiritual wealth, mental wealth, physical wealth, you know? There wasn't attachment, there wasn't encouragement, you know? There was despair, there was substance use, there was generational trauma, you know, there was pain. And the only way that I knew how to express that was externally. So even through multiple interactions in education, teachers, counselors, juvenile probation, you know, 172 extended detentions the first time I got put into juvenile placement. Nobody ever said, is something wrong? Sorry, I'm getting a little emotional. I was worried about doing this. My mom had just passed away. So I was like, I'll probably get emotional. But the point is, you know, I had run away. My mother and I had gotten into an argument. She had busted my nose. I walked out the front door. I went to work the next day. The state police came, took me home, and I was identified as a runaway. I didn't run away. I walked out the front door to stop being abused, and I got put into placement. That was the trajectory of the rest of my life. You know, all behavior is a form of communication, right? I would look back and think to myself, why didn't I ever ask anybody for help? I did. I was screaming for help. It just wasn't the words that came out of my mouth, you know? So I went in and out of prison for years. Got out in 2006, you know, got pregnant. I had like a 3-week furlough, we'll call it. Got pregnant, had my daughter, Karma. My brother passed away from a car accident while I was in prison. They threatened to put me on suicide watch if I didn't allow them to tell me over the phone. Like the piece of paper was sitting there and it said my brother's name, coroner's office. So a complete stranger had to inform me my brother was deceased. And their solution to that and emotional well-being and care in our institutions is to place you on suicide watch, where you have no connection to anybody. So I had to let a complete stranger explain that to me so I could go downstairs and have access to phones. And I got out and I tried to keep my life together and I couldn't, because that's how I learned how to cope and continued to use. They raided my house and took my kids. And this was the first time they ever offered me services. So I took an alternative to state prison sentence. My certified recovery specialist saved my life. He said to me, you have to go to a meeting, and I didn't want to go to meetings, so I agreed to go. And he offered me hope for the first time. He said to me, I used to be sitting right where you were. And I was like, what are you talking about? He's like, I did the same things you did. And so I was like, okay, maybe I could change my life. And I did. I'd gotten my GED in prison, so I went to, he signed me up for a certified recovery specialist training. I didn't have a driver's license for 3.5 years. I got a ride back and forth to every training. I started working where I went to treatment. They didn't allow people to work there that had criminal records. So they changed the policy, and I was the first person to ever work there that was actively on probation or parole. I completed my alternative to state prison sentence. The judge put her glasses down and looked at me, and I said, it's okay, Your Honor. I'm just as amazed as you are. When she completed it, because when she sentenced me, she said, when you come back in front of me, you'll be going to prison for a very lengthy amount of time. And I believed her. I believed her. And I got custody of my kids back. It took over 2 years, but I got them back. My oldest daughter didn't want to come back because she lived through all the misery of my use and my mental health. I got her back. She came back. She went through 2 years of her own, internal and external struggle with her mental health. 5 institutional stays. I call it the dark period of my recovery. 2 of those were diversion and stabilization. She had a big bout with self-harm. She wanted to end her life 5 separate times. I lived in a home with sporks and no knives, and carried, she's like 5'11", carried her into the ER, begging doctors to put her somewhere safe, and they wouldn't. 4, 5 times, and it wasn't until her last day that she got appropriately diagnosed and medicated. And now she has been free of self-harm for 3 years. Just had her first baby. She's 14 months old, and at her follow-up for postpartum, they did not screen her mental health. So why do I share all of that, right? Why do I talk about all of that? Every single intercept, 0 is community, right? Prevention, education, making sure our kids know. My youngest daughter's 17. She just won the state national. She's going to nationals for the family, communities, and charities for Pennsylvania because of the work that she does in our community. That's one wave, right? I tell her all the time, she sucked all the nice out of me. She does it because of what we lived, but now I implement the first intercept as law enforcement. Second is initial courts and hearings. 3rd is big court and jails. 4th is reentry. 5th is community corrections, right? We can't stop the fact that we have individuals with mental health and substance use, right, within our criminal justice system. But what we can do is we can put individuals like me and like you in the places to assist them and help them now, right? And help and make sure they don't re-enter, right? And help and make sure that they're not going in there at a faster rate of speed, right? I needed somebody like me, and somebody like me made it. I work at the University of Pittsburgh. I train first responders how to have a compassionate response to an overdose scene. So they call 911 again, right? So thank you. I apologize for getting emotional.
Oh, Kat. Thank you for sharing. And I want to let you know that we'll pick this back up. I'd like to hear from Wes. And I have some thoughts about what you've shared, so I appreciate your courage. Thank you.
Yeah, thank you. It's a little bit difficult to follow that. But I think it sort of illustrates one thing that is really incredible, and that there are some people that manage to be successful despite the system. And, you know, we've heard a lot, I think, of things that are, that have really been positive about the evolution of self-care and of healthcare, but also some of the obstacles. And, you know, we've talked a lot about systems and larger systems and how we get those to change. And those are pretty difficult and slow processes. So I want to talk just a little bit about some of the issues that have really prevented many of those interventions from being successful. You know, and we know, you know, that when we look at the health of our communities, all these things haven't made things much better. To be honest, you know, when we look at the indicators most commonly used to measure mental health, such as levels of substance use, suicide, homicide rates, violence, levels of emotional distress, they're all generally much worse in the United States than they are in other places. And we've heard a lot about the crises that we've been in. Pennsylvania is probably a little bit better than most states in many respects, but it's not dramatically different than a lot of the problems that the country have, we also have here. And so we now know most of the things that we need to do to stabilize mental illness and prevent, you know, some of the conditions that cause it. But we really lack the commitment to providing resources and systems to support them. So I'm going to start just by talking about a few things that stand in the way of really helping those things to do the jobs that they need to do. And then kind of end up with talking about some different kinds of solutions that we might think about. So, you know, one of the main things that is a hindrance in our system is fragmentation, right? We don't have continuity between different service providers and different levels of care. And we don't really have a system of care. We have you know, systems that are disconnected and often kind of work in opposition to one another. That diminishes our ability to communicate, provide continuity of care and coordination, and it also creates a lot of redundancy and inefficiency, particularly when clients are involved with more than one system or over time. Financing is another issue. Most publicly funded mental health treatment providers struggle to stay afloat and provide quality care in the process. Fee-for-service financing is kind of a rigid system that really incentivizes quantity over quality. And since there are defined billable activities, it really reduces flexibility and creativity in terms of meeting client needs. The healthcare business. In the US, healthcare is largely organized around for-profit businesses, which means profit often takes priority over outcomes. And that means that resources are diverted from providing services. And one of the products of all of these things is administrative complexity. So the US spends about 3 times as much on administration as other developed countries. Ironically, managed care organizations were designed to control costs, but in many ways, they've actually added to the expense through utilization management and billing procedures. And we still manage to spend almost 20% of our GDP on healthcare, at least twice that of other countries. and about a third more than 25 years ago. And once again, we don't get anything back on our return. Our health statistics, mental health statistics are much worse than other countries. Technology is another issue. You know, we can say that there might be some good things about electronic medical records in terms of storage of information and maybe billing, but it hasn't reduced fragmentation or enhanced information sharing. And on the balance, it's been more of a hindrance than a help so far. It's increased the documentation burden on clinicians and reduced the time available to do actual clinical work. The workforce is another thing. All these things have an adverse effect on our workforce, as we've heard, both for psychiatrists and otherwise. And it's especially true in the public sector where demand is high, resources are thin, autonomy is limited, and compensation is low. Provider agencies require high productivity just to stay afloat. And the workflow is often difficult and inefficient. Regulatory requirements add to administrative burdens. And the net result is low clinician satisfaction and an exodus of mental health professionals from the public sector work. Burnouts become something that we're all very familiar with. So all of these things have a negative impact on the psychiatric workforce. The contraction of the curricula and psychiatric training toward biologic interventions has reduced the scope of psychiatric practice and really competence. Psychiatric practice in the public sector is seldom more than medication management. And even if there were time and resources available for psychiatrists to engage in other activities, such as therapy or supervision, they are no longer trained very well to provide it. The other issue that reduces our effectiveness is that we're trained to focus on illness rather than health. And we've heard a lot about prevention and health promotion, and we don't spend enough time with people doing that work. We also live in professional silos with limited perspectives on how we can meet demand and expand our capacity, and with few opportunities to build collaborative relationships with other professionals. And we're conditioned to think of shared roles as a threat rather than an opportunity. So these are all these negative things that I've been able to come up with and kind of throw some water on the fire that we all have burning. But it almost feels like, we need to redesign the system. But, politics, we've heard a lot about today really kind of get in the way of that. And so part of what I wanted to do is think about what we can do and what we can do easily. We're not as powerless as we feel sometimes. So we have to resist the urge to just kind of give up and acquiesce to the system. So first of all, if we look at our profession, we have the most control over what we do individually and clinically. So psychiatrists and all clinicians can use more time with our clients to address self-care, and whether that's sleep hygiene, nutrition, habit control, or exercise, whatever the case, help people to manage illness better. I think we talked a little bit about recovery, and I think that is somewhat distinct from recovery-oriented care. And sometimes we don't make that distinction, but however people define recovery, we can do things to help them get there. And that improves our relationship and causes greater investment in service planning and better ability to move forward. Medication management is another area that we can spend more time on: education, simplification, and cost-conscious prescribing. It's too often that we see people on a boatload of medications that are ineffective and irrational. And so we need to understand, and our clients need to understand that all distress is not necessarily pathologic and that more medication is not always a solution. Diagnosis is sometimes comforting to individuals, but overdiagnosis and overtreatment with medications are just too common. And there are other ways that we can be more efficient. Group treatments are rarely used by psychiatrists today, but they provide not only efficiency, but greater insight into our clients' personality and relationships. And unfortunately, most programs don't prepare psychiatrists to do that very well today, which leads us to another piece of a critical element for change, and that's how we prepare our workforce. The demand for psychiatric care is much greater than the supply, and that's not going to be changing anytime soon. As many of us with gray hair are aging out of direct service. And even if we increase the number of training slots available considerably, it would take a very long time to meet the need with psychiatrists alone. So as mentioned earlier, I think we need to expand psychiatric skills beyond medication management. We really don't need 4 years to teach people to write prescriptions. We could and should be able to train psychiatrists to provide consultation, supervision, develop individual, family, and group therapy skills. We've attempted to do a little bit of that with our fellowship programs, but our graduates are relatively few. And most of this has dropped out of standard psychiatric curricula. And they're critical skills if we hope to shape better systems for our future. We also need to think differently about our relationship with other mental health professionals, we psychiatrists. We need to support alternative prescribers if we hope to meet the needs of communities. We have to have transdisciplinary training experience and the incorporation of diverse types of mental health workers in our teams and our service plans. And those things would help expand our capacity. And it would begin to break down some of the silos in which we reside. There's also systems change that are probably beyond what we can do as professionals, but on an administrative level, there are many things, many of these problems that could be addressed and that mental health administrations have the power to change. We can reduce communication issues and enhance continuity of care by establishing uniformity in our service intensity assessments, treatment planning, documentation, and medical records. Moving away from fee-for-service financing would reduce administrative expenses significantly, with the elimination of need for complex billing procedures. More all-inclusive payment arrangements would make it much easier to compensate providers. Also enabling providers to assume a greater share of the risk would reduce administrative expenses by payers eliminating some of the utilization management that's needed and diverting more resources to treatment. Technology has the potential to reduce the administrative burden rather than increasing it. A uniform medical record that is clinician friendly would be one measure that would be helpful. And some AI applications are really already capable of reducing some of the aspects of clinical documentation and allowing clinicians to spend more time with their clients. So those are some of the things that need to happen. The American Association of Community Psychiatry has developed an instrument that incorporates several of these solutions. Some of you have heard me talk about LOCUS before, the Level of Care Utilization System, which is a service intensity tool that uses 6-dimensional ratings to recommend placement in one of 6 uniquely defined levels of service intensity. LOCUS is designed to be simple and intuitive, allowing client participation in the assessment process, facilitating the therapeutic relationship. And it also provides a platform that allows integrated workflow, mitigating the burden of documentation. It can replace complex medical necessity criteria sets with a clinical tool that not only guides service intensity decisions, but provides clinicians with a clear rationale for those decisions, potentially reducing or eliminating the expense of utilization management. A broad implementation of this instrument enables easier communication and continuity of care between providers. Quantified rating system allows data collection that tracks the individual course of illness as well as the system strengths and weaknesses. Locus will also facilitate rate setting for per diem or episode case rates, simplifying the way that providers get paid. And in addition, the uniform objectified scoring system reduces the impact of bias in decision-making and hopefully ultimately reducing health disparities. So, that's just a thumbnail sketch of this instrument, but it is an example of something that's easily implemented and could have a significant impact on both the quality and cost of care. There are all these larger systems issues too, in which, really political solutions are required. Things like harm reduction, decriminalization or legalization of substance use, actual corrections in our penal system, provision of housing and nutrition to impoverished communities, the elimination of childhood poverty and food insecurity are all good places to start. But again, require action and many of the advocacy activities that we talked about earlier, and they're going to be slow to change, and they're difficult to find unity in a very fractious kind of political scene. So those things have to take place on a political level. Public education may help a little bit with that. But we can really take solace in the knowledge that there are many things that we can do to eliminate some of these problems in the meantime that don't require collaboration with people who have distinct values. So I will stop there.
Thanks so much, Wes, and actually to all of you. And I'm gonna look to open the questions and discussion up. I want to first thank all of you. I think about Sally, your point around data collection around the workforce to make sure that it's not just our emotional gut level feeling, but that this is what it is and we need to do something about it. And having that innovative thinking and then tracking, is this helpful or not helpful? I appreciate, Kat, you're helping us see all of the spaces where we have opportunities to do a much better job in how we care for folks. I am reminded of one of the fellows that I've worked with a couple of years ago. She was a nurse working in a Erie County jail system. And a project that she worked on was to screen for 3 months inmates that came to the mental health clinic inside the jail with an ACEs screening, adverse childhood events screening. And in that data, what we saw was there was no one with less than a 4 out of 10. And there were some that were more than some with 8 to 10, hitting all of those ACEs screenings. And what was very important, and to your description of the experience, no one along the way was asking what happened. And so you get to an age where you are in this chute that you can't get out of because we are not paying attention to those intercepts. So I think my question is, how do we pay attention to intercepts? in the current state where we are stretched. And I think it does speak to how do we train folks? So thoughts about how do we look at intercepts? And this is really for all of you.
I guess I would just say that one of the things that we don't do is we don't train our professionals as well as we ought to understand these systems and why they work and why they don't work. And, you know, I think it really is important. We talked a little bit earlier about the importance of understanding financing. And that's really true just from a political point of view, but until we have enough people who do that and understand that, we don't have really the opportunities to form coalitions to really make for effective change.
My next question has to do with thinking about the current way in which we interface with family systems and thoughts about where we might have wins, where are opportunities to manage that better. Because I think for me, the challenge is the disconnect for folks with struggles in mental illness and the family systems and how we either support or not support that whole process, because you can't do it in isolation. Any wins along that? Or is that an area of need?
Yeah, I mean, I'll say, I think there's definitely been some wins, right? I think there's been a focus on not only peers, but family peers, right? Like families have lived this too. Families are getting louder, right? They're speaking up, right? That like, this is my lived experience as well. You know, I think helping families navigate systems, right? I think helping families navigate interactions with their loved ones, right? Like you even heard Jennifer say today, like just saying like, I have to call this, you know, it's a cascading event, right? Like one thing happens and you have to call here and you have to call there. And, you know, and as Wes was saying, like medication, you know, does medication follow through happen? You know, I had that with my daughter. She would come home and she would stop taking all the medications, and there wasn't that small conversation like, she's not going to take this medication because it makes her gain weight. And she's not going to take that one. So there has to be a different medication, right? To even have that conversation of whether she's going to continue to take it when she comes home from the hospital. And just real, like, what have you been successful on before? Like identifying strengths within the family of, I've seen somebody be successful, you know, when they have been taking this medication. My daughter and my husband would not survive if it wasn't for me when it came to antibiotics and high blood pressure medication. They're both just absent-minded when it comes to medication, right? I'm the one that's very organized, and you have, you know, reminders and these are your things. So we can find a lot of value and strength in our family members that are within the home that are diligent and regimented and helping our loved ones succeed, right, when they transition. Also knowing, you know, when they see warning signs, right, that sometimes we're not aware of, you know, maybe being a little bit more distant, you know, less communicative, right? Especially if we have very high highs, very low lows, you know, being aware to say like, maybe you should pick up the phone and schedule an extra session, right? You're down to seeing your therapist, you know, your psychiatrist once a month. Maybe you should, you know, uptick it, right? I'm really big on doing that with my daughter. I was like, when was the last time you talked to Julie? Like, I think maybe you need to reach out to Julie, right? So family inclusion is definitely beneficial as long as the individual wants their family to be included. I always like to add in a caveat, family can be toxic, right? So I really like to encourage somebody to know that they can identify their family as people who enlighten and empower them, not people that harm them. Sorry, go ahead.
No, and safety, I think, is important, and it speaks to thinking about how do we look at the whole system and where are the hurts and how can we help support and heal? And that might look different and in a different space and pace
Yeah.
for everybody, that everybody is down, aligned always.
I want to go back to Kat's comment about navigation and assistance and support, because I can't stress enough, we're just now looking at developing 2 family navigator programs, and the implementation and development of these programs was driven by the need to have somebody whose only job is to tell families what that means. And I'll give an example. I accompanied my 81-year-old mother-in-law to her family physician last week, and the doctor would talk and then I would interpret. And the doctor, I was trying to hopefully subtly say to her, can you speak in plain English that an 81-year-old woman would understand? Because she didn't. But then I think about us, we don't even speak in a language that sometimes other college educated people can understand, right? So I think having people there whose sole purpose is to say to the family, this is what that could mean for you. This is what you might want to expect in this type of meeting. This is how we can prepare you. Let's put together a document that talks about the important things you want to make sure everyone around the table knows. Let's keep a med list, a history thing current. Let's make sure that when we go in, we're presenting our story and there aren't assumptions made, right? Nobody asks you what happened to you until when.
Yeah.
Because I think sometimes everyone assumes everyone has the history. It's in the paper that was passed on from the previous provider level of care. So I can't say enough about really making sure that we have supports in place that help our families to access and to understand what it is we're offering them and whether or not it's a good fit for them.
And I think about how that resonates with the transdisciplinary approach of thinking about and we've heard this earlier today, I believe from Estelle, we are all partners on this team to make this work for well-being in the community and wholeness of care. So we all have a point and a part in this process. I know that we are right at 11:45. I don't know whether there's anything on the thing, or I think we're gonna wrap it up so we can try to stay on track. Oh, no, Crystal, I couldn't see over this. I'm short.
I also have family inclusion. So part of the problem with families is we have no idea what the government is. No one has ever explained it. We have no education on it. So yeah, we probably do appear toxic.
Yeah.
We have no clue that what we're doing is going anything harmful.
That's right.
So,
Yeah.
until that is, in the children's world, it looks a little different. They may not have any options. On who family is, but in the adult world, you do, an older adult. But educating the family is the first step on what
Beautiful.
that looks like, and that individual, what they can do. Always family by choice.
On some level, I think everybody knows.
Yes.
I think on some level, everybody knows that, but the system kind of beats it out of people.
Yes.
And, when clinicians are really harried and, don't have time to get through the basics, that's one of the first things that gets dropped.
Well, they creating that partnership between clinicians and peers. So important, because that's a piece, the peer can pick up that pace and help, any peer.
Yeah.
So, and family peer will be coming sooner than what we may be thinking.
So I will thank everyone for their partnership in this particular panel. We could go on for another couple hours, but we do need to move along and let others speak. So think communication, coordination, collaboration, and community. If we pay attention to those, we are in a better stead, and we need to help our community understand all of this. Thanks.
I don't know what
I need to, okay, because there's lots of interesting things going along.
member to another, I am Richman.
I just heard it. Does this mic work? Is it good? I never need a mic though, to be honest. Like I said, that's why my daughter has her headphones in. So I think we lost, if we didn't lose Kat, I wanted to say from another family member to another, families of choice is very important. That's just my little 2 cents. Right now, I would like to introduce a colleague, I'm friend Chris, my friend Chris. Chris, for those of you who do not know Chris Finello, I can read a bunch of things about her. Of course, the most current thing is that she's the executive director for the Governor's Behavioral Health Council. It started under Governor Shapiro. She's also, over the last 15 years, she's been involved in different parts of county government, in Philadelphia, in Bucks County, even with PMHCC. Her specialty has, probably, if not all, has been forensics, if not most, if not all, has been forensics, including working a lot in the specialty courts and things like that. She's a licensed psychologist. She has a doctoral degree as well in clinical psychology. She was able to do her pre-doctoral internship for United States Medical Center for Federal Prisoners. Some may or may not know she ran for public office, which if I could have voted for her, I would. So she still may come back to that at some point. But I will just for a quick second is just say how I know Chris. I met Chris when I was working for the Psych Society and some of the work that is being done or has been done for the Pennsylvania Commission on Crime and Delinquency, which I'm looking at Kathy Doherty. She still is involved in the Mental Health Justice Advisory Committee. That's how I met Chris. And at the time, she was working with the Drexel Center of Excellence, I believe. So she was very instrumental in working on a lot of things we were talking about, like the intercepts and some of the other things that we had. We had that Centers of Excellence for a long time, gave some guidance for PCCD. So I can tell you that when I heard that Chris was going to move into a space with the governor, I was very excited. And people who are PPLC that know, I told you I was excited, still am excited. She is definitely a wealth of knowledge. She knows the things we're talking about that Nancy talked about the needs for forensic space and how we treat behavioral health. But I heard talk today, she can probably just give us an overview of the Behavioral Health Council. Some of you may or may not know about that. And if you haven't, she can fill you in a little bit. So it's my pleasure to introduce Chris Finello. Thank you. Very nice.
Thank you for those kind words. I don't really think I'll need this when I was along with being a clinical psychologist, I'm also a licensed attorney. And I think the second or third day of law school, I got the both at the same time, just before anybody asked. They always ask, which one did you get first? Done at the same time. But about the second day of law school, they said, no, you don't need the microphone. And some days I wish I didn't have the microphone because you don't always know the answer in law school. They put you on the spot and they ask you a bunch of questions. You're like, ooh. But anyway, so, but thank you. I appreciate the time to let you know about what's going on with the Behavioral Health Council and also how you can be a part of the council and this initiative, because this is a very large undertaking we just heard the last panel talk about kind of systems working together, systems work. It sometimes can be slow and plodding, but we do have to move with some alacrity. I kind of think of this process with the Behavioral Health Council as deliberate, but expeditious at the same time, because we have people, we have issues that I happen to be on this, happen to listen to this panel previous. There was other panels, I'm sure, and other people discussing some of the opportunities, but the challenges. We have folks and you deal with every day. I've dealt with in my previous roles, not as much direct service these days, but more systems work. Learned the systems work kind of by doing, as Deb said, my specialty is around the intersection between criminal justice and mental health and substance use. So criminal justice, behavioral health, building up programming, making those systems actually be able to talk to each other a little bit better and communicate and really do that type of work. So that interdisciplinary work that we're looking for. But once I moved to Bucks County as the role of Deputy Director of Housing and Human Services, really started to look at integrating human services across those departments. Even though those departments were in theory working together towards the same goal, still a lot of silos in that work by somehow by how designed and how programs and systems have to work. But at the same time, just the way that they kind of over time morphed into silos that actually kind of got in the way of continuity of care, and kind of making sure that we were able to untangle a lot of that in Bucks County. That was a lot of the work that I was doing there to create an integrated data system. I heard one of the folks on the panel talk about, information sharing. That is really a tough thing to do. We tried to do some of that work in Bucks County around information sharing across those departments, and it can be challenging for a number of reasons: programmatic, legal, not the least of which legal. And I'm a lawyer, so I can, kind of make that face, but because when you do that, the work is hard. Of course, we don't want information to be out there. We don't want everybody's information, but we cannot let this information sharing or the lack thereof get in the way of good continuity of care. We really do have information, but we have to be able to use that information in such a way that is useful for the folks that we're serving. So really that is what this Behavioral Health Council is all about. So as Deb mentioned, the Behavioral Health Council was established by Governor Shapiro in October through an executive order. And it's going to create a statewide action plan aimed at removing silos across state agencies, healthcare providers, payers, state and local governments. So pretty much everybody. As I said, this is kind of a Herculean task, ensuring more efficient use of resource. At the end of the day, that's what this is about. We know, I don't need to tell anybody in this room, what is it now been, was it 12 years ago? It was right when about 5 years after I'd started in this realm, we had that severe cut to mental health services that we've never really realized. We've never seen that money get back again. It went away. And as we know, each year, as part of my role in Bucks County was doing the fiscal. Don't have that degree, but you have to do what you got to do. Learn about fiscal, learn how to do that work, learn how to make sure that you're able to pay for those things. But it was really hard to do budgeting, especially in sometimes when you're dealing with folks that say, we don't want you to spend any more than you did the previous year. Well, just to pay providers a living wage or give them, a small cost of living, I'm already over budget. So these are challenging times. And, I understand. And I think that's a real benefit of coming from where I came from to where I am now, working from the counties and coming up to the state. Because when I tell you that I understand what's going on at the county level and how this kind of all comes together, I really do. Now, it's a matter of what are we going to do about it and how we're going to be able to accomplish those things. The other thing that I heard very loud and clear too on this panel, and we've talked about this for a while and we've talked about it at the council, is about measurement and measuring impacts and outcomes, and how important it is to be able to find a way to do some good measurement. But again, we don't need that to be overly onerous on the counties, on the providers, on the people that do the good work. But it is really important that we make sure that that information that we have, we know what it tells us. So I've done a lot of that work in both Philadelphia and in Bucks County. So that will be one of the focuses of this work as well. So the council's purpose, as I said, the aim is really to create a more user-friendly, holistic approach for persons with mental health conditions, substance use, and their care needs. And I know it sounds like a lot of buzzwords, and it really does. I mean, you have to kind of succinctly say these things. If I was going to, explain them, as most of these panels, we could be here for many hours in the day. But we really are looking at the whole person, and the whole person in a realistic way. I heard that word being used as well, in a realistic way. How do we treat the whole person, making sure that we are able to do that? We just don't want to say we're aiming to treat the whole person. We want to actually do and treat the whole person. This came together because there's obviously a recognition and of a need to look at this comprehensively and collaboratively to improve health outcomes. It just can't be in silos anymore. It can't just be with one agency being responsible to try to figure this out. This is a whole system problem. Looking to create a roadmap to address gaps in access, affordability, and delivery. So they're kind of the North Stars of the council, is about access, affordability, and delivery of mental health and substance use services. Looking to do strategic, long-term sustainable investments. A lot of my work in Philly, but also a little bit in Bucks County as well, when they decided to just throw some forensic stuff at me, because I didn't have enough to do with the rest of the rest of the division, was around creating programs, but creating programs that were sustainable. A lot of times there's some great ideas, you get money, PCCD is a great example, get some money, but it's about, and SAMHSA is another good example of this, but it's about making sure that those investments are sustainable. So what is the things that we need to do to make sure that a great program gets to be and continue to be a great program? It's not just a one-time thing that helped a few people. We want to help everybody. We want the promising practices of today to become those evidence-based and those regular programs of tomorrow. But it's talking about leaving those as sustainable investments, not just, oh, you got some money, good for you, county. You're on your own to figure out what's going to happen with that and how to keep that great program. We need to do more of the good things and less of the things that don't work. And that's why I think, as I mentioned, data is really important in that. What does that information tell us? It's about, and I think the panel also said this here, about, it's not, we might feel something's happening, good, bad, or indifferent, but what is the data telling us? What's that information telling us? Again, I don't really need to tell you why the governor finds this work so important. He had participated in a roundtable discussion on Black mental health, and he was also involved in an initiative on strengthening youth mental health with the National Governors Association last year. And it kind of expedited this conversation around what should Pennsylvania be doing, what should the executive branch be doing to make the system better, and the need to convene this council to reduce those barriers about accessing care at the right time, and also address the concerns about, quite frankly, the affordability of care. We know that things are expensive. We know that we have to change that. When people are at their looking for help, they need the help, they need the right kind of help when they need it and at the cost that they can afford. So a lot of these things, kind of all came together at once. We had, suicide. It continues to be a severe public health concern, especially among the youth. The governor started a Safe to Say Something program, which is the school safety program that was run. It's still run under the Attorney General's office. And that has received over 120,000 tips to identify individuals at risk. We know that there's the shortage of mental health providers, which exacerbates issues. COVID pandemic kind of intensified what we all in this room knew. Everybody knew that the system needed help, that we needed more resources, that we needed to streamline things. But when COVID came around, it really showed how much mental health is an everybody problem, not just a select few problem. We know that the lack of mental health supports has overwhelmed emergency departments. We've heard that time and time again, overcrowding, delays in care. So all of these things kind of coalesced and came together to have the governor want to put this council together and make sure that we're doing the things that we need to do. Let me tell you a little bit about the council's makeup. I think I have we have our council and we have an advisory committee, and I'll let you know about what those are. We have our council, Behavioral Health Council. It's a diverse array of stakeholders, state, county, local governments, provider, community, advocacy groups, individuals with lived and living experience. So we have, for example, we have Commonwealth representatives. The chair of the Behavioral Health Council is the Secretary of Policy and Planning. Our vice chair is the Secretary of the Department of Human Services, Valerie Cush. I know many of you know. We also have on the council, obviously, some of the other state agencies that you would typically think of that involve human services, mental health, substance use, Department of Health, Department of Aging, Department of Drug and Alcohol Programs, but we also have the Pennsylvania Insurance Department is a key member. And when I tell you about some of the topics we're talking about right now, this month, we've been talking a lot about insurance and reimbursement. So our insurance department is a key player there. But we also have the Department of Education, Military and Veterans Affairs, Corrections, the Department of State, because licensing and regulations, Department of Agriculture, PCCD, L&I, Labor and Industry, because we'll talk a little bit in a minute about some of our findings. Again, that will be no surprise to you around workforce shortages and those types of issues. Digital strategy, because we have a website that's under construction that we're constantly updating, but we want to have a digital presence. And then our the Attorney General's office as well. But along with the Commonwealth representatives, like I said, we have persons with lived and living experience, treatment advocates. We have family members who share their story about all the things that she had to go through to get her son treatment, and even now, still not great. I mean, we'll just be honest that there's still a lot of barriers to his complex case. County representatives, because of course, the state cannot do this. This is all, the counties do the yeoman's part of the work. So we have county mental health, our single county authorities are represented. Both we did the way that they broke it down here was urban and rural. You could have broken it down quite a few different ways, but that was kind of where the executive order lied. So we have representatives from what are considered urban county mental health offices. We have rural county mental offices, SCAs, and then the area agency on aging as well for our county representatives. I happen to be in Bucks. I always talk about how that kind of has it's a microcosm, it's not the very upper part of Bucks, but is rural. We have like the middle suburban part, and then we have our lower part of Bucks County that borders Philadelphia that looks very urban. So so in a small way, understand the challenges of delivery of services to all different types of areas. But I think it was Sally Walker who said that even if you had all of those individuals, urban, suburban, and rural in the room, you would find some similar challenges. Yes, there's obviously challenges that happen particular to rural areas versus urban areas, but there is a lot of commonalities around the challenges and then hopefully the opportunities as well. We have a number of clinical representatives. We have child psychiatrist. We have a primary care doc. We have somebody that has a psychiatrist that has an intersection between co-occurring IDD, autism, and also mental illness, and an expert in addiction medicine, substance use treatment. So a lot of highly qualified clinicians that are helping us trying to figure this out. And then last but not least on the council, there are representatives from the General Assembly. So two state representatives and 2 state senators who so far have been very, very appreciative of the work, but also very involved in our council meetings, wanting to know more, asking questions, meeting offline with some of our other council members. So really want to understand what's going on. So it's a real opportunity for the council to be able to inform the General Assembly around what actually needs to happen when they're trying to create these laws, very well-intentioned laws, but what is really happening on the ground level that could help. So all of these things are intersecting here. And then we have our advisory committee that is that brings together industry knowledge, expertise, and feedback from communities. They're helping, there is an adjunct to the Behavioral Health Council. They're a committee of folks that have come together to provide that expertise to kind of dig a little bit deeper into some of these very dense issues that we have to talk about. Sally, like I said, is a member of our advisory committee representing her organization, BHARP, the county level managed care organization. So we're happy to have Sally on our advisory committee. So, but there's many folks. We have Juvenile Court Commission, we have Rural County Government, we have what else? We have the Office of this Victim Advocate. We have a person from organization representing county and drug and alcohol administrators. We have someone representing statewide social workers. We have somebody that's from the Pennsylvania courts, their behavioral health administrator, because there's that initiative, if you haven't heard, around behavioral health in the courts that's happening with Justice Doherty. So same type of thing where they see that there is a need in the criminal justice system, particularly around behavioral health. So we're working closely the two groups are working closely together, because if you know anything about me, I don't like to duplicate things. I don't like to reinvent the wheel. There's already been a lot of good work being done. Actually, I had a head start coming into this job with all the materials and work that's already been produced. Like I said, really utilizing that to inform myself, inform council and committee where necessary, to make sure that when we're ultimately writing up these recommendations, we have a well-informed group of persons that are able to give us, again, concrete, realistic, usable recommendations that we can move forward quite quickly on, at least for some of them. Obviously, some of them are going to take a little bit longer than others, but there is a need and a push to get things done as soon as possible. So when the statewide action plan is written, there is an expectation that there will be some amount of recommendations that will be implemented almost immediately, or as immediately as things can sometimes happen in government. But the point is, this is not just going to be something that sits on the shelf, collects dust, and, everybody just did a good job. And, it's going to be something that's action oriented. I don't really like things to just sit there. And, when I got to Bucks County, we had done the intercept we did with the mapping of Bucks County around the criminal justice system a number of years before I'd gotten there, and we got back and they pulled me in to do some forensic work, and I said, well, where's the mapping? What are you talking about? I said, where's the mapping? I said, we got to pull that out. We pulled it out, we redid it, and we started moving stuff along. And we, created an action plan that actually moved things along. 'Cause I was like, we have to get this going. We have good stuff, but we got to get it moving. So we're going to use the council, the advisory committee, and then we also have other recommendations. And this is just a small smattering of the materials. There's probably other things. I'm hoping in a few minutes when I tell you how you can help, I'm hoping there's other things that you can provide as well. But there's been recommendations from, if you recall, the Behavioral Health Commission. There was a commission. They had recommended that $100 million be invested into the adult mental health system. As we know, when that all came to pass with the budget and all those things, that did not come to pass. There are many individuals still working to make that happen. The $100 million did go towards the schools, which of course they need as well. But as I said from the outset, we know what our system needs as vis-a-vis, funding. We know we have a gap. The $100 million, quite frankly, would make a dent. There's a lot more to be done. So a part of this council is about where we can streamline and have efficiencies, because we're literally going to have to make every dollar work for us in this system. And we know that, it's just I think it's just part of what we have to deal with on an everyday basis. I see nodding heads. I know, you know what I'm talking about. We have to make this work. But using one of the recommendations that came out of the Behavioral Health Commission, besides the very important one about the investment that is needed into the mental health system, was about having an entity, or, whatever that looked like. It was around something that could look at these issues day in and day out. So actually, this Behavioral Health Council is one of the recommendations that also came out of the commission. So not a total. We didn't just put that document on the shelf and just kind of put it there after the 100 million, but wasn't able to be allocated at this time. But like I said, there are individuals that are working on that as we speak. In fact, Representative Schlossberg, who was the author of the House bill for that, is one of the representatives on the Behavioral Health Council. So we're working together. There's other groups and commissions within mental health and substance use provision. So we have a lot of different recommendations, but one of the things that a few of the things that the Behavioral Health Council will consider. One of the things considering, we'll be looking at Pennsylvania's current behavioral health landscape, obviously. You have to know where you are to know where you're going, including but not limited to resources allocated, new and innovative care delivery, workforce infrastructure and funding, regulatory enhancements, payment models, and a data ecosystem that would measure gaps in services. Another thing we're going to be looking at is unmet health-related social needs, health inequities, integration with primary care, and how that could be coordinated to treat, again, the whole person. We're going to be examining the collaboration between criminal justice system, public safety networks, and public health organizations to emulate models that have worked effectively at local levels. Like I said, there's a lot of good work being done. I know some of it, but I don't know all of it. I haven't been to all 67 counties just yet. I've been to most states. See, I gotta go back now. See, I've been to most states. I've been to every state but 8. Now I gotta come back here and get to every county. So my number's not quite close to 8 yet. But the thing is, there's a lot of good work being done. We're also going to consider specific legislative policy and investment recommendations. We want to actually advance, in a real way, materially advance the turnaround time in which individuals with mental health and substance use needs receive their care and services. We don't want people waiting. We don't want people not getting services because the wait lists are too long or they've just kind of timed out, so to speak. That's not what we want to happen. We want to make sure people get what they need and get it in the timely fashion. And then we'll also review the availability of mental health services provided to historically underserved communities. A lot of need here, but we know there's some underserved communities as well. There is a lot of talk in not only in the Behavioral Health Council, but in other parts of the executive branch, but the legislative branch around the need in in our rural parts of Pennsylvania. That is a huge need. We, again, COVID highlighted, the use of telehealth. Sally and this panel talked about, what it looked like when there was some relaxation of regulations. Again, putting on my legal hat. We got to make sure that we're doing what we're supposed to be doing, accountability and those things, but there is no reason why we can't look at some flexibility in some of these regulations, some of the things that we're doing, especially if it is accomplishing the goal of getting services to people. And it is in the same way. It's never going to be exactly the same as in person, but there is a lot of things with technology that we can utilize to our benefit. So just quickly, I just wanted to go over just a couple of things that will not be news to you, but I figured I would share because I think some of you probably participated. We had sent out a survey, I think in November, late in the last year, where we asked folks a few questions, and we had 900 responses, which I know just kind of scratches the surface, but we had 900 responses for a survey that was open for a couple of weeks. The biggest area of responses was from behavioral health direct service providers. So they had a lot to say, which was great because, again, a lot of data, a lot of good information. After that, county government agency was the next biggest group of respondents to the survey. But we just asked a few questions. One of them was key challenges. We asked folks that rank key challenges individuals seeking care face in Pennsylvania, and the top 3, again, I don't think these will be a shock to you: finding timely care, finding care covered by insurance, finding affordable care. That was the top 3 that people said were the challenges. We also asked people the key challenges that healthcare professionals who provide care face. So so we did the individuals, then we asked what the providers face. Top 3, I'll do top 4 for this one. Workforce shortages was number 1. Number 2, 3, and 4 were reimbursement for care because we had split it up between Medicaid and then Medicare and then commercial payers. So that was 2, 3, and 4. And then the next 2 were state regulation barriers, federal regulation barriers, and then information sharing. They were kind of your top 3 buckets, but spread over about 6 or 7 responses. And then we asked areas of concern that the council should work to improve the behavioral health landscape. We had 8, or I should say 7. Then we had like an other. We just let people do like a catch-all. And then we kind of put those in buckets. But the top 3 were improving workforce and infrastructure, innovative and sustainable care delivery models, streamline funding models. Because funding is kind of the big central part of this. And then we also had regulatory licensing and credentialing enhancements, innovative reimbursement and payment models were kind of the big ones that rose to the top. So the last thing I just wanted to say, because this goes long into how you can be a part of this, because yes, there's the council and the advisory committee, and we have awesome people on those. But one of the things that both the council and the advisory committee has been doing is introducing me and connecting me to other folks that want to be involved in this. So everybody can be involved in this, in this work. So I'm hoping that after this session, I'll leave my cards. If there's, I'm going to talk about the topics that we're going to be looking at, and I can certainly provide this topic list to your leadership if, you can see this. But if there's something that you feel very strongly about or have experience in, or know of a speaker, or know of somebody that has some really good expertise in the area around this, or a group of folks. I travel, I'm going to come see some folks that have some particular expertise in an area that can really inform how we need to change this and what will really be a good recommendation for the statewide action plan. By all means, please send them my way. So far, we've talked about access and integration of co-occurring services. We've talked about kind of funding principles and challenges. Right now, we're kind of elbow deep in insurance and reimbursement. Future topics, we're going to be talking about regulatory and licensing issues and innovations, but also some flexibilities. Trust me, I get there's regulations and there's licensing, and they are what they are right now, but that doesn't mean they have to stay the same. I'm not saying I had the magic wand to change them, but nothing's going to stop me from putting a good recommendation forward about maybe how we can have some more flexibility in different regulations that may actually help continuity of care. So if there's some good stuff that you've been doing in your area or know people who are doing good things, you let me know. Prevention, early intervention strategies, crisis system. I heard Kat, I think it was, talk about Intercept Zero. Love Intercept Zero. Intercept Zero wasn't a thing when I first started with the Intercept model, but love Intercept Zero. But we're talking about the crisis system. How can we improve our crisis system? We heard about 911, but now 988. How can we get 988 to be, a system that works together with 911 and really enhance that? So we'll be talking a lot about the crisis system and structure. Children and adolescent well-being, addressing gaps in care is something else another topic that'll be looked at. My favorite, although sometimes makes me want to pull my hair out because I could tell you stories about my time in Bucks County when we were doing this, information share. We have to deal with that. We have to figure out a better way, as I had said before, to use that information that is at our fingertips, but we have to figure out what it's telling us and how we can use it better. Use of telehealth and technological innovations too will be discussed. Workforce, another big topic. And then health-related social needs and whole person care. So that's just a high-level highlight of the topics that will be contemplated by the council and the advisory committee. And again, I can share that list with your leadership so you can kind of more, fully peruse it at your convenience. And like I said, I'll leave cards. Last things, expected outcomes, as I said, we'll be having that action plan that's going to talk about improving access, affordability, and quality. Promote better coordination between various levels of government agencies and providers, creating a resilient behavioral health delivery system. A couple other things we're going to be doing is resource and service mapping, create a shared and comprehensive understanding of the resources allocated, services rendered, and stakeholders engaged in service provision. We have a lot of existing work groups that are doing some really nice work on this. So we're looking to bring that all together. We're looking to also have, with this action plan, as I said, we'll be contemplating policy, regulatory, and programmatic reforms and innovations, also fiscal as well. So, and then ultimately, we want to establish a more streamlined approach and delivery of mental health and substance use services. And we want to also have a digital presence. So as I said, I mentioned the website that is currently under construction. We're adding to it. We'll say about every couple of weeks, we're trying to add and enhance it. And so if you have any suggestions around things that we could also have on the website, again, feel free. There is nothing that I'm not willing to hear. I want to hear any and all ideas. I want everybody to be involved because this is such a big task, but we have to make it better. We have to move quickly, but deliberately, and want to make sure that we're doing right by our residents. When we know that people have issues with mental health and substance use, the last thing they need to do is have a system that is so hard to difficult to navigate in the time when that's really, when they're having problems that are much worse than that. We need to be able to get them the care that they need when they need it and the right kind of care. So I hope that you will interact with me. I hope that you will email me, call me, tell me everything that you know, tell me problems, gaps, opportunities, whatever. I hope you will come with me on this journey so that we can make more streamlined services for our folks here in Pennsylvania. Thank you so much for your time today.
Thank you so much. We don't really have a whole lot of time for questions. We could probably take one if anybody has one. Okay, we'll give Lloyd the final word on this.
Thank you very much for being here with us today and making this presentation.
Yeah.
On the day the council was being announced, we had a meeting earlier in that day with Ms. Lindsay Malden. And she heard about Psychiatric Leadership Council, and you're in a room of people who have their feet on the ground, the boots are entrenched and providing services to the people you're talking about that this council is planning to serve. And then there's another set of those that are reviewing, not in person. And at that time, Lindsay said that perhaps an opportunity for the PPLC to present to the council should be something that would be offered. I believe we're still willing to make that type of presentation. And is that still something that you could put on the agenda?
Oh, yes, absolutely. Like I said, I will provide that list of kind of topics I went through, and I'd be happy to discuss with you, offline, any and all topics you would like to, do a presentation, whether we do it once or whether maybe there's a few topics that you feel like there might be yourself or other members would be willing or able to present. So I think there's a lot of different opportunities with the breadth and depth of different topics we are contemplating.
Yeah, I mean, clearly the focus is on community psychiatry at a number of levels. We've actually written a paper on kind of reimagining the community system. I don't know if that's been shared with you, but we're happy to.
Please.
Okay.
Absolutely.
Well, thank you very, very much for being with us.
You're welcome. No, thank you so much, Lydia. Like I said, I am not going to profess to know every resource or anything. So that's why I rely on folks like you and people in this room and other rooms that I've been in to let me know what I'm missing. If I don't know it, you have to tell me, you have to tell me what I need to know and from your perspective, because that's what it's really all about. Everybody has a different perspective with this work. There's no shortage of work and perspectives on this, but I know we can make it better if we work together. So again, I thank you for this opportunity today to talk to you about what we're looking to do and how we can use your help.
Great. Thank you so much. If you could give her another round of applause for joining us. Thank you so much. So up next, we have our third panel, and I'm going to pass it over to Sierra McNeil.
I just want to make sure we have one more panelist online, I believe.
Yes, good afternoon. I am online and on video. Is that working for you?
Yes. Ooh.
Okay, wonderful.
Okay, Dr. Norris, can you hear me?
I can hear you. And
Yeah.
yourself, can you hear me? Great.
Yes, all right, so we're good. Technology is underway. All right, so we are the third panel and very excited to have this panel. This is talking about the future. So we've heard a lot about sort of what has happened in the past and the present, and so now we're gonna talk about the future. And I'm going to introduce myself because I realize I sometimes start these things and forget to introduce myself. So I am Sierra McNeil. I am the Director of Workforce Development in Philadelphia Connections. And I also wear a dual hat as the President of NASW Pennsylvania, which is the National Association of Social Workers Pennsylvania chapter. So I am a social worker. So just like to put that out there. And I am joined by two amazing colleagues. And I know the other panels, they sort of read your bio and introduced, but I'm sort of, I guess you would say either old school or maybe new school, and like to have you both introduce yourself. And so Dr. Dixon, we are going to start with you.
Okay, let's see if this is working. So I'm Dr. Clarice Dixon. I am a psychiatric fellow with Western Psych under UPMC. I'm doing the Rural and Community Psych Fellowship. I did train in Lee Common Erie, and that's where I'm working currently. So that's just a brief introduction to me, and we'll pass along to Dr. Norris.
So good afternoon, everybody. I'm sorry I can't be there in person. My role is that I am the Chief Medical Executive for the Behavioral and Community Health Service line at Lehigh Valley Health Network. And in that role, I oversee both the Department of Psychiatry as chair, as well as the Community Health Network efforts across our continuum. Very happy to be here.
All right, thank you for that introduction. And so it looks like, Dr. Dixon, you have something prepared?
Yes, I do.
Okay.
So I'm just going to stand up at the podium here. So I did put together this brief presentation. I did want to state that I had some acknowledgements. I don't have any financial interests or conflicts of interest. I wanted to thank Dr. Cindy Cho out of UPMC Pittsburgh, who did introduce me to the collaborative care model and allowed me to join her on her project. And also Dr. Marianne Alba, who is my preceptor and who is always putting my name in the hat for things. I was originally supposed to be a moderator on this panel, but I found myself getting an email from Deb a couple weeks ago asking if I could fill in for someone who had to pull out. So this was, oh, sorry about that. So this was put together, pretty quickly, and it is going to be a pretty brief overview of this topic of integrated care, specifically the collaborative care model. So our objectives are to identify the gaps in the current mental health assessment and access, define collaborative care, and to define the roles of the collaborative care team. Now, there's lots of other topics that we could talk about underneath this umbrella. But I'm really glad that this kind of concept was introduced through many of the different panels, talking about reaching across the aisle, eliminating those silos that we're experiencing, and expanding access to everyone. So I'll start with a quote. This is the WHO definition of health, which is a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. And that was defined in 1948. So we've known about this for a long time. Have we actually caught up with our policies and our practice? Not necessarily. And then another quote, just hearkening back to my osteopathic roots. This is from A.T. Still, who's the founder of osteopathic medicine. He says, "The body is a unit, a harmonious whole made up of mutually dependent parts." And I believe I recently heard someone at one of the webinars state that we have necks that connect our brains to our bodies, and we should not be forgetting that we are whole humans. So for some background, a lot of these topics were touched upon. 25% of all the disability worldwide is related to a psychiatric disorder. Persons with psychiatric disorders do have higher risk for other health conditions, with them having a 3 times higher risk for diabetes, 10 times higher risk for heart disease, and 40 times higher risk for cancer. And unhealthy behaviors are one of the major drivers of healthcare costs, and that behavior determines approximately 50% of all morbidity and mortality. And 40 to 50% of our patients do struggle with treatment adherence. So only 40% of mental health, Americans with a mental health disorder or a substance use disorder have received treatment, with 12% of those people seeing a psychiatrist. 21% saw any mental health care professional, and only 48% of those consumers who were in the mental health care facilities received minimally acceptable care. 23% of these individuals were seen by their PCPs, and only 25% of those received minimally acceptable care. And half of the people who were referred to a mental health specialist do not follow through with that. There's many different reasons for that, access, not having the ability to get transportation, and their insurance not covering that care. And then the people who do manage to get to those specialists in mental health only have an average of 2 visits. So 1 in 5 counties in the United States have an unmet need for non-prescribing mental health professionals, but 96% of US counties have an unmet need for prescribers. So the psychiatrists are spread particularly thin, and there's an even higher need in lower socioeconomic status areas. So the ideal length of weekly availability for psychiatrists is 50 minutes per person, but the actual time available in US urban areas is 6 minutes, and in rural areas, it's about 1.5 minutes. So we are not reaching all the people we need to reach. So per the Milliman report by the APA in 2014, with current care, mental health and substance use disorders cost healthcare was 2 to 3 times more than those in the general population. And the most of the added cost is facility-based. So these people ended up in the ER or inpatient visits for their medical care, not their psychiatric care. So in order to bridge the gap, we need to expand awareness about the importance of recognizing mental health as an integral part of overall wellness. And we need to provide mental health treatment in settings that are most comfortable for the patient to reduce stigma, reduce overall costs, and improve coordination of medical care. So there's a triple aim of healthcare reform that you guys may be familiar with, including improved access, improved outcomes, and lower costs. And we want to have it all. So one way that is proposed to address these concerns is the collaborative care model. So this is a type of integrated care that operationalizes the principles of chronic care model to improve access to evidence-based mental health treatments for primary care patients. It's caseload focused. There's a psychiatric consultation component supported by a behavioral health care manager to coordinate the care of patients under the PCP setting. And it's been called the chronic care model for mental health. There's an estimated 5 to 10% reduction in healthcare expenditures and a potential annual savings of $26 to $48 billion if this was implemented. So there are 5 principles of collaborative care, and that they are patient-centered, measurement-based, population-based, evidence-based, and accountable. And I know a lot of those concepts already came up in many of the different panels today, so I was excited about that because I get to kind of tie it all in. So the evidence base is largely supported by the IMPACT trial, which was the Improving Mood Promoting Access to Collaborative Treatment. This was done from 1998 to 2003, led by Dr. Jürgen Unenzer. I'm hoping I'm saying that right. It was one of the largest treatment trials for depression as of 2014. So it's a little bit outdated, this data that I have now, because it's based on the studies at the time, but there have been more and more emerging supportive evidence behind this model. So this IMPACT trial followed 1,801 depressed older adults from 18 diverse primary care clinics and 8 healthcare organizations across the US, and included 450 primary care providers. And it was a diverse population in urban and semi-rural areas, and they did look at capitated and fee-for-service models for pay. So they compared the usual care group with the collaborative care model. And the results were that there was a 50% greater improvement in major depression at 12 months across ethnic groups, and that there was $6 in savings for every $1 spent, and that it was replicated in over 80 randomized controlled trials. So this is very well supported. So there is an established evidence base in depression for not only adults, but adolescents, patients with diabetes and heart disease, patients with cancer, and patients in women's health clinics. There's also evidence for support in anxiety, PTSD, chronic pain, and dementia. And there's emerging evidence in those with substance use disorders, ADHD, and bipolar disorder. So now we're just going to get into the basics of the collaborative care team. This is a graphic from the University of Washington's AIMS website, and that is Advancing Integrated Mental Health Services. And they have like a plethora of resources, and I'll link them at the end of this presentation. So the team consists of the patient, the primary care provider, the behavioral health care management, and psychiatric consultant. So of course, the patient might be stated to be the most important member of the team because it's their treatment and we are focused on their goals. So they are actively engaged in the behavioral health treatment. They provide feedback and assist in tracking their treatment progress, and they ask questions and voice any concerns. The primary care provider is the overseer of all the care. They do formulate the diagnosis and administer the medications in the primary care setting, working closely with the behavioral health care manager, and then they also engage patients proactively to reach their treatment goals. Now, probably the mover and shaker of the team would be the behavioral health care manager. This is a person who is typically a nurse, a psychologist, a social worker, or a licensed counselor who is responsible for coordinating the care and facilitating patient engagement. They perform systematic initial and follow-up assessments. They track the treatment response, and they support the treatment plan with the PCP. And they also are responsible for reviewing challenging patients with a psychiatric consultant, and they may provide some counseling if they have the credentials to do so. And then the role of the psychiatric consultant is to support the PCP and the behavioral health care manager in treating patients. They assist in diagnostics, treatment planning and recommendations, and they provide educational behavioral health diagnoses and treatments to the PCP and the behavioral health care manager. They also may rarely provide some direct care for challenging patients or those who are not showing improvement with current treatment. So all this is facilitated through the use of a health registry where we share information, which was also brought up. That might be one of the ways that we utilize our available technology. Some existing EMRs do have the ability to do this, but many of them don't have a way to track a population of patients. So you would use this to track all of the currently enrolled patients, and you can use it to determine if patients are following up with care, and you can identify health measurement scores such as PHQ-9 and GAD-7 to track treatment targets and identify patients who are not improving. So this is just a look at what one of those health registries might look like. It's probably hard to see, but this is also from the University of Washington. So just as a reminder of the core principles of the collaborative care model, we do focus on the patient as it's patient-centered, measurement-based through this assistance with the registry, and it's population-based, which we track through that same registry. The evidence is also supported by utilization of the registry, and we keep account by always checking in with patients, making sure that we're reaching the goals of treatment. So I just wanted to finish up with training and resources. So if these slides are made available, these links will point you to the AIMS Center, the University of Washington's websites, where they have a plethora of resources, including how do you reach out to implement a team? There's surveys about your clinic's readiness to engage in integrated care. There's all of the papers that were in the impact trial are linked there so you can read up yourself on the evidence base. And there's so many other supporting resources to kind of get this kind of program off the ground. And there's also free training available for psychiatrists and primary care providers on the APA's website, which I've linked below. So there's really no barrier to getting more information on this. There's plenty of more that I could have talked about, but I did want to keep it brief in the interest of, having some room for conversation.
Thank you, Dr. Dixon. And we will absolutely come back to that. And so before we get into some questions that I have prepared, Dr. Norris, I would like to turn it over to you, and you can talk about the great work that you are doing as well.
Sure, thank you so much. And as we just heard, the collaborative care model is a great model out of the University of Washington to help extend the reach of psychiatry, because I think the goal of everyone here in this conference is how can we give everybody who needs mental health care the optimal care that they need, and that really takes a village. And so in that role, we really need to think about multiple ways of approaching our patient population, including our federally qualified health centers and the outpatient care that we deliver there. But as we know, in the outpatient setting with primary care, or excuse me, in psychiatric care, a psychiatrist who is seeing patients for 60-minute new person evaluation and follow-ups at 20 minutes for times a year hits a panel size of around 840 patients, and they have attrition of about 10%. So that full-time psychiatrist gets in about 84 new patients a year, which when we look at our demand will not be sufficient as we go forward in the future. So partnering with primary care to help them do more is definitely one of the key aspects to expand behavioral health care. And we do a lot of partnering with our primary care providers, including behavioral health integration, which is a step below collaborative care. We're actually flipping that switch this fall. But just for instance, we're able to have 65 licensed professional counselors and social workers provide supportive care to about 160 practices. And with that, we use our consultation psychiatrists to support the primary care provider, and that they often can ask us for help, and we'll evaluate their patient in a one-time consult. And just for scale, thinking about this as you look at your own systems, if you do a one-time consult and you do 3 one-time consults in a 4-hour block, that same full-time psychiatrist can actually see over 1,400 patients a year. So an outpatient psychiatrist with a turnover of 80 patients a year versus a consultant doing over 1,400, we all of a sudden have a manner to turn the numbers into something that could be meaningful for the Commonwealth. And so we're a huge fan of supporting primary care in whatever way we can. That includes, there are apps that help manage that patient population. There's a number of different providers or companies that will do that. And that also assists that care manager know what patients are having difficulty or struggling in between their actual visits. And then another aspect that we're doing as a health system is in the world of healthcare apps. As many of you know, there are actually over 300,000 digital health apps, and about 20,000 of those are designed for behavioral health, and only 6 of those are actually FDA approved. And so working with a consortium of hospitals in Pennsylvania, New Jersey, we're able to create an app formulary where actually providers, both primary care and psychiatrists, can prescribe apps to patients that have been fully vetted, both for security as well as efficacy. And we're able to help patients in the world of depression, anxiety, ADD, insomnia, smoking cessation, and even weight management in a way that is measured and much more, I'm blanking on the word, but much more meaningfully created. And then the final thing that's really exciting is a pilot that we are doing in the Lehigh Valley with a group based out of Pittsburgh called Visible Hands, and it's based on integrative community therapy. And integrative community therapy was actually born in Brazil over 40 years ago, and it's based on communication theory, cultural anthropology, as well as the theory of resilience. And what's fascinating about this form of involvement is it requires no degrees. You do not need a high school degree, college, or a therapist degree. You just need training in ICT to be able to work in communities. And as you work in communities, they help bring together local resources through both these hour-and-a-half-long sessions that are led by peers. So they're led by peers out of community-based organizations. So it's wonderful in the world of DEI because you have like people helping each other, and it's based on the fact that if the community can work together, they're able to help rise themselves out of common issues that otherwise create significant individual burdens. Brazil has studied this extensively, and actually they have found that where they have deployed it across their country, approximately in 88% of the time, it has allowed the resolution of the problem, and only 12% of people have need to be escalated up to higher levels of care. So we are piloting that with training 31 community-based organizations in the greater Lehigh Valley and Scranton area to see what kind of leverage we can get in this new to us, not new to Brazil and 40 other countries, type of intervention, really to bring community resilience. And so just, again, sort of going on level overview of many things that we would be thinking about, both with our care delivery, how we interact with our patients, and how we can bring in novel strategies that are breaking the system, because at the end of the day, we would all love to see payer reform to bring in more providers into our area, but I unfortunately do not see that resolving anytime soon. So with that, I'm happy to hand it back for questions.
Yes, thank you, Dr. Norris, for that great introduction. And I could almost promise you're going to have some questions directly related to ICT at the end of this. But I would like to get to some of our planned questions. And so my first question is for Dr. Dixon. So you gave a great presentation on a collaborative care model, and thank you for that. So as a COE fellow and a future leader, what barriers do you see moving ahead with the quality of collaborative care?
So I think one of the first barriers that we'll see is buy-in, getting everyone to work as a team, getting the primary care providers to see that the psychiatry consultant is there to help them see more patients and deliver more effective care. Fortunately, the University of Washington does have a lot of tools on their AIMS website about how to start those conversations and to promote provider buy-in.
I appreciate that. So I just visited a university not too long ago, and so they have simulation rooms, and these simulation rooms were actually used for the nursing program. But the nursing program got more funding, and so they now bought a different building, and they donated or gave that room to the School of Social Work. And one of the things I appreciate about it is that it's starting to move towards that collaborative care model where they can create an ER room, and the social workers can learn how to work with nurses or the ER doctors or the psychiatrists that are in that field. So there is hope, and I hope that we do continue to move towards that model.
Absolutely.
Yes. All right, Dr. Norris, I'm going to come to you. So this conference today is talking about the Community Mental Health Act and celebrating the 60 years. And so my question to you is, as the Community Mental Health Act moves into the future, what barriers does the act cause in providing innovative treatment and services in a time where there is resistance for payment for innovation?
Right, and I think it's a challenge that we are facing in multiple areas of the state, because a struggle that we face is that in our coverage area, we actually have 3 different Medicaid carriers for the population that we serve, and all 3, as we know, have different rules with regards to how they feel about innovation and pilot programs. And so we face a challenge with how we speak to our regional carriers to help them to understand we have to be forward looking to be able to find projects that work in our different areas, because each of our areas are handicapped, and the better that we understand our communities and what our strengths are in our communities allow us to leverage those options for different pilot programs. For example, ICT is a pilot program that we're leveraging in this area. It might not be as effective in a different area depending upon the support of the community and the community-based organizations. How do we, another challenge that we all face in the world of this is telehealth. All right, with the recent ruling of about 4 walls and the need for either the patient or the provider to be in the mental health clinic has caused a significant disruption in care. And so at a time where we need to be innovating and moving forward, it's difficult. And so we need to have persistence and perseverance and ultimately speak with the right people to get these trials.
I think that leads into my next question, and this question's for both of you. So we're talking about innovation and moving forward as a future, but one of the things that is sort of hindering us from moving forward is that recovery is not a top priority. We've heard about it today from a lot of individuals in this room, but when we look at sort of what's happening at the state level and some other policy, recovery is not that top priority. So how do we continue to innovate and move forward when recovery is not something that is at the forefront of the work that we're doing?
I think one of the most important things is education, and I feel that, in every single field of mental health and physical health, having more of an incentive to educate the consumers about what exactly it is that we're doing and why we're doing it, and asking them about what their actual goals are, because what our treatment goals are might not necessarily match up with the patient's goals.
Dr. Norris?
Right. I think yeah, I think that's a great point. There's a lot of people to educate, right? We need to start with our patients and their families, and then we need to move to our communities, and then we need to move to our representatives, both the state and federal, who ultimately help control the funding that would allow us to do more of the recovery work that we have to do. And so we have to continue to advocate, and we have to continue to come together and look for small wins. And then hopefully, taking a step back, we've come a very long way in the last 20 years when we think about stigma. Stigma still exists. It's far less, and people are far more willing to speak about the struggles that they have. And as we have more people speaking about the struggles, other people come forward and say, me too. And so we will get there. We just have to continue to advocate.
I agree. And this is kind of switching gears a little, but not really. It's still staying within the same realm. We talked a lot about patient and patient care, but one of the other largest challenges that we're seeing is sort of the workforce shortages. And so in my job, I have been focused on sort of early career and the student population, and sort of looking at how we can support and bring resources to them so that they can be successful in their career moving into the workforce. And so my question to both of you is, what do you think is some of the biggest barriers when it comes to the current mental health system and the workforce entering into the system?
Well, of course, there's a lot of turnover, there's a lot of burnout, and one of the things that the collaborative care model specifically addresses is that there is a higher rate of not only patient satisfaction, but provider satisfaction, because you feel like you're actually making a difference. People are getting better faster, and they have a more comfortable setting to access their health care, and they're able to meet with that behavioral health care manager in between their doctor's visits. So instead of seeing their psychiatrist 4 times a year and their PCP every 6 months, they're in contact with somebody who's keeping track of their mental health care in conjunction with their physical health care on a regular basis. And that might lead to some diminishing of burnout and higher retention rates in both settings.
Thank you. Dr. Norris?
Sure. One thing I would add is it really takes a lot of communication in the collaborative care model, because the primary care practice is actually recognizing the revenue for the work that's being done by the behavioral health care manager and that support of their team. And so it does definitely requires a team-based approach. But going back to that beginning, or that opening early mental health provider and clinician, ensuring that they have adequate mentoring and support, especially in the beginning, I think is very important for success. And that takes time / money, right? And you have to be very proactive about creating that time for both supervision as well as oversight to ensure that that everyone's onboarding well. A longer term trick that we have employed is we have a number of feeder programs that include feeder programs from social work schools, from PA schools, from CRNP schools, where we allow and bring people in the social work world to do their internships under supervision of other social workers who are already working here. And all of these programs also feed that that workforce recruitment strategy, because people get exposure to your programs, they understand how they could fit in to your system, and we've been very successful. Now that all of that takes time to lay out those steps, but again, that's another thing that we should be looking at our programs, because schools are always looking to place more interns in different clinical settings.
And Dr. Norris, I appreciate you bringing up mentorship and sort of the and also talking about internships and how your agency is providing an opportunity for early career and students to get introduced to the field. I think that also contributes to burnout. One of the things, I just held a student focus group, and we were talking about this exact thing of, what are you looking forward to when you get into the behavioral health? And some of them said, I'm not looking forward to anything. And so we talked about that. And a lot of their fears are around not understanding what is it really going to look like when I enter as a worker? Because when you're a student, you have the university to rely back on. You can go to them for supports. But when you're a worker, you don't always necessarily have that support by your agency. One of the biggest things that I've seen in the difference between those entering the workforce 30 years and someone like myself, a millennial, entering in the workforce, was that there wasn't many supports. And so we're sort of on this path of figuring things out and sort of just being like, oh, this looks like a great opportunity, let me take advantage of it, but not really knowing how that's going to develop my skills and not really understanding how that's going to make me a better worker. I'm fortunate enough to have Val as my boss, and so she sort of has been my boss / mentor for the past 5 years, but not everyone sort of has that opportunity or that privilege. So looking at some of these, I like to call them tangibles, but some people call them intangibles when we talk about mentorship. But that's very important when we're looking at the workforce moving ahead. So that kind of leads me into my next question, which is, what are some of the lessons learned that each of you have been doing in your work that you would love to offer up to the audience now?
So I'm an early career psychiatrist, so I still have plenty to learn. The biggest lesson that I've learned is to always take the opportunity to continue to learn. And I take even participating in this conference and being a part of this panel as an opportunity to kind of learn and get myself immersed in the work that's involved in, making this system work for our clients.
Thank you. Dr. Norris?
Sure. And so I think in our field, one of the things that we bring to it is patience, because the course of treatment of illness and recovery for so many of our patients is not that of a surgeon where it's a quick procedure. It takes weeks and months. And so in our field, we have a lot of patience. I think that's very important also when we think about what are we trying to do, and how are we trying to, let's say, bend the free market around mental health care, right? And so there are many different steps to that. One is the realization of just how informing people, which is one step, but also lobbying and all these other steps to actually get to change take a very long time. And so having patience and understanding that not everything's going to happen in as quick as it should has been very useful for me over time. But you don't forget the fight. It just, you put it in perspective. A great perspective, which I learned recently. Ghana has 33 million people. They have 14 psychiatrists and 28 psychiatric residents. So their ratio is 1 psychiatrist to 1 million people. So as tough as it is in Pennsylvania, we're still better than other places. And so keeping that perspective in place as we move forward is also important.
Thank you for that. And I think something important that you mentioned was the patience. We didn't get into this issue overnight, so it's not going to take us overnight to fix it. Although I think that's sort of where our state government is at. They want these quick solutions. I like to call them Band-Aids because that's exactly what they are. They're Band-Aids on a blood wound or a bullet wound. So I have one last question, and then we will open up for questions. And this is more of just like, what advice would you give? So, Dr. Dixon, what advice would you give to another early career future leader coming into this workforce? And then Dr. Norris, what advice would you give to emerging leaders that are also coming into this field?
So I think always consider yourself as a member of the team. It's not necessarily a hierarchy with, you being in charge as the provider or the clinician, but you're trying to work together with your supporting staff, with your care managers, and most importantly, with the patient and the family to get them to where they're trying to go. And I think that being in this fellowship has taught me so much about team-based care and, following the lead of people who have more experience than you, and particularly the clients have the most experience with their own personal lives. So listen to them.
Awesome. Dr. Norris?
Sure. First of all, I would echo that the care of behavioral health is a team-based sport, and it requires both, internally different layers and different levels of professionals all working together, as well as when you move into the community working together. And so the first part I would say is learn to listen to your team and learn to empower your team to hear their voice, because often they have other information or other sites that you might not be aware of, and working together, you get a better solution. And the other thing, outside of suicide, don't be afraid to fail, when pilot different programs and see if they work, because again, we all know that our current system is highly challenged and is not going to give us what we want for all of our patients. So we have to think outside of the box. And the only way we can do that is by trying different efforts and seeing what work and seeing what does not work. And so being afraid of failure is something that, as you move in your career, you really need to step away from to try new things. So those would be my 2 points.
Thank you. First, before we get into questions from my audience, I just want to thank you, Dr. Dixon and Dr. Norris, for being on this panel today. Yep, we can give a round of applause. All right. Do we have any questions from the audience?
Okay, so this comes from David Kolko online. He said, are there any examples in PA where collaborative care model codes are being used and the service is being reimbursed well?
So I honestly do not have all of that information. There are some that are kind of in infancy right now. The project that I was getting on board with was having some challenges with keeping track of the data because the psychiatrist was the one keeping track of the registry, which got to be a bit overwhelming for her. So as far as outcomes, they weren't even sure if it was successful. So that's what the continuing research is focused around. But honestly, I've only just started to touch the surface of this. But I'm sure that there's lots of examples in other cases. I'll point you again to the University of Washington's website. They do have a huge amount of resources, including those papers showing that those collaborative care codes in use and are getting people care, and the people who are providing that care are satisfied with what they're doing. And I would assume that the reimbursement and pay is included in that satisfaction.
Any other questions?
And I will speak for UPMC. I will say I'll speak for UPMC. I'm 90% sure that parts of UPMC have already rolled out collaborative care because I know my team has been talking to them about some of their issues.
We have a question.
I just wanted to add one more response to that last piece. And so, yes, Dr. Schlesinger down at UPMC in Pittsburgh, there's a number of things that are rolled out. It does require that coordination because the codes really are for the primary care group to secure. And so it's a partnership where your consultant then is rolled in a different way in a contract. And so it is a mutual, how does everybody understand how to work it?
You have a question?
Yes. Hi, everybody. So I'm a resident psychiatrist, and I have an international American background. And I say this because I wanted to visit a little bit of the integrative community therapy, which I heard a lot about from Dr. Ken Thompson years ago, who's very innovative and progressive in sharing knowledge about that. So thank you, Dr. Norris, for bringing that up. And I was curious because coming from a culture like Brazil in a way where from the Caribbean, there's a lot of innate, intrinsic bonding and like a cultural workaround that allows that to happen almost naturally within the community. And I'm saying that because when you think about the American culture, at times it can be a lot of an individualistic, a very maybe self-centered attitude, and not wanting to be dependent on others, which can be a theme that tends to happen in when you compare international and American cultures. So I was curious with what strategies are in place to get local American communities to focus on the integrative mindset, and what challenges do you see in doing so? I've met a lot of American communities who do have a very warm, group set-in, but I was just curious in terms of implementing that as you are trying to lay out this train in the Lehigh Valley. I was curious and wondering. Thank you.
Certainly, and Dr. Thompson is in the audience, and I had the serendipity to run into Dr. Thompson, and I'm working with his group in this rollout, and so I will let him speak a little bit more to the details of ICT, but to roll it out operationally, you need strong community-based organizations, and fortunately, where we are, we have a number of strong based organizations, actually, as well as government agency, actually have members from both local counties, mental health team that are engaging in ICT training as well. And so in our area, it seemed perfect for a rollout and pilot of it. I'll hand it to Dr. Thompson.
Thanks, Ed, and thanks, Val, for giving the microphone. I guess people should know this was not arranged as a shout out to me in any kind of way. This is Ed. This is Ed and the work that they've been doing in Lehigh Valley. But there is a PPLC connection that I should mention, and that is the reason that ICT is being rolled out in part in Lehigh Valley is there is a guy by the name of Ed Meehan. There are the two Eds in Lehigh, Ed Norris and Ed Meehan. Ed Meehan works and continues to work for something called the Pool Institute. And David Dinich, more than a decade ago, took me to visit with Ed and a guy named Ron, whose last name has just got my head. What is it? Ron Dennis. To meet, because we were trying at that point, to think about extending the Centers of Excellence program into the Lehigh Valley, which we were not successful at doing at that exact moment. But Ed Meehan remembered those conversations, and when he heard about ICT, he looked into it, and we remade the connection. So that particular link is a direct result of the work of the PPLC, and the fact that you're taking this innovation step is related to Dave Dinich and Ed haven't had a relationship. And the reason I mention that is you don't know what you're planting when you make a connection with people and what's possible in the future. And it is quite astonishing that stuff can continue to happen and bear fruit. And to be truthfully honest, what's going on in the Lehigh Valley, from my perspective, is an extraordinary experiment in exactly addressing the challenge that you asked. What can we do in our culture to become a little less individualistic in all the work that we do, but allow people to be themselves in the context of connection? And that is that's the experiment that we're engaged in. I think Ed is absolutely right. It is totally based in the United States, especially on having strong linkages that come through organizations that are in community already and through people who are peers and connected into those communities already. We don't expect that it will always be easy. Americans, the best example I can give of this, and it's a sort of a metaphor, is that in Brazil, in the transitions during it's an hour and a half long process to do a session of ICT. There are 5 transitions in that. During the transitions in Brazil, they play a little music. And as soon as they put the music on in Brazil, everybody stands up and dances, because that's what you do when you hear music. It's like to get open, and that's how they make the transition. I have to beg people to just move their hands a little bit in beat with the music in an American audience. Nobody will stand up. Now, I don't want to overstate this. There are some communities and some cultures in the United States where this is not true. So we have the benefit of being very broad in the different kinds of communities that we have. But for the average American community, this is not a straightforward thing. And the process of sharing their challenges with each other to find solutions together is something that we are hoping becomes something of value to them and helps us do a better job of making resources available to people faster and sooner, along the lines that you guys are talking about. So thanks for the shout out, Ed, on this and the work that you guys are doing. And I would say the extraordinary effort to do something innovative is just really, really profound. Lastly, I want one more thing to say about collaborative care, and that is, I think it's an extraordinarily important innovation, but I also think that there are situations where the populations have such great psychiatric medical needs that collaborative care is not sufficient. And what we've moved to is what we call fused care. And that is a distinct team-based approach in which psychiatric and primary medical care are absolutely completely fused at the core of a person's care. So whole person primary health services that are really extensive and not just co-located, co-situated in the challenge of a particular family and community and person.
I have a question. Can I ask you? This is Dr. Martinez, and I want to say extraordinary question from the lady from the international background, and wonderful replies. And Ken, I think it's absolutely terrific, your analogy about the dance. It's so true, because the other day I was just simply playing a drum from a powwow, and in the Native American culture, that's acceptable. But don't you dare do it anywhere else, without getting permission. And I think it's incredibly effective for turning around those negative adverse events into positive ones. And I have introduced it in an approach for dealing with trauma and recovery. My question to you all is, in the advent of many, many, many different people now that have arrived to this country, what steps or strategies with the integrative mindset do you have in terms of becoming or even attempting to bridge that divide of linguistic proficiency and cultural? In medical school, they always taught us to do one, see one, and teach one. And I think that same approach should be done with our providers and paraprofessionals and professionals. But what steps are you taking for that? And National Latino Behavioral Health Association can be a very big resource. They're out of Albuquerque, New Mexico.
I could address this question. So very great question. And I think sort of, even though my expertise is, workforce development, me being a Black woman and sort of influences the work that I do. And so the program that I currently run, Well-Oiled Machine, has been doing amazing work. But one of the things that I seen that it was lacking was sort of that involvement from other organizations when we talk about access. So looking at sort of the Association of Black Social Workers, looking at, I had teamed up with this one agency called like Mango Tree, which was focused on South Asian population. And so I think that is a starting point, is really looking at sort of who is missing and how we're actually bringing them to the table and being part of the conversation. Because there's one thing for us to say that, oh, we're creating access by creating this program or putting this out there, but there's another thing to actually reach out and bring that individual or that population to the work that you're doing. And so that's sort of one of the first steps that I have taken. And then the other thing is actually creating subgroups to address these. So this is the work that I do with NASW. One of the things that I realize is that social work is large, social justice is also a large topic, and we weren't sort of narrowly focused on what does that mean and the work that we're doing. And so I created 3 subgroups. One was a committee on racial equity, the other one was LGBTQIA, and then the last one was disability inclusion. And that last one, disability inclusion, was something that was needed for so long because we talk about mental health, behavioral health, but we don't really always talk about how someone with a physical disability may be impacted by the work that they are not only providing, but also those with a physical disability as well. So that's sort of one of the first steps that I have been taking.
Well, you specifically mentioned language barriers, and
Oh,
admittedly,
excellent.
I feel that there is a lot that needs to be done to improve access to translators and having our providers perhaps, learn another language. And I know that's much easier said than done. And I think that is seriously an area that is lacking. Now, as far as the cultural component, I believe that integrated care does have the potential to bring more people in of culturally diverse backgrounds, because in certain ethnic and national backgrounds, mental health is not thought of in the same way as it is in this country. And people are much more likely to have a relationship with their primary care providers than they are to seek out mental health services through a psychiatrist or a psychologist.
Ed, do you have a comment?
And I think these are all great points made. Yes, I think these are all great points already made by the panelists. I think that you need to be very intentional about this. For example, not only does the network have a DEI committee, but we in the Department of Psychiatry have a separate DEI committee, as well as one with our residents. They're all separate groups, ensuring that attention and focus is placed in areas where we can always improve and get better education around different cultures as different cultures enter our community. I think the idea of sending somebody to linguist school is fantastic, and we just have to figure out now how we can create that grant program as well. Because I see in the chat room that there's a member in the audience who notes that for any billable staff, they actually send them, or they pay for 3 months of language immersion school, which is fantastic. I'd love to know how they do that.
Is that Gail? Okay, yeah.
That
I was gonna
is.
say I was gonna put in a recommendation to reach out to Gail from the FQHC in Philadelphia, Esperanza. They do a immersion program. So if anyone would like to learn more about how they're doing that, Gail, I'm sorry, but I'm gonna have them reach out to you.
No problem. It's actually not that expensive, surprisingly.
All right. As this panel, as many other panels, we could probably continue this conversation for another hour, but we need to wrap this up. So again, I would like to give a round of applause for our panelists, Dr. Dixon and Dr. Norris. And now I'm going to hand it over to Ken. You're closing us out.
Well, Val's going.
Well, come on, we're going.
All right.
Unless you want to have the last word.
Well, I couldn't rob you of that, Ken. So I don't know that I introduced myself earlier. I'm Valerie Ferry. I'm the director of FTAC and PPLC. And I just wanted to take a minute to thank everybody for attending today. I know some of you traveled quite far, so I really appreciate it as always. I also want to thank all the folks who joined us online and taking some time out of your day to hear these wonderful speakers. And I really think today was packed with wonderful speakers, and that was because of the work of many of the people in this room. So I certainly wanted to acknowledge the Conference Planning Committee, including the PPLC and the COE directors. We can't do it without you guys, so thank you so much. And I especially wanted to thank Deb Shoemaker, Lucianne Green, and Katie back there, who is running our chat today. Logistically, you guys made this a breeze. Thank you very, very much for that. I did want to take a second to acknowledge somebody who we lost last week, who was a member of the PPLC and had worked quite extensively on a few of our projects, including our Racial Justice Collaborative and our Spirituality Committee. Reverend Thelma Mitchell passed away very suddenly, and she's being laid to rest today. And unfortunately, we couldn't be there to say goodbye to her, but she was an amazing person, and we will miss her. So if you knew Thelma, you knew how wonderful she was, and what a wonderful and inspirational person that she was to work with. She did many incredible things across her life. So if you had not received her obituary, I highly recommend reaching out to Lucy. She can get it to you. She really did incredible things, and I feel quite humbled and honored that she spent last of her working with us on some things. So Thelma will be missed. Okay, I did also want to just give you a few announcements. So if you need CE or CME, as we've said throughout the presentations today, please reach out to Lucianne Green at lgreen, like the color, at pmhcc.org. It should be up on the slide during intermission, so I hope you jotted that down. So please reach out to her, and she will give you instructions on how to receive those credits. I also wanted to remind you of a few things that we have going on with the PPLC, including our Racial Justice Initiative. We meet on Monday nights. Dr. Marianne Oliba and Dr. Rachel Talley and Crystal all provide great leadership to that group. So please join us if you want to talk a little bit more about how to diversify psychiatry within the state of Pennsylvania. We also have our general PPLC meetings every second and fourth Thursday. Those are online, as well as our previous meeting. So you're welcome to come and join us. We talk about a lot of different things. Sometimes they are topical based, and sometimes they're current events based. It kind of depends on what's going on. So you're more than welcome. You don't have to be a psychiatrist to join us in those meetings. They're at 6 p.m. So the racial justice meeting is at 6 p.m., as is the second and fourth Thursday. And Lucy is your main woman for all of these contacts. And then I also wanted to point out that several of the COE directors have collaborated to put together an early career clinical support session, which happens every third Friday. You know, I think we talked a lot about workforce support today and mentorship. This is a great way to get that started. I know everybody has busy schedules, but if you have a little time at noon every third Thursday, it's a great group. It's a place for you to be with your peers. This is a psychiatry and psychiatric practicing, so it's open to our nurse practitioner friends who are working in a psychiatric space as well. This is a great opportunity to get with some of your peers and talk out some cases and about life. We have a fall meeting coming up. I do not know what the date of that will be, but please look out for that. And of course, we'll be having our PPLC conference again next year in the springtime.
The fair.
Oh, thank you. Thank you. If you're working with a third year medical student who identifies as Black, we're actually having a residency fair. You're welcome to join us, or if you know somebody who would be looking to learn more about the residency programs within the state of Pennsylvania, all of the residency program directors will be there and talking about their programs. It's a great opportunity for med students to learn a little bit more. And I believe we'll have some of our students, or I'm sorry, our residents from the Black Resident Roundtable who will be there as well to have a separate session just to talk a little bit about that group, which Sierra facilitates, that they meet quarterly. So that's an opportunity. So please send that out, and you can also get that information from Lucy. And those are my announcements.
So I'm going to be very quick before we all go off. First, I want to thank all of you for coming and for supporting the work of the PPLC and being the PPLC. This has been I think, an extraordinary conference. And I think you've heard from speakers that the state of Pennsylvania really demonstrates some extraordinary talent. I believe that it is possible for us in this state to really go very far ahead in the work that we're doing, if we can just figure out how to keep the pressure up and keep the ideas flowing and keep ourselves unstuck enough to pursue this. So that work is something It doesn't take a lot of us. It just takes persistence. And I think it takes just having us the best ideas that we can possibly imagine to put forward. So I thank you all for that. In support of that, I hope that you will communicate with us if you have any thoughts about the conference, you know, what's been said, what needed to be said that wasn't, or things that you want to add or subtract from the processes that you've been part of today. Please let us know. We don't have an actual sort of survey about the, do we have a survey at the back of our thing? We don't.
No, but we could get searched.
So I mean, at some point, we do want feedback. So that's what I'm asking for. If you've got feedback, please send it along. I think, lastly, I want to just echo all the thanks that Val said. But I want to actually thank Val and Lloyd, who have been shepherding us through this period of time in an extraordinary way. And we would not be here. They had big footsteps to fill with David. And as you saw with Estelle's original contribution, but we've been able to carry it on. And I think that this is an extraordinary thing. I don't know of any state in the union that has this kind of capacity to gather all the different kinds of viewpoints about how we do good community mental health and psychiatry, public service. I don't think there is any place like this in the United States or a group like this. So I'm very thankful for that. And lastly, I guess what I would like to say is be careful out there and drive safely. Thank you very much. That's for the good of the order.
Wonderful job.